ده الحقيقه النادر. Should I stop here? Continue. Okay. So ده النادر، ده تشك فيه امتى؟ لما تلاقي abnormal lead impedance either low pointing to insulation break or high pointing to an open circuit. انما المور common reason for apparent no capture تلاقي معاه normal lead impedance، ولازم ساعتها تدور على الايفنت ماركر. لو ما لقيتش حاجه في الايفنت ماركر يبقى ده غالبا سودو مالفانكشن زي الهيستريسيس اللي احنا وريناه. لو لقيت resetting by a sensed event ده معناه ده قد يكون inappropriate نتيجه اوفر سنسنج اللي احنا ورينا منه اكزامبل، والاوفر سنسنج ده ممكن يكون فيسيولوجيك ايفنتس زي البكتورال ماسل كونتراكشن، او يكون نتيجه الكترومagnetic انترفيرنس. وقد يكون appropriate sensing، يعني العيان جاله بي في سي فالجهاز سكت، بس البي في سي دي انت مش شايفها على الهولتر تريسنج، وده كومن قوي في الهولترز اللي بتسجل سنجل ليد. طبعا ده very unlikely when you have a 12 lead electrocardiogram. او ممكن يكون apparent loss of capture، يعني هو مش failure to output، هو failure to capture، بس انت مش شايف البيسنج سبايك because it's very small، لان frequently البايبولار pacing does not show on the surface ECG. So ده كان الفيلير to output. What about what about this example? What do we see here? So this is a P wave, and this is atrial pacing followed by a P wave, and this is a P wave, atrial pacing followed by a P wave. So what's happening here is that there is intermittent atrial undersensing. So this beat is not sensed, and thus the device paces and it captures the atrium. So this is an example of atrial undersensing. What about this example? So this example, this is the patient who has this AV delay programmed in a dual chamber pacemaker. What's important here is that the ventricular channel is not sensing. So there is an intrinsic QRS complex here, and the device paces here. It is pacing, but it is under sensing. So this is an example of ventricular channel under sensing. So these are the failure to sense causes. Failure to sense could be because of true under sensing. And you need to figure out what's the relation to implantation. Is it close to implantation? So this is probably micro dislodgement or perforation, or is it remote? And the remote reasons could be patient related, like if the patient has an ectopic beats whose amplitude is very small and thus not sensed by the device, or is it pacemaker related factors? So there is a problem with this lead or a problem with the battery. The most common reason of course is the stuck reed switch. الريد switch ده عبارة عن two metal bars موجودين في سيركت جوه الديفايس. المفروض لما نحط عليهم لما نحط على الديفايس ماجنت، الديفايس يتحول من سensing ماشين لنون سensing ماشين، ما بيحسش اي حاجه. ده بيبقى نتيجه ان التو ميتال بارز دول بيمسكوا في بعض فبيقفلوا سيركت السنسنج. احيانا الريد سويتش ده يبقى ستيكي ما بيفكش بسهوله، فده one of the reasons of under sensing. يلزقوا في بعض التو ميتالز دول فيحولوا الجهاز لنون سensing ماشين وما يفكوش تاني فيرجع الجهاز يحس. او قد يكون الفيلير تو سنس ده نتيجه سودو مالفانكشن، يعني ارتيفاكتس مثلا commonly في الهولتر او في المونيتور الالكتريك مونيتور بنشوف what looks like spacing spikes توحيلك ان ده قد يكون under sensing، بس هو مش كده، ده هو بس الديفايس is annotating some rapid signals as being pacing spikes while they are not. او ان يكون في programming issues زي مثلا تكون programming long refractory periods، او انت تكون الار ويف بتاعت المريض ده 3 وانت مثلا programming sensing threshold على 5 أو 6، فتلقائي وطبيعي ان الجهاز ما يشوفش. So these are the last examples that I would like to show. This is pacing spikes followed by pacing in the ventricle, and this is a QRS complex, and this is a pacing spike with failure to capture. So this is what we call apparent failure to capture. In this particular case, this apparent failure to capture is due to under sensing. So the device is not sensing the R wave, and it paces in the ventricular effective refractory period, and thus it's not capturing. This is another nice example of a 78-year-old gentleman presenting with syncope following the implantation of a pacemaker. ايه رأي حضراتكم في الفانكشن البيسنج فانكشن بتاعت الفنتريكولار ليد؟
Ahmed, 2 more minutes, please.
2 minutes, okay, sure. So this is the pacing spike and no capture. This is the pacing spike and no capture. So this is clear failure to capture of the ventricular lead. Is the ventricular, the question is, why is the ventricular lead pacing at such slow intervals? لا ما هو ده اسكيب ريزم بس الجهاز بيبيس على هارت ريت 20 يمكن 30. اكيد مفيش حد هيبروجرام الديفايس على البيسنج ريت ده، صح؟ الفكره ايه بقى؟ الفكره ان this device despite being malcapturing it's actually sensing. So it's sensing the QRS complex this and it resets the lower rate interval for it paces here. And then it senses this, it resets the lower rate interval and it paces here. Okay? So these are the causes of failure to capture. I'm not going to go through it because of the time, and I'm just going to show you this last tracing. This is a 64-year-old gentleman presented with shortness of breath and infected pacemaker pocket following implantation. ال ECG ده حقيقة interesting. I want to go through it يعني really quickly. لو حضراتكم ركزتوا في الريذم ستريب بس، الريذم ستريب هتلاقوا 3 populations of QRSs. أول population اللي هي ليها short AV delay دي زي أول 3 بيتس، وبعدين تاني population فيها single ventricular pacing spike وراه ventricular capture زي البيت دي وزي البيت دي مثلا، وآخر population هم زي البيتس دي اللي هي فيها 2 pacing spikes at the seemingly normal AV delay. فإيه اللي بيحصل؟ الاتريال ليد في العيان ده كان hovering across the tricuspid annulus. فأحيانا بيعمل إيه؟ أحيانا يخش الفنتكل. لما بيخش الفنتكل بيكابشر الكيو ار اس كومبلكس بتاعت العيان. فطبعا يبقى في سنسد ايفنت في الكروس توك انترفال، فيقوم الديفايس يبيس بشورت اي في ديلي فنتريكولار سيفتي بيسنج، وبعدين يروح الاتريوم فيعمل نورمال ديفايس فانكشن بي ويف بيكينج التي هنا. انتوا مش شايفين. اوكي ما هو ما فيش غير ده اصلا. فهو ده البيسنج ويز شورت اي في ديلي اللي احنا قلنا عليه، وبعدين البيت دي بي ويف وراها كيو ار اس كومبلكس. ده نورمال، ده البيت الوحيده اللي فيها نورمال ديفايس فانكشن سنسد اتريال ايفنت بيست فنتريكولار ايفنت. كويس. وبعدين هنا بيبقى على الترايكاسبيد انيولس، وهو على الترايكاسبيد انيولس مش بيحس الاتريوم، يعني في بي ويف اهي محسوسه مش محسوسه، وبالتالي بيبيس وتلقائي ان هو مش بيكابتشر الاتريوم، بس في البيتس دي كمان مش بيكابشر الفنتركل. فدول الثلاث مناظر اللي حصلوا لما كان الاتريال ليد بيهفر على الترايكاسبيد انيولس زي ما حضراتكم شايفين كده. And that's it. Thank you so much.
Thank you. Thank you Ahmed for this stimulating talk. اتفضل معانا. بعد كده في كيس برزنتيشن دكتور حاتم عبد الجواد. اتفضل. لا لا
صباح الخير على حضراتكم، كل سنه وحضراتكم طيبين. شكرا دكتور مجدي على دعوه حضرتك. هقدم لحضراتكم النهارده ان شاء الله كيس كنا عملناها في الديبارتمنت عندنا، ويعني حاولنا نشوف لها عنوان كويس كده، و interrogation solves the mystery. So this is a 52-year-old lady. She has a history of rheumatic heart disease for which she did a mechanical mitral valve replacement in 2010. She had a completely eventless history until in April 2021. She presented to our department with fever, breathlessness, and palpitations. On clinical examination, the most important findings were that she had prominent peripheral signs of aortic regurgitation, like Corrigan signs and collapsing pulse. Her ECG showed sinus tachycardia with first-degree heart block. Her labs showed normocytic normochromic anemia, and her inflammatory markers were markedly elevated with shift to the left. And her blood culture and sensitivity of 3 bottles showed Enterococcus faecalis. هو كان قبل الايفنت ده البيشنت كان جالها وورفرين توكسيسيتي وراحت مستشفى بره عملت upper GI endoscopy. Most important findings في الايمجينج بتاعها ان هو الترانستوراسيك والترانساسوفيجيال echocardiography showed that she had mitral prosthetic valve infective endocarditis and also native aortic valve infective endocarditis with aortic root abscess that led to severe aortic regurgitation. The course of infective endocarditis guideline-directed antibiotics were started as per guidelines over 6 weeks. This led to a relative clinical improvement. The patient was then referred to the cardiothoracic department, and she did a redo to her mitral valve replacement and a mechanical aortic valve replacement. On day 3 post-operatively, she developed a Mobitz type 2 second-degree heart block, and this progressed over the days into complete heart block. So a jugular temporary pacemaker was inserted, and all through her hospital course, she was completely pacemaker dependent. So on day 16 post-operatively, a permanent dual chamber pacemaker was implanted, and the patient was successfully discharged. Guidelines state that we should wait at least 5 days post-cardiac surgery inflicted heart block before implanting a pacemaker. We waited 16 days, so it's a quite reasonable time. This was the ECG that upon which the DDD was implanted, and it shows clear signs of a complete AV dissociation. After that, بعد حوالي 5 أسابيع البيشنت كلمتنا ان هي راحت اتحجزت في مستشفى بره وجالها sudden onset of tachycardia وخدت DC shock وبعتوا لنا الاي سي جي ده. As we can see from this ECG, it's a wide complex tachycardia that is regular and very rapid. The differential diagnosis of wide complex tachycardia, as all of us might know, is that first of all, we bear in mind that this patient has a permanent pacemaker. So paced rhythm would be one of the differential diagnoses of wide complex tachycardia. However, what's against pacemaker-mediated tachycardia in this patient is that the rate is very rapid. And pacemaker-mediated tachycardia usually occurs at the upper track, زي ما دكتور أحمد قال في المحاضرة اللي فاتت, at the upper tracking rate of the device, which is usually set at around 130 beats per minute. As we can see, this tachycardia is much faster than 130 beats per minute, so pacemaker-mediated tachycardia would be a very remote possibility. Second would be an artifact, and this doesn't look like an artifact. The 3 other differential diagnoses of wide complex tachycardia would be the SVT with aberrancy, the SVT with an accessory pathway, and the ventricular tachycardia. الابروتش بعد كده بيبقى ان احنا بنحاول نشوف البروجادا الجوريثم اور سمبلر ابروتش للبروجادا الجوريثم ده زي ما كان يعني بنتعلم مع دكتور احمد ان احنا اول حاجه بنشوف احنا خلاص اكسكلودد ان ده بيست ريثم واكسكلودد ان ده ارتيفاكت بنحاول نشوف بعد كده هل في اي clear signs of AV dissociation in this ECG. I cannot see that there are any evident signs of complete or signs of any AV dissociation in this ECG. There's no capture or fusion beats, no P waves that are clearly visible عشان نقدر نحكم عليه. الحاجتين التانيين اللي هيبقوا موجودين هم ان يبقى في SVT with aberrancy او SVT mediated through an accessory pathway. فالحاجه بعد كده اللي بنبص عليها هو المورفولوجي. هل ده يعني يبان منه ان ده an ECG with typical left bundle or typical right bundle branch block pattern؟ الحقيقه ان ده شكله انه في typical left bundle branch block pattern زي ما باين في البريكورديال ليدز ومن ليد 1 و AVL. فاور top probability or possibility في البيشنت دي هو ان ده يبقى SVT with an aberrant conduction, an underlying left bundle branch block. فده الديفرنشال diagnosis زي ما قلنا، وقلنا ازاي حاولنا نفكر في الاكسكلوجن وترجيح حاجه عن الحاجه الثانيه. We scheduled an early visit for the patient at our EP clinic وعملنا interrogation للديفايس. دي الانترفيس بتاع البروجرامر in this patient it's a St. Jude device. لو حضراتكم شايفين الشانل اللي فوق دي الاتريال شانل، والشانل اللي تحت دي الفنتريكولار شانل، ودي الماركرز اللي الديفايس بيانوتيت عليها السيجنالز اللي هو شايفها دي. فزي ما احنا شايفين فوق الشارب سيجنالز دي هي الاتريال سيجنال، الريلاتيفلي وايد سيجنال على الاتريال شانل دي فار فيلد من الفنتريكل، والشارب سيجنالز على الفنتريكولار شانل دي الفي سيجنال. تحت الديفايس اري ASVS. AS stands for atrial sensing and VS stands for ventricular sensing. So to our surprise is that this patient is currently not in AV block and she has a this is completely her intrinsic rhythm. So now we know that this patient can have an SVT which can be tracked to the ventricle because she regained her AV conduction. The next question would be which type of SVT? The broad differential diagnosis of SVT includes AVNRT, atrial tachycardia, and AVRT. So now we know that it's an SVT. The next question would be which type of SVT. الديفايس لما بيبقى فيه اي ايفنت بتحصل خارج المألوف بيسجل ده، ودي بتبقى easily retrieved من الداتا بتاعت الديفايس. زي ما احنا شايفين دي التاكيكارديا بتاعت اللي جت للبيشنت وهو الديفايس مسجلها. فوق دي زي ما قلنا الاتريال شانل، وتحت الفنتريكولار شانل، وزي ما احنا قادرين شايفين في it's a tachycardia with one-to-one conduction, so each atrial signal is associated with a ventricular signal, and the atrial events and ventricular events are almost simultaneous. In the EP language, this translates that the tachycardia has a very short VA time. طيب هل ده يفيدنا في حاجة؟ الحقيقة ده المنظر ده يخلي ال AVNRT is a top possibility. However الأهم من ده إن هو يقدر exclude حاجة زي ال AVRT. وليه يقدر exclude حاجة زي ال AVRT؟ لأن ال AVRT is a macro reentratic circuit with the antegrade limb being the AV node and the retrograde limb being the accessory pathway. So this means that the atrium and the ventricle are integral parts of the circuit. واي اسرع accessory pathway الكوندكشن بتاعه at least بياخد 70 ملي سكند. فعلشان التاكيكارديا دي تبقى AVRT orthodromic يعني و underlying left bundle branch block pattern وراجعه على accessory pathway، مستحيل او صعب جدا يبقى منظر ال VA time very short زي ده. فاحنا كده استبعدنا ال AVRT وعندنا احتماليه كبيره ان ده يبقى AVNRT. الديفايس سجل المومنت اوف انيشيشن بتاعه التاكيكارديا. هو ما اعرفش هو ليه جاي كده. اوكي دي المومنت اوف انيشيشن اوف ذا تاكيكارديا، والبيت اللي متعلم عليها دي actually it's a PAC a premature atrial contraction. ولو حضراتكم شايفين الجزء الاولاني من التريسنج ده هو او البيسنج بتاع البيشنت atrial sensing ventricular pacing, so it's a the tracking mode of the device. وهنا اللي حصل ان جت premature atrial contraction ونزلت ب slightly longer PR او AV time. لو حضراتكم شايفين ال AV time هنا visually اقصر من ال AV time هنا، فده بيدينوت ان البيشنت ممكن يكون عندها what is known as the dual AV nodal pathology, which is the presence of both a slow and a fast pathway through the AV nodal tissue. فالبي اي سي دي اللي جت البريماتور اتريال بيت دي نزلت على السلو باثواي زي ما باين بان هو slightly longer AV time وانيشيتد التاكيكارديا. هو ده بالظبط اللي احنا بنحاول نعمله في الاي بي ستادي لما بنحاول نعمل واتس كود ان اكسترا ستيمولس، ان احنا نجيب بيت بدري عن ميعادها بحيث ان هي تبقى بلوكت في باثواي وتنزل على الباثواي الثاني وتانيشيت التاكيكارد. وده الكلاسيكال ديبيكشن بتاع الديوال ايفي نودال باثولوجي with the presence of the slow pathway and the fast pathway. So this PAC نزلت على السلو باثواي ورجعت على الفاست باثواي وعملت perpetuation للتاكيكارديا اللي هي مكمله بعد كده. الحاجه كمان اللي كانت انترستنج في الستورج بتاع الديفايس ان هو سجل المومنت اوف ترمينيشن اوف ذا تاكيكارديا. النص الثاني من التريسنج ده الريجين بتاع الساينس او يعني الريجين بتاع التراكنج مود عادي بتاع الديفايس الدي دي دي مود، وده النص الاولاني التاكيكارديا ان بروجرس. وزي ما احنا شايفين دي اللحظه اللي انتهت فيها التاكيكارديا، وزي ما احنا شايفين هي انتهت باتريال ايفنت. طيب هل ده يفيدني في حاجه؟ هل termination of an SVT with an atrial event ده يفيدني في حاجه؟ يفيدني ان هو نقدر نكسكلود منه الاتريال تاكيكارديا از ذا كوز اوف اس في تي. ليه نقدر نكسكلود الاتريال تاكيكارديا؟ لان علشان الاتريال تاكيكارديا تبقى ترمينيتد، يعني ده يتطلب ان يحصل حاجتين يجتمعوا ويلتقوا في نفس الوقت، هو ان التاكيكارديا تنتهي تبقى ترمينيتد وفي نفس الوقت يحصل اي في بلوك، فالاتريال سيجنال دي ما تبقاش كوندكتد للفنتريكل، واجتماع الحاجتين دول مع بعض صعب. فعلشان كده our top diagnosis now is AVNRT or an SVT with aberrant conduction. رحنا بعد كده على الاي بي لاب والكلاسيك بريباريشن بتاعنا. بندخل 3 شيتس، 3 فيمورال شيتس، 2 6 فرنش وواحد 7 فرنش او اكوردنج يعني للتايب اوف كاثيترز. ده زي ما احنا شايفين ده الاتريال ليد وده الفنتريكولار ليد بتاع الديفايس، ودول التو بروستيسز بتاعتها. الكاثيترز اللاي اوت بتاعتها، الكاثيتر اللي قدامنا دي ده ال اي او فيو، عشان كده شايفين الميترال انيولس قدامنا في وشنا. الار في ليد ده سوري الار في كاثيتر دي كوادري بولار كاثيتر في الار في بوزيشن، ودي الكوروناري ساينس كاثيتر في الكوروناري ساينس تو ريكورد ذا اتريال سيجنال، ودي وات از كولد ذا مابينج اور ابليشن كاثيتر اللي بنحاول نوصل بيها لحد الهيس باندر ريجن، وبعد كده نعمل مابينج ونعمل ابليشن لما نوصل للدايجنوزس. ده كان السيرفيس اي سي جي بتاع البيشنت قبل ما نبدا، وزي ما احنا شايفين هي دلوقتي ده الساينس ريذم بتاعها عادي، اتس ساينس تاكيكارديا with a left bundle branch block. قبل ما بنبدا الستادي بنعمل وات از كولد ميجرمنت اوف ذا انترفلز. اللاي اوت اللي احنا شايفينه قدامنا ده الثلاثه تشانلز اللي فوق دول اللي باللون الابيض دول السيرفيس اي سي جي. سوري يعني قدامي بالظبط ان شاء الله دقيقه.
طيب
ده السيرفيس اي سي جي اللي بالثلاث شانلز، ليد 1 وليد 2 وليد في 1. دول اللي بالاصفر دي المابينج كاثيتر او الكاثيتر اللي هي الابليشن كاثيتر اللي بنحطها عند الهيس ريجن، وده الديكابولار كاثيتر القسطره الكوروناري ساينس، وده الار في تشانل. فالمابينج كاثيتر دي هنلاقي عليها ان في 3 سيجنالز. اول سيجنال دي الاتريال سيجنال، في فيري سمول ديفليكشن دي الهيس سيجنال، والسيجنال الاخرانيه دي الفنتريكولار سيجنال. الانترفلز اللي احنا بنقيسها هي الاي اتش انترفال، ودي بتتقاس على القسطره الابليشن من بدايه الاتريال سيجنال لبدايه الهيس سيجنال. وبعد كده الاتش في انترفال اللي هي بتتقاس من بدايه الهيس سيجنال لبدايه the earliest evidence of ventricular activation اللي هي usually بتبقى السيرفيس اي سي جي. القرايات طلعت معانا كده الاي اتش انترفال 68 والاتش في انترفال 73. النورمال بتاع الاي اتش انترفال هو بيبقى في حدود من 55 تو اراوند 130 ملي سكند، والاتش في انترفال بتبقى من 35 ل 55 ملي سكند.
ثانيه يا دكتور وفاء، قول لنا بس الفاينل.
اوكي خلاص، يعني جبنا التاكيكارديا وبعد كده جزء من التاكيد ان دي اي في ان ار تي بنعمل حاجه اسمها انترينمنت. انترينمنت معناه ان احنا بنوفر درايف التاكيكارديا ونميك شور ذات وي انتريد ان احنا دخلنا جواها وسرعناها، وبنقيس حاجه اسمها البوست بيسنج انترفال اللي هي الانترفال ما بين اللاست انتريند بيت والريتيرنينج بيت بتاعه التاكيكارديا، وبنخصم ده من التاكيكارديا سايكل لينث بيطلع لنا رقم. هو هنا البوست بيسنج انترفال هو ال 629، والتاكيكارديا سايكل لينث اللي هي الجزء الثاني من التريسنج 431. فالرقم ده عالي قوي. الرقم لما نخصم التاكيكارديا سايكل لينث من البي بي اي ويطلع رقم اكتر من 115 ده بيعلي البروبابيلتي بتاع الاي في ان ار تي. اخر حاجه هو ان احنا هقول بس افكر حضراتكم
احنا عندنا لايف كمان 10 دقائق، فعشان ايمانويل بس ما
التراينجل اوف كوخ ده اللي بيبقى السايت بتاعنا او التارجت بتاعنا في الابليشن بتاع السلو باث واي، وهو دي الباوندريز بتاعته السبتال ليفلت بتاع الترايكاسبيد فالف، والتندر اوف تودارو اللي هو الاكستنشن بتاع اليوستيكيان فالف، والبيز بيبقى الكورونري ساينس بتاعنا. الايبكس بتاع التراينجل ده بيبقى الفاست باث واي، وده اللي احنا عايزين نبعد عنه وما نقربش منه وما نعملش افكشن ليه، والبيز بتاع التراينجل ده هو التارجت، هو السلو باث واي، وهو ده اللي احنا بنعمله تارجت عشان نعمل له موديفيكيشن ونعمل نبقى عملنا سلو باث واي موديفيكيشن.
ثانك يو حاتم. ثانك يو. Very well presented case. Thank you, Hattie.
It's my pleasure to introduce Professor Dr. Emmanuel Faris. He will talk about recent updates in sudden cardiac death. Just 5 minutes. 12
صباح الخير. هتكلم النهارده على الابديتس بتاعت السادن كاردياك ديث. based on the 2022 European guidelines for the management of patients with ventricular arrhythmia and prevention of sudden cardiac death. دي الأجندة, the workup of the first VT episode, sudden cardiac death survivor, victims and their relatives. الحاجة الثانية management of VT with structural heart disease, management of electrical storm, primary prevention of sudden cardiac death, and if time allows هتكلم على primary electrical abnormalities. أول حاجة ال workup of first VT episode. أهم حاجة دايما في أي episode بتاع VT أو recovered sudden cardiac arrest إن احنا ناخد a comprehensive history that covers the events very well. ازاي حصل, ايه precipitating factors, associated symptoms, لو في history of cardiac disease, history of coronary artery disease, لو في اي medications بياخدها زي antiarrhythmic medications او medications that can cause prolongation of the QT, the family history of sudden cardiac death او sudden infant death syndrome او repeated spontaneous pregnancy او loss او family history of heart disease او neuromuscular disease. فده أول algorithm في ال guidelines, patients presenting with an incidental finding of non-sustained VT. كان الهدف من الفيجر ديت إن هو ال non-sustained VT in a patient with a normal heart is totally different from a non-sustained VT episode in a patient who has a structural heart disease. فأهم حاجة في ال patient زي دوت إن احنا ندetect the presence of structural heart disease عن طريق 12 lead ECG and echocardiogram, and we can go for a CMR. Why? Because the presence of structural heart disease increases the risk of sudden cardiac death compared to patients who have a normal heart. What about a patient who presented with a first episode of a sustained monomorphic VT? برضه هيبقى أهم step اللي هي ال evaluation of the patient بالhistory taking والexamination. بعد كده a 12 lead ECG during the VT episode and during sinus rhythm, an echocardiogram. The patient can go for a coronary angio if we are suspecting coronary artery disease, and CMR to exclude the presence of structural heart disease that was not apparent in the echocardiogram and the surface ECG. If we are suspecting a myocarditis ممكن نعمل further studying زي ال PET CT أو cardiac biopsy. And in some patients we can go for an EP study and ventricular extrastimulation. فهي ديت ال battery of investigations that we do for a patient presenting with a first episode of sustained monomorphic VT. The same thing applies for patient who survived a sudden cardiac arrest. A 12 lead ECG is the first step after recovery. And if the ECG shows evidence of STEMI, then urgent coronary angiogram is a class 1 indication. If not, the coronary angio can be postponed to a later stage. بعد كده an echocardiogram طبعا is very important to detect the presence of structural heart disease, brain and CT chest to exclude extracardiac causes of cardiac arrest, blood sampling for toxicology and genetic testing, and review repeated ECGs to detect any electrical abnormalities that were not apparent in previous ECGs. It's a stepwise approach. Then after that, if we did not evaluate the coronary anatomy at presentation, that would be the time to do it now through a cardiac CT or a coronary angiogram, a CMR for detection of structural heart disease. بعد كده more advanced electrical studies عن طريق ان احنا نعمل high leads, نركب ال ECG لفوق شويه او نعمل ال sodium channel blocker tests و exercise test. And if we are suspecting coronary vasospasm, we can go for testing of coronary vasospasm. The second topic would be how to manage the VT. خلاص احنا we investigated everything. What to do next? Management of VT with structural heart disease. The first step, if the patient is hemodynamically unstable, هيبقى طبعا a cardioversion or defibrillation. If we are suspecting, if he's hemodynamically stable and he has features suggestive of SVT with aberrancy, you can give adenosine or vagal maneuvers. And then the next step would be we will, if he has an idiopathic VT, سواء كانت fascicular أو outflow tract, we can give either verapamil أو beta blockers على حسب نوع ال VT. If not, we will assess the risk of anesthesia for cardioversion. If he has a low risk, then the next step would be a cardioversion. If not, antiarrhythmic medication في شكل prokinamide, ده class 2A indication, and if not available like in our country هيبقى الاميودارون. What about patients who have coronary artery disease, chronic coronary artery disease, and have sustained monomorphic VT? It depends whether it's the first presentation or if they already have an ICD. If it's the first presentation, we will examine two things: the ejection fraction and the hemodynamic status during the VT. If the ejection fraction was less than 40 or the patient was hemodynamically unstable during the VT, then an ICD implantation is a class 1. However, if the ejection fraction was higher than 40 and the patient was not hemodynamically unstable and he was stable during the VT, then we have three options which are almost equally in the strength of recommendation. That would be catheter ablation, ICD implantation, or amiodarone, or with a class 2A. If the patient already have an ICD, we'll see if he's on amiodarone or not. If he's not on amiodarone, then he will start amiodarone. If he's already on amiodarone, then ablation would be a class 1. I will skip this slide for the sake of time. Management of the electrical storm. What's an electric storm? It's a state of cardiac electrical instability that is defined by 3 or more episodes of sustained VT or VF or appropriate shocks from an ICD within 24 hours. Most patients with electrical storm have severe underlying structural heart disease. What's the approach for a patient with an electrical storm? The first step is to make sure that it is actually an electrical storm, not an ICD malfunction or inappropriate therapy. How we do that? By programming of the ICD, making sure that it's not delivering a shock for an SVT or atrial fibrillation, or a shock while it could have delivered مثلا ATP or something. The next step would be, we know now that it's a real electrical storm. If the patient is hemodynamically unstable, the advanced life support is activated. The next step would be a light sedation. الهدف من الsedation حاجتين. One, the comfort of the patient because he's receiving multiple shocks and he's very anxious. والحاجة الثانية إنه هتقلل sympathetic drive, which is a very important contributing factor in the perpetuation of the storm. And then according to the type of ventricular arrhythmia presenting, we have one of two pathways. The polymorphic VAs, وديت المانجمنت بتاعها depends on the cause. I will not go through this برضه for the sake of time. لكن we will manage. If there are electrolyte abnormalities, we correct the electrolytes. If there are medications that prolong the QTC, we will remove them. If there is acute ischemia, the patient should go for angiography. If still recurrent after correction of all of this, then deep sedation intubation is a class 2A indication. What if it's a monomorphic ventricular arrhythmia? Again, ICD programming is very important. Beta blocker and sedation, preferably with a non-selective beta blocker, is a class 1 indication, starting amiodarone infusion as well. If still recurrent, catheter ablation is a class 1 indication. We'll move to the third part of the presentation, which is primary prevention for sudden cardiac death. And I chose two important entities. The first one, patients who have ischemic heart disease, which present about 50% of patients who have survived cardiac arrests. And again, the most important risk stratification tool that we use is the ejection fraction. If the ejection fraction is severely impaired, below 35% or even below 30 in absence of symptoms, an ICD implantation is recommended, and it's a class 1 indication. patients who have a borderline ejection fraction between 36 and 40%. If they are asymptomatic, then all they need is a follow-up. However, if they have non-sustained VT or unexplained syncope, then programmed electrical stimulation should be the next step. And if they have a sustained monomorphic VT induced during the EP study, ICD implantation is recommended. The second most important entity are patients who do not have an ischemic heart disease, those with dilated cardiomyopathy or hypokinetic non-dilated cardiomyopathy. A very prominent feature in these guidelines are the CMR and the genetic testing, which are very prominent throughout the guidelines. So CMR in these patients is a class 2A indication for one, exclusion of myocarditis, two, detection of late gadolinium enhancement. The second most important thing is genetic testing for patients who have a family history of dilated cardiomyopathy or a history of sudden cardiac death before the age of 50 years, or those who have AV block before the age of 50 years. If the genetic testing shows a pathogenic mutation, like the LMNA mutation وفي حاجات تانية other mutations mentioned in the guidelines, then some of these patients are eligible for implantation of an ICD directly. The patients who do not do a genetic testing or who do not have a pathogenic mutation, again we will go back to the ejection fraction. If it's below 35, then implantation of an ICD is a class 2A, and that's a downgrade from the previous edition of the guidelines. What about those who have, again, the borderline ejection fraction between 36 and 50? And if they have two or more of the risk factors that are mentioned, if they have these risk factors, syncope أو sustained monomorphic VT في programmed electrical stimulation أو gene mutation أو late gadolinium enhancement, we will do a programmed electrical stimulation and they be candidates for an ICD. We can skip this part عشان هي تاخد. And thank you very much.
صباح الخير. صباح الخير. لو نقدر كده نكونكت
جاهز
مع اللاب.
اوبس. الاثنين نمسك الوايرين مع بعض.
السكرين مش جايبه هنا عندنا.
وري فوق.
طيب احنا سامعينكم.
نخرج. اوكي خرج دي الاول.
الدكتور رضا عشان نكسب وقت، احنا متأخرين كده. ها يا كريم؟
نعم. ماشي الحال. كمل.
هم مش سامعين.
احنا ايه؟
دكتور رضا صباح الفل.
not ready.
لا لسه. ليه لايف؟ ما تقول لي لسه. تقول لي لا
Not ready.
still we have some time. we'll tell you when we are ready.
محتاجين يعرفوا ان احنا سامعين.
يا دكتور ده دكتور محمد
ده
احنا سامعينكم
أنهي؟
كويس، انتوا مش سامعيننا؟
لا ده اللي فيه الستنت ده. سوري. يلا. طب استنى. لا خرج دي معلش. يلا ادخل تاني.
هي دلوقتي الدكاترة مش جاهزين. اوكي. دكتور مجدي what do you want to do? هي.
برزنتيشن
So we'll have a quick show of hands لأنه صراحة to cover all three valve platforms اللي موجودة في مصر will become a bit difficult and we'll have to scroll quickly through them. I actually want a show of hands. Are you interested أكتر to see an accurate neo؟ كده رضا هيورينا an evolute I assume. فهل the audience would want an accurate neo ولا sapien an S3؟ ايه التفضيل؟ sapien. اوكي. اصل it becomes very difficult. ممكن ممكن نحط اللايف كيس. If we have time we'll go into the accurate neo. So I think the best way to show this is for actually the screen to work. أولاً يعني thank you very much Dr. Magdi, the entire faculty في اسم 23. It's an honor as always to be with you back home. And the slides should come up shortly. ممكن نطلع السلايدز يا جماعة؟ Hey. So this is actually a live transmission. And we can go quickly through the setup for an S3. Now, first of all, أول خطوة with any valve is the proper planning. Without the planning, you're doomed to get into trouble. And by planning, in the vast majority of instances, we mean CT. There are actually very few contraindications to CT. And nowadays, there are very few logic reasons to proceed with a TAVI without the proper planning with a CT in advance. So whether you do an ultrasound guided puncture or you do a fluoroscopy or an angio-guided puncture, the single most important step is that you do it under visualization. So we do not take the bony landmarks as a landmark, as a guide. We do not use palpation and try to figure out where the common femoral artery is. It has to be done under visualization. And by visualization, we actually want to pick a spot within the common femoral artery, 1 centimeter or so above the bifurcation, below the origin of the inferior epigastric artery, because that marks the entry into the abdomen, sorry. And you want a central puncture. The more you hit the artery in a central spot, the less likely there will be a closure device failure. On this occasion, we have a crossover from the contralateral side, from the left side. You can see that we're doing a couple of puffs just to make sure that we're entering the vessel exactly where we want. Thank you. الخطوة دي obviously applies regardless of what valve platform you're using. So what we're doing now is we've hit the vessel, or we're starting to hit the vessel hopefully. And again, you will see this is being done under visualization. This is not entirely the best practice. You can see our hand is in the radiation field. Now, there are ways to avoid doing that if you don't want to expose your hand to radiation, which you shouldn't, in all honesty. And you will see that we're entering now in a very central position, and this will lead, in the vast majority of instances, to a successful closure at the end of the procedure. Now, the second most important step with TAVI is vascular complications are still the #1 complication. They've gone down dramatically from 10, 12% in the early days to less than 5%, but it still is the most common complication you're likely to encounter. And good vascular access hygiene starts with the puncture and the pre-deployed ProGlide sutures. There's obviously a MANTA device as well, but so far the ProGlide will remain remains worldwide as the most commonly used closure device. To make sure that your suture is being delivered to the anterior wall of the vessel rather than being blocked in the subcutaneous tissue, you really need to dilate a good track. This is why you see the blunt dissection with an artery or a forceps prior to inserting that sheath. الفكرة كلها ان عايزين الغرزة اللي احنا هنحطها 2 ProGlides. We want to make sure you're able to deliver them all the way to the external wall of the vessel rather than become trapped في subcutaneous tissue. So I think we can discuss the ProGlide at a later stage. إنما anything above 12 French, you will go in with 2 ProGlide sutures, usually deployed at 11 and 1 o'clock. You want to make sure that you are able to close. A ProGlide is a relatively simple device. You go in, you deploy the handle. Now you've deployed the inner foot of the device. You catch the inner table of the vessel. Once you have that, you deploy your suture. We know from the CT that we're already picking a segment where there is no calcification on the anterior wall of the vessel, because that is the most common means or most common reason why your ProGlide suture will not work. And once you do that, you deploy the other ProGlide, the ProGlide الثانية, and you can see we're pushing this towards the 1 o'clock rather than 11 o'clock. And once we've had the foot deployed, we move to a more perpendicular angulation, deploy the sutures, then cut it, withdraw the device, and insert an 8 French sheath. Okay. The second most important thing with vascular hygiene, I think there was a coronary angio at some stage here. The second most important thing with vascular hygiene is the fact that whenever you are dealing with a large bore access, a large sheath, you need a stiff wire. So you can't really advance over a floppy wire. But what you've seen here is we've inserted a regular floppy wire, a 6 French catheter all the way to the arch, then exchange that floppy wire for a super stiff wire. Once you have your super stiff wire, الفرق ما بين الEvolute والEvolute you can go sheathless. It has an inline sheath. With an Edwards valve, you need the E sheath, and E stands for expandable. So once you have your E sheath in place, it's actually a beautiful device, hydrophilic, quite tapered, and in the vast majority of instances, you won't face any problems. The sheath itself is built in an expandable fashion, i.e. it has 2 layers overlapping on the posterior aspect of the sheath. الهدف إنه you want to minimize the overall profile. The sheath will expand, similar to what you see how a python eats, for instance. It will expand as you advance the valve, and then it will shrink again as the valve exits the sheath. تاني innovation I would have to say with Edwards is because this valve is mounted on a balloon, it has a large profile. And very early on, engineers at Edwards minimized the overall profile of the system by making sure that you mount the valve on the balloon inside the body rather than outside the body. فالخطوة المهمة إنه once the valve is in, it is actually crimped on the delivery system proximal to the balloon, and we only mount it onto the balloon inside the abdominal aorta or descending thoracic aorta rather than outside the system. Now this is a quick coronary angiogram. And I'm sure Dr. Reda and Dr. Muhammad will address nowadays. In the earlier days, we used to say, okay, we will fix coronary disease prior to doing the TAVI. Now, while we don't have a definite answer for that yet in terms of clinical data, however, practice has moved dramatically towards the opposite. Patients with severe aortic stenosis, unless there's a proximal LED disease, tight LED disease or left main disease, they die from aortic stenosis rather than from coronary disease. So coronary disease, or stable coronary disease in particular, is a relatively benign condition compared to severe aortic stenosis, and for those patients we usually go for the valve, and then the coronary anatomy can be dealt with unless there's a very compelling reason to do otherwise. So we've done the coronary angiogram. That's a temporary pacemaker. And the second nuisance with TAVIs is temporary pacemaker leads perforation. Now, we've moved to a great extent to pacing via the LV wire, and we can see the setup on the other side with the accurate neo. And I think this adds a lot of safety on the whole, because you can have a very safe procedure and you end up with a wire-based perforation. Remember, particularly in elderly ladies, those patients are prone to RV perforation. One way to minimize the incidence of that is to avoid placing the lead all the way into the apex and try to pace the septum, which is something we've adopted quite some time. But in all honesty, ultimately, pacing by the LV wire provides the best support. And similar with any TAVI, regardless of what valve platform you're using, here you would see that the pigtail is placed in the right coronary cusp. Now, with self-expanding platforms, we usually put that in the non-coronary cusp. كل self-expanding platforms, you cannot really command or you cannot really direct the delivery system. With an Edwards, you have a wheel that can introduce a lot of flexion all the way to almost 180 degrees. But with self-expanding platforms, you go passively onto the external curvature of the aorta. And that means that almost always your valve delivery system will rest under the non-coronary cusp. This is why with self-expanding platforms, we want the pigtail in the non-coronary cusp. With balloon expanding platforms, it's ideal to have it, I mean, you could still put it in the non-coronary cusp, but having it in the right coronary cusp gives you a perfect central position, and you can centralize the valve, and we'll see that in a second. So regardless of the valve platform, you're going to want to cross the valve. This is, I think it's a relatively, there's an element of luck in that. Usually those valves, you can cross them within less than a minute. Sometimes it's more difficult. The difficult anatomies are always related to the bicuspid spectrum. If you have a dilated aorta, a bit horizontal, I would say that the most difficult type is usually a type 0 bicuspid with a right non-fusion configuration, which is luckily not all that common. But anyway, regardless of the anatomy, you follow the same principle. We usually use an AL1, an AL2 if it's a dilated aorta, and you map the valve. And essentially, you're rotating clockwise, and as you're rotating, you're trying to advance a straight-tipped wire, be it a hydrophilic or a non-hydrophilic wire. Doesn't really make the difference. Hydrophilic makes life slightly easier, but at the expense of slightly reduced safety. Now, there are tips and tricks for that, but usually you will not have to resort to anything fancy. The second important thing is once you've crossed the valve, and that also applies to all valve platforms, is to do a baseline hemodynamic study, a very quick measure of pressures. And this is not there to confirm the presence of severe aortic stenosis. I mean, this is already established by echo, and echo is very accurate when it comes to aortic stenosis. However, you really want to look at, one, what is your baseline LVN diastolic pressure? Two, what is your baseline aortic diastolic pressure? Because at the end of the procedure, if you end up with a degree of AR and you find it difficult to classify or quantify the severity, your baseline hemodynamics will provide a lot of insight. So once you've had your straight wire in, we usually would advance your Amplatz left one, put an exchange wire, put a pigtail, and use that pigtail to introduce your either pre-shaped wire or manually shaped wire into the apex. On this occasion, this is a manually shaped wire, and though pre-shaped wires obviously make life much easier, however, they're quite expensive as well. We usually resort to pre-shaped wires when the anatomy is difficult. Let's say there's a lot of tortuosity, there's a bit of a horizontal aorta, or when the LV cavity is very small, because they tend to sit snugly and much better in the apex compared to manually shaped. However, you can still manually shape the wire and end up with a beautiful curve. The most important thing is you want to make sure that you have sufficient amount of the stiff portion of the wire into the LV, because this is what is going to provide the valve with the needed support. But you also want to avoid to have too much of the stiff component in, because that can tear the LV. So usually we would have one limb of that curve as the stiff part, but the apex of the curve itself is on the floppy part of the wire. So once you have your wire, you would usually want to go in an RAO projection that avoids any foreshortening within the LV cavity. Once you have your wire in a good position in the apex, then you are in a good position to start advancing your valve. So this is the valve, and you can see there's usually a bit of friction when you introduce it through the sheath, but once it's outside the sheath, this is sitting in the descending thoracic aorta, this is the time where you start mounting the valve onto the balloon inside the body. So to do so, and I have to admit that this has become easier with the newer iterations. One, we usually move to a bit cranial projection because we want to avoid any parallax on the system. And you can see that the balloon is still distal to the valve itself. And this is where we will start pulling back on the balloon to get it inside the valve. And you should see that in a second. Yep, sorry. So we unlock the system. We're pulling the inner shaft of the delivery system onto which the balloon is mounted, and this is going all the way inside the valve. Now there's another wheel that gives you fine tuning, and this fine tuning will allow the balloon to continue to get inside the valve. What you want to achieve is have this proximal and distal markers at both ends of the valve and the central marker in the middle position of the valve. Now, contrary to self-expanding valves, this valve you can actively flex it. So what we have here is another wheel. The big black wheel here introduces flexion into the system. So we want to understand the anatomy of the arch. This is where we would move to an LAO projection as we traverse the arch. And once we do that, you can see that we're flexing the wheel here. And this is introducing the necessary flexion into the system. This is usually a bit of flexion with posterior angulation. And once you're in the position, you cross the valve, you can see that we still have our pigtail as a marker. And now you want to withdraw that part of the sheath proximal to the balloon. And this sheath that is covering part of the balloon, so you can't really start deploying with this configuration. And this is exactly what we're doing. So once you have that beyond or just prior to the first marker, you know that you've cleared the balloon and you're good to go. Now, one particularly, people would always say that recapturable valves, there's an element of safety with that. I think similar to any balloon expanding versus self-expanding platform, the good thing with balloon expanding platforms, they're very reliable. If you do it once and you do it right, you can almost 100% of the time figure out in advance where that valve is going to end. Now, this is not particularly applicable with self-expanding valves, even in very experienced hands, but there is an element of unsafety or alarm that comes with the fact that this is a one-shot thing and you cannot really reposition or retrieve the valve. But in all honesty, with very basic training, this shouldn't be a problem. These valves are very, very, very reliable in terms of where they land finally. Now, to make sure with balloon expanding valves that you end up where you are, rapid pacing is probably the most crucial part of this procedure. There's a balloon that you're going to expand. If your pacemaker is not reliably capturing every single beat, if you get one drop beat, you get an extra systole, you lose capture, this valve is going to end up in the aorta if this happens midway during deployment. So it's particularly important to make sure that your pacemaker is placed in a good position, you're achieving 100% capture, and there's very good communication within the lab. So the person holding the pacemaker should be communicating with the primary operator, and this is a period of silence in the lab. Now, for this valve, you want to place that mid-marker right at the level of the annulus. And this is why it's quite important to make sure you have a very good coplanar view with the nadir of all three cusps at one line. So once you've achieved that, this is the time where we start rapid pacing, hopefully soon. Yeah, so this is some final fine-tuning before we go for the deployment. And I think this is the deployment. No. So we would usually do a quick test with rapid pacing just before deployment. And you can see that the deployment is a slow process. In the older days, we used to do it quickly. Nowadays, we're doing it in a very controlled, this should be a 4 or 5 second exercise, just to make sure that you have enough room to do any final modifications. So let's say you start inflating the balloon, the valve dives into the LV or moves into the aorta, you still have some time to make final modifications during the deployment. And once you've done that, you can see that the newer versions, either the S3 or the S3 Ultra, because of the external sealing skirt, it's actually quite uncommon to see any degree of regurgitation. Now, if you see a degree of regurgitation, usually means that this valve has been slightly underexpanded. So another balloon dilatation, perhaps with 1 or 2 extra cc's, usually solves the problem. So once you've done that, you want to do your root injection. And we've moved to trying to minimize the post-valve deployment checks, and we usually check with echo, but a single root injection just to make sure that you don't have any other complications like coronary obstruction or an annular rupture, for instance, is still advisable. Now, to get the most details from a single root injection, you would want to move into a projection with no parallax on the valve, do 1 injection. Usually I would do it in an RAO view just to make sure that we understand fully the depth of the valve, especially as it relates to the membranous septum. But you can see that this is the perfect position we have in mind, with 10% of the valve under the annular level and the rest of the valve over the or above the annulus. We're good? We're good. I'm fine. I'm done.
Thank you, Gendy, for the marvelous presentation. تعالى معانا بقى هنا في
أنا بس عشان أبقى عارف أشوف
طب دكتور رضا، دكتور محمد, can you hear us?
Hi, Ahmed, sorry. Any questions?
لا بقولك تعالى معانا على الستيج يعني, بس خلاص لو عايز تبص من هنا مفيش مشكلة.
كده هتبقى أزرق.
بس أنا مش عارف هم حد سمعنا في اللايف الناحية التانية ولا لا؟
دكتور رضا, دكتور محمد, we don't hear you, we don't see you. I'm not sure.
السلام عليكم.
عليكم السلام ورحمة الله.
Dear Chairman, dear professors, and my colleagues, it's honor for us to present with you one of our TAVI program cases. Are welcoming my professor and my mentor, Professor Dr. Rida Abou Al-Ata, who is a proctor of our TAVI program, who will share with us this difficult case. On my right, my colleague in the team and my best friend in the cardiology department, Dr. Karim Mahmoud. With us, Dr. Mahmoud Abdel Tawab, anesthesia consultant at University, Dr. Mamdouh Abdel Salam, vascular surgeon. Our CAS lab team, Mr. Adnan, Mr. Sabah, Mr. Mustafa, and Mr. Said. Our colleagues in the department, Dr. Sharif Ashraf and Dr. Luay. Dr. Karim will present to you briefly our case.
Good morning, أحمد جندي, أحمد عادل, هم دول اللي أنا سمعت صوتكم. مين معانا تاني في البانل يا جماعة؟
صباح الفل. احنا our bad. So we have on the panel Muhammad Hassan, Ahmed Adil, Hussam Bishr, Great to see you guys. You're looking good.
Good morning,
ودكتور
Ahmed.
سامي ميل, sorry. دكتور سامي
So,
ميل. So جه على الجنب.
so we have an interesting case today. He is a 72-year-old male. He is known to have diabetes mellitus and hypertension. His main complaint is shortness of breath, Canadian NIHA class 3. He has a history of cancer prostate at 2020, and he received multiple sessions of chemotherapy and radiotherapy. On 2021, he also was diagnosed as an ulcerative colitis after repeated attacks of bleeding. He received laser photocoagulation, argon photocoagulation, and also steroid and chemotherapy for ulcerative colitis. His anemia was corrected with repeated blood transfusion and iron supplementation. However, he continued to have shortness of breath. Echocardiography was done at this time and revealed severe aortic stenosis. His examination is more or less, he's stable regarding the heart failure. His blood pressure is 150, 140, and he has a murmur of aortic stenosis over the heart base. As you can appreciate, the ECG, شايفينه يا أحمد؟
كريم
ECG زي ما احنا شايفين في right bundle branch block. Echocardiography also was done and revealed LVH with ejection fraction of 70%. The mean gradient كان 41 millimeter mercury. كان عندنا mild degree of mitral regurgitation and tricuspid regurgitation. His estimated STS score was low. لكن يعني احنا دلوقتي عندنا despite ان احنا عندنا estimated STS score is low, في عندنا comorbidities اللي هي مش موجودة عندنا في السكور ألا وهي bleeding due to his underlying GIT condition, which is ulcerative colitis, and the history also of cancer prostate. So this should be taken into consideration while assessing this patient and the option for aortic valve replacement. Also, for academic reason, we assessed the TVT score, which is a score for TAVI, and it was also low. So here I have Dr. Reda, and we have the panel for the discussion. What is the best option for this patient?
Thank you, Karim.
Good morning.
Do we have a chance for a couple of minutes discussion?
طب
Yes.
كريم عايز اسال الفريلتي اندكس بتاع البيشنت دوت was it calculated ولا
Sorry, yeah.
الفريلتي اندكس
Frailty index.
This is an important point, Dr. Reda. I think the patient is not.
Actually, he is a self-dependent. He can drive his car. He's doing his work. So I don't think that we can classify this patient as a frail person.
Very good.
Sorry. Good morning first for everybody.
صباح الفل.
الله يحفظك. دكتور أحمد, دكتور عادل, دكتور حسن, دكتور بشر. I would like just to share a few points. And I heard your presentation, Dr. Ahmed. It was excellent. Thank you very much. Now, this patient, he had a CT first time, and the CT was by mistake from the center who did this one. It gave just a regular aortography, not gated, and we could not get any information of the root. We sent him back to the best center to do the CT, and unfortunately, it cannot be interpreted for any data. We cannot read any root data. We cannot, only that we could see is the significant calcification and massive tortuosity of the iliofemorals. This is why we elected to have a very elite small cut down to make sure that we don't have a problem to the vessel. So we face a problem now for this patient. We cannot size him right by the CT data. It cannot be interpreted. So go back to the panel. What is the option for this patient first? The second, what is the option for the operators if we are going to do this patient for TAVI? And what we have today is a platform of the self-expandable valve, the Evolute R.
I think these are excellent questions, Dr. Reda. A couple of things to share with you. One, I missed how he's 78, right?
72.
72. Okay. So he lies in sort of a gray zone where both SAVR and TAVR can come into play. I think surgical risk as a gatekeeper to TAVI, we're already beyond that. It's really age that matters, and the second most important thing you want to address is the suitability for a transfemoral TAVI. I can see that you probably have a LunderQuest inside, so that spells that the tortuosity is not the greatest. But I have to ask you one question. He has a baseline right bundle branch block, and for the audience, these patients are at the highest risk of developing complete AV block after TAVI. So how did that affect your choice of valves? وأحمد عادل بيضحك وراك لأنه عارف أنا قصدي إيه.
Actually, this patient, if we can put him on either platform, and maybe if we have a balloon expandable valve with a almost 95 to 5% ventricular, probably it would have a lower risk, but I don't think so, because this patient has a very big root. It looks to me a massively calcified, and add to this one, he has also a significant mitral annular calcification, and he has a significant calcification in the membranous septum. We can see from the echo images, we have a big lump of calcium in the vicinity of the membranous septum.
Yeah.
So to me, this patient, add on to his own problems, he's also at the extreme possibility or probability of developing complete heart block after.
Yeah.
But before this one, to share with you, to get your experience from all our panelists, that this patient, we don't know the size for now. So what is your algorithm or your approach to get it? We don't have a 3D TEE in-house. We have only the two-dimensional echo only. So we are left with that.
That's a bummer. Muhammad.
Dr. Reda, Muhammad Hassan, I think you answered actually you answered the question. Firstly, in absence of proper pre-procedural planning, don't have CT interpretation, I think intraoperative TE will help us in proper sizing. We know that it will a little bit underestimate, but firstly, it will help us in sizing, and secondly, we may have some balloon interrogation as a second step during the procedure.
So two-dimensional TEE make use of the best available now. Now there are ways to sort of, I'm just reiterating, Muhammad, for the audience, there are ways to sort of introduce a three-dimensional mental image with a two-dimensional TEE study. So that can be helpful, yes, but that means that probably this patient will undergo the procedure under GA.
Yes. No, he is not under GA.
So that really takes off the option you had. I think we are left with a combination, and Dr. Reda is a master when it comes to that, of a combination of root injections and balloon sizing.
Yes.
And that's going to be interesting because we haven't seen those for some time.
I need to add something more interesting, that we have actually a technical problem for the injector. So actually, we don't have injector. So
now that's going to be interesting. Now, I mean, you can handle one thing at a time, but this is a combination of interesting things. That's going to be interesting because it's going to show, A, how skilled you are in the face of adversity, B, perhaps the positioning of the valve, and especially in this patient, you really want a high implant if there's any chance whatsoever of getting out without complete AV block. So it's going to be interesting to see if you're using one pigtail versus two, and I think that means it's good old balloon sizing alone without a root injection.
Just one comment, Dr. Reda. We know that in such cases, you depend also on transthoracic echo, and you have your tips and tricks to use transthoracic. So definitely you had a look on the transthoracic. So what's your input from the transthoracic echo?
Actually, when I look to the transthoracic echo, usually I scroll the anterior wall of the aorta, and then till I reach to the base of the right coronary cusp, then I take this point, and then I scroll the posterior aortic wall till I come to the commissure between the left and the none, and then I take this vertical measurements, and these vertical measurements, it came between 26 to 27 millimeters. So if we try to compare this one to the CT measurements, usually it is underestimated by around 5%. So if I can say that this should be a 27 plus aortic annulus, that it will put us in the context of the big valve, which is the 34 millimeter. For the interest of time, just let me do him the balloon, and actually we will count on the what we call the mental work to make sure that we can see the root itself. We can try to find ourselves what we call, we try to move in the blindness to see where we are. This is the big tail in the nadir of the right coronary cusp, the non-coronary, sorry.
Can
Go
we
to
see
AB,
the
please.
fluoro screen, ya Jamaa, please?
You can see the floor.
AB,
To
please.
be mentioned, we have an osteal lesion, significant osteal lesion at the right coronary artery, and we did a PCI to this right coronary artery using a 4.512 balloon that was dilated with 5O balloon.
This is again the same point you mentioned, Ahmed, here. When you have this type of patients, you do the PCI ahead, or you do the PCI in the context of this, what we call it, the index of the procedure. Another problem, this patient, he has a diffuse disease in the left system. Can we review the coronaries while we are talking? And in a patient, when I'm telling maybe Medtronic, they will not be happy for that. Can you see, Ahmed?
Yes, that's quite a tight osteal lesion, yeah.
Yeah, it's a calcified, very tight lesion, super dominant vessel, ectatic, some diffuse disease in the BDA. It's a wearing take off of the RCA with a bit of difficulty for support or for doing the job, and we have a distal lesion in the BL also.
Yep.
Can you go to the? Okay, this is the left system. We have a chronic totally occluded distal LCX, mild disease in the proximal left vein and LAD. Next, and then the mid LAD, we can see a diffuse medical issue, a massively calcified, proximal to mid areas. When I'm going to do a patient with a balloon expandable short profile valve, we never worry about the coronaries. But if we have this type of patients that we have an osteal RCA, and we know that up to more than 25% will not be able to cannulate the right coronary after the procedure. So this will put me in the obligation to fix his right coronary. And this is actually a critical lesion in a super dominant vessel, and it is covering the LCX territory. And with this short diseased LAD, the backflow coming from the BDA to the LAD is very crucial. So what is your thoughts, Ahmed, in this? You will fix it. It can affect our choice for the valve, or what is your thoughts in this issue?
Yeah, I mean, you make a very strong argument. This is one of the scenarios where this is a super dominant right, as you mentioned. It's quite a tight lesion. It is osteal, so the entire RCA territory is compromised. And yeah, I think a quick fix, even if it's not a quick fix and you would have to rotablate that, I would fix it before the valve, especially in light of self-expanding large stent frame. So I totally follow the rationale here.
Yeah. This is if we are in the options of if we have, I assume that this patient is 5 years younger, he is in the 60s, and he has these coronaries. You would like to stick to the same platform of the valve, or you would like to shift to another valve type?
Excellent
and
question.
as you believe in that the lifetime management of the aortic valve disease is crucially affected by the accessibility and the risk of coronary occlusion and the need for another TAVI in the future.
Let me redirect that, excellent point, Dr. Adel. Let me redirect that to Dr. Ahmed Adel. So if he was slightly younger with the expected survival of 20 more years, and in view of very advanced coronary disease as what we see, what would be your initial choice of valve?
I think a balloon expandable valve would be a good option here in this situation, taking into consideration that we might need another procedure later on, another TAVI procedure maybe, or another intervention in the coronaries. So I think, of course, hypothetically, that at this age, he doesn't need surgical intervention as well, because SAVR would be an option if he's 5 years younger. SAVR would be an option.
Very good. So the argument here, sorry? If you were younger, yeah, surgery obviously would be a very good option, بس احنا في مؤتمر intervention هنعمل ايه طيب؟ So yeah, so the points Dr. Reda and Dr. Ahmed are raising are important because you really want to think how this patient is going to be treated, not just today, but 5, 6, 10 years down the line, and this obviously becomes a more pressing question the younger the patient is. So if you have a self-expanding platform, it fails after 10, 12 years, for instance, and you want to put another valve, then coronary accessibility, even if the first valve was put with good commissural alignment, and I'm sure they'll give us a fantastic demonstration with that, the chances of having coronary access after putting in a second valve are going to reduce dramatically. Now, the opposite is not particularly true. If you have a short stent frame balloon expanding valve to be followed by a self-expanding valve, you still have a very good chance of coronary access later on. So we don't want to keep you. You already have quite a challenge ahead of you. So
a lot, actually.
Yes, please. So take us through the setup and please proceed.
I would like to just to summarize. So we have a patient. We are missing some of the information, and I will, from my visual assessment, actually, I don't have availability to power injector contrast. I will just have a buff, very gentle buff to the non-coronary cusp to see what we have here as a root.
Dr. can you tell us what type of balloon are you using and what size?
This is a 20 millimeter crystal balloon. I'm going to actually balloon the valve. Why the reason of that? Because I have a lot of missing information, and if I see that this wire is traveling to the commissure, so actually this valve can be left alone to the radial force of the prosthesis. It can lift it up. And definitely he is not a bicuspid valve. So the balloon interrogation I have to skip, and the balloon dilatation we might skip. But actually for this very horizontal aorta and for the rigidity of the delivery system of the Evolute R, I prefer to have this valve dilated to make sure that this commissure will not bias the valve during the advancement. If you allow me, just for the sake of the time, we can continue to discuss. I will continue to work. So
no, please go ahead. We're following you.
Rapid basing, please.
وبعدين كريم بيلعب حديد فممكن تخليه اعتمد عليه كباور انجكتور.
لا. Okay, this is the 25 millimeter balloon, and actually, if I can see the lump of calcium. Basing off, please. If I can see the lump of calcium toward the left vein side or the left coronary, I think we are at least 2 millimeter away. So if this is a 25 millimeter, that it means that the annulus is almost 27 millimeters. So I think it will be much better to have a 34 millimeter valve. If this is a bicuspid valve, probably I would pick up a smaller one. But I think this one will be okay. The rationale when we have this horizontal and this what we call out-curving aorta in the AB view, we can pretty sure that the balloon would help to minimize the what we call the difficulty in crossing the valve, and supported with the Lunderquist valve, specifically with this very big, what I can say, this very big valve.
So what Dr. Reda has in the LV, or the group, they have a Lunderquist wire. This is the highest stiffness of wires we have in our armamentarium. And I think he just explained why he chose that wire. It's not a bad choice in general when you have a lot of tortuosity. It actually becomes quite useful. It also becomes quite useful when you have this type of horizontal anatomy, which is a bit of a challenge with self-expanding platforms, particularly Evolute. So what this will allow the valve is, rather than have a configuration where you are slightly
Ready?
high on the non-coronary side and you're diving very deep on the left-right side. It will allow the valve to follow the external curvature of the aorta and allow for a relatively homogeneous inflation or deployment, sorry, within the LV.
Because as you see here, the valve is very long, so you need a very stiff wire in order to navigate it through this horizontal aorta. So it's important to have the stiffest possible wire.
One important thing, sorry, Ahmed, one important thing. Now, they've introduced the valve with the flush port at 3 o'clock. 3 o'clock يعني بعيد عن الoperator. And I think commissural alignment is extremely important in this relatively young individual with advanced coronary disease. And chances are that this patient is going to need a future procedure for his coronaries. ساعات بتبقى in the context of an acute coronary syndrome.
That's it.
ومش بالضرورة for someone who has experience in doing a coronary angiogram or PCI for good valve. فwhat you see here في ال LAO view واحنا هنشوف دكتور رضا هيروح RAO دلوقتي the hat marker اللي موجودة تحت is pointing towards the left side. Now, we know that this means that you're achieving a very good degree of commissural alignment. That was a quick deployment.
That's it.
We're not seeing the hemodynamics, but I can assume that you moved very quickly. The hemodynamics were not the greatest, huh?
Yeah. This when we just crossed the valve, actually the pressure went significantly down. Probably we spent a lot of time. So actually, we don't have the again, we don't have the commissural what we call this cusp overlap facility. We don't have the ability to use it. So in this case, what we have to do is to just only to use the AB view. We have good news that probably the injector is ready, but before doing the injection, I think from the fluoro view, we can assume that this valve, it looks in good position.
It does. It actually does, provided that the pigtail is still in its position. But I like... So we've seen
I will try it.
Yeah. Sorry.
Go caudal, please caudal a bit. That's it. Now, first of all, I need to make sure that I don't have any parallax, that we are sure that when we inject, we are in the same plane or the same, what we call the horizontality that we see from the near portion of the valve and the far portion of the valve from this cylinder in relation to the aortic annulus, and the two cusps are almost the same. Now our pressure is already good. We have almost 100 by 50, and this, I think it is good. From the appearance of the valve, I think it is okay. We have the time to go to the right caudal, please, to make sure from the same anatomy that we can see that we are probably we locked it to be in good position. Okay, go more RAU, more caudal, please. Yeah. Far away caudal. Yeah. Far away caudal. Here we can appreciate that from the right coronary cusp, I think we are almost 2 millimeter. We have a bit of parallax, but it can give us the impression that this valve is well opened. Go to the LAO. Again, in the other LAO, which is the long axis or the largest diameter of the annulus, we can appreciate how the valve is opened or not. Go more.
That's
it.
View.
That's it.
You usually have the left and right coronary cusps on the right-hand side of the screen, and the non-coronary cusp is isolated. So it gives you a full understanding of how deep the valve is as it relates to the membranous septum.
We will try to test this injector. I hope that it will work. Ready? No. Ready to inject? Yalla, bismillah. Okay, inject. Okay. We have the injection, we have almost, the level is almost zero. This is a good question. AB caudal. Benel, what do you think?
Excellent. Can we see the same thing with the right caudal view?
Yeah, I will give it to you to the AB and
Ahmed, Hussein, what do you think? So would you go
we'll
ahead
give you
and
more
release?
images. Inject. This is the AB caudal view.
I think this is a good position.
Release. Muhammad.
Release.
I think it's a good position. However, I need to see again the LAO view. I'm really a little bit worried.
Can you review the LAO?
Yeah.
To make sure
an echo would also help at this point, if you have any doubts.
Okay, well, this is what we are going to do. Please, can we have a look with the echo, please?
So I'll tell you لغاية ما نبص على echo to answer Dr. Rida. This is a high implant, which is
Yes.
actually good in this patient.
Yes.
So it's almost 0 level,
Yeah, but-
perhaps -1.
Yeah.
But that's not particularly bad. There's only one scenario where I would not release this valve في البوزيشن ده in this patient with baseline right bundle branch block. If the valve was not expanded, then I think I'm going to require post-dilatation. Now, if you do this and they do a very slow release, Dr. Rida is going to apply, with Dr. Muhammad are going to apply significant forward pressure as well. I'm happy to release the valve. بس لو كان الفريم ده under expanded وباين إنه there's a high likelihood of post-dilatation, this is not going to be a safe position and you probably will end
Yes.
up with migration upwards.
This is an
I'm not sure if you
excellent
can see the echo مع echo بس
Yeah,
يعني
we will try,
if we
we'll
can't, we
try.
trust you.
Yeah. So if we, Ahmed, this is a very interesting point for me and for everybody. If we have a conflict in leveling between the two views, here in the LAO view, we can see almost from the non-coronary it is 0, from the left coronary it is 0. And in the AB caudal, yes, in this view, we have in this patient, we can see the non-coronary cusp and the left coronary cusp. And we are dead sure because we are in the caudal projection that the right coronary cusp is higher. So this is a conflict. Here we have one view, we are almost 0 in a tricuspid patient, and in another view, we have it's a +2 millimeter in one and +4 in the left coronary. What do you think? Which one we have to consider? And by the way, our ECG is the same. We don't have any heart block. We have still this degree of right bundle branch.
The RE caudal is the best to consider because there's no parallax and here we are sure that the level is below the NC cusp, so it's only 1 millimeter or less or 0. So this is the best chance for the patient to escape the pacemaker implantation possibility.
So a high implant on this occasion is something welcome, obviously. But remember, you don't want to end up with a migrated valve.
Yes,
Now, I think there are 3 questions. Dr. Rida is really asking important questions. One, is the valve below the level of the annulus all around? If there's part where it's not below the level of the annulus, this valve needs to be repositioned. أبيض وأسود. So what he's doing, he's isolated the non-coronary cusp in the REO caudal view or the AP caudal view. He's isolated the left cusp in the LAO view. And we might have doubts about whether the right coronary the valve is below the right coronary cusp. Now this can be challenging, especially if we don't have a baseline CT to understand the basic views, what the coplanar is, what the double cusp overlap in both configurations is. بس هنا دي أهمية الإيكو, if you have any doubts. Now, I would still say if it's, I also like the fact that in the LAO view, this valve is quite coaxial with the axis of the aorta.
Perfect.
الcoaxiality دي تديك a lot of reassurance that it's not going to jump or move a lot once you deploy it. لو كان الصمام ده is sitting with a lot of non-coaxiality, you would be alarmed. لأن وقت الرelease, it's going to try to tilt and centralize itself, and this is where you can get migration. So we're waiting for you to move, guys.
The echo, Dr. Ahmed, thank you for your excellent comments, actually. This is what I meant to see, that if I am in doubt, we need to make sure to have the reassurance from every piece of information available. We never get our hands blind. This what you said about the orientation or the alignment or the being so parallel to the course of the aorta in the AP and in the LAO. This is very important work from the wire and from the initial pushing of the valve. We have to make sure that the valve is sitting in the outer curve of the arch and the wire is supported very well, and we don't have lag in the system. This will allow us to make the valve in the flight position, in this what we call ascending aorta alignment or oriented in a proper way in this very horizontal aorta. For this one, if you allow me, Dr. Ahmed, I will take my steps to again For sure, we have to make sure that we don't have a coronary problem. I don't think we have any issue related to the coronaries. And we actually not sure that we'll have, again, the injector. So for this one, I will, first of all, I will release the tension of the system by pulling the wire a bit to make sure that I don't have a pushing backward forces from this tough wire. So I'm pulling a bit the wire to make sure that the nose cone is freely flying. Rapid pacing, please. Again, I usually prefer in this patient to make it on rapid pacing. We started the rapid pacing and slowly, gently, we are trying to release the valve. Bismillah. Okay, off pacing, please. Now we have the valve still sitting in position. I think it looks nice, and the two C-taps, they are already released. And here we can centralize the nose cone to take it back to make sure that it came gently inside, and then we push back the wire again to replace it. And actually, the movement or the maneuver with the wire is very crucial in this type of patients. Okay, so now I think we have the valve. It looks in a real, very horizontal aorta. Decrease the caudal a bit, please. We can see how this decrease a bit more. That's it. Now we removed the barrack, so we can appreciate that the valve, it looks from the size point of view, we can see that the inflow of the valve is a bit bigger than the waste. So this one, it gives us an impression that this valve is proper sized. Number two, we have the valve now we view the echo again to see if we are in need. In similar patients, actually, if we have a point related to his renal impairments, we can skip most of these injections, but this is for academic point of view. We'll try to find if we can find another injection.
I love the fact that with self-expanding platforms, you see that they're waiting on the final check angio. This frame will continue to expand within the coming few minutes, and you can actually end up with a much better result than what you achieve immediately. So take your time, do the echo, check everything. This is good downtime. And from a contrast saving perspective, there's no point unless you really have any doubts about the hemodynamics. There's no point in doing an immediate injection. Sorry, Dr. Reda, carry on.
Yeah. I'm trying to get you the echo. Karim, can you mention the echo, please?
So the valve is in the aortic position going into the LVOT by about 3 millimeter. There is no apparent paravalvular leakage. The valve is well opened. There is no turbulence now across the LVOT. In the short axis, also the valve is good. So I'm going to get a gradient across the aortic valve.
25 or 20? It is 20.
Okay, so they're pressing us for time. Dr. Reda, we want to see the final injection.
Okay,
and perhaps,
let me try.
just 2 minutes for questions from the audience or the panel.
Yeah. Already? Bismillah. Pardon? Yeah.
Oh, fantastic.
That's fine. So we have a very nice position of the valve. We are sure that we are almost at 2 to 3 millimeter from this level. I think this is the best position that we can ask for a patient with right bundle branch block with this 34. We have adequately good coronary perfusion. We don't have any degree of aortic regurgitation.
So, great. Any questions from the audience, the panel? I think we have a couple of minutes before we fantastic result, guys.
2.5.
Any questions?
Mean gradient is 2.5.
Congratulations, Professor Dr. Reda, Mohammed, and Karim. Really very challenging case. My question actually to Ahmed, you mentioned in your presentation, if you don't have obstructive coronary artery disease in the CT, do you do a conventional angiography?
Very good.
Because actually we are toward minimalistic approach. We need to save contrast. We have our patients. What's your...
So the strategy we're currently adopting is, unless the CT comes back with very advanced and severe coronary disease that we think is going to be a bit of a long procedure and needs to be addressed beforehand, we usually do the coronary angiogram at the time of the procedure. Now, what we've also adopted, if the coronary CT comes back as normal, we skip the coronary angio altogether. So I would say in 80% of cases nowadays, we do the coronary angio at the time of the procedure, but the two extremes are patients with a normal coronary anatomy on CT. We skip the angio altogether during the procedure, or those with very advanced disease, those come in a week earlier for a separate coronary session.
My question to Professor Dr. Reda, are you keeping the pacemaker till tomorrow? Because we know of the right bundle branch. Actually, we don't have conduction abnormality, but is it better and safe to keep it till tomorrow?
What I will do, I will pull the lead out of the RV. I will keep it either in the right atrium on the IVC to make sure it is in place in case, la qaddar Allah, there is an emergency. But I think with this position, with minimal trauma to the annulus, we did not change the natural history of his conductive system. We don't exhibit any compression to this route at all. And I hope that we give him the best chance to avoid any progression or compression to his conductive system.
Hey, Ahmed, the one last question, Dr. Reda, Dr. Mohammed.
Dr. Reda, please.
Ahmed Adel.
أنا بس عايز حضرتك if you can summarize to us your way of thinking في pre-planning procedure. حضرتك قلت this patient does not have an adequate CT. So what's the next best option usually in these scenarios? CT with contrast, dry CT, 3D echo, 2D echo, TE. How do you think about it? How do you proceed with these patients if you don't have the best thing? What's the next best thing?
For sure, what you are telling is very valid point. For every institute, they should have the very well-trained interventional echo team. From the past history, I know that Hani Mahmoud, particularly when he was working in Al-Ihsa, most of their cases, they were working Edwards in the 2012 and 13. And most of the cases, if not all the cases, they are done only with 3D transesophageal echo, and this is very important. The second point is, so the echo 3D is dated to get the annulus, the area, the coronary height, and everything we can need with a very good, what we call sensitivity and specificity that I can respect. The second point is well preparation of the patient before going to have these cases. And finally is the self-expandable platform. They are very well forgiven in this type of patients if we don't have a valid CT, or if we have a patient with significant renal impairment and his main enemy is the contrast. So in sequence, 3D echo training program for every institute for people to be very comfortable for every case when they do 30, 40 cases in consequence and they compare their findings to the CT, they can improve, and will be the pillars for every institute. The second is balloon interrogation. If we have a problem with a proper pre-mind or a pre-selection of the size of the balloon based on the two-dimensional echo with -1 at least from the measurements we grabbed by the 2D echo, I think this is the best way. MRI, it was a trial to have the MRI on board, but I don't think that the MRI gave us adequate information to count on.
Thank you very much, Dr. Reda, Dr. Mohammed, Dr. Karim, the entire Cath Lab team, as always, Ahmed Adel. Thank you. It has been a pleasure being with you. We will have to bring this to an end, but look forward to seeing you soon. Thank you.
Thank you very much, everybody. Thank you. شكرا جميعا. تسلم يا محمد. شكرا يا شريف.
So now we have one of the sessions of the meeting today, which is symposium of Advia, pharmaceutical company. And in a couple of minutes, I'm going to cover the guidelines for heart failure management. And we know that according to the new universal definition of heart failure, that heart failure can be diagnosed using this universal definition. I forgot to thank my co-chairman, Professor Fathi Maqladi, Professor Atif Al-Bahri. I'm sorry عشان الوقت النهارده we postponed the session from yesterday, so we have a very long and busy agenda. So I'm sorry. So heart failure can be diagnosed based on symptoms and or signs of heart failure caused by structural and or functional cardiac abnormality and incorporated by at least one of the following: high level of natriuretic peptides or objective evidence of cardiogenic pulmonary or systemic congestion. And symptoms and signs caused by structural or functional cardiac abnormality can be detected by ejection fraction less than 50%, abnormal cardiac chamber enlargement, E over A prime more than 15, moderate severe ventricular hypertrophy, moderate or severe valvular obstructive or regurgitant lesions, and objective evidence of cardiogenic pulmonary or systemic congestion can be detected by different imaging tools like chest X-ray, high LV filling pressure by echo, hemodynamic measurements, right heart cath with high wedge pressure. So the guidelines for diagnosis and treatment of acute coronary heart failure, the last EC 2021 guidelines classified the heart failure into three phenotypes: HFrEF, which is symptoms and signs of heart failure, and an ejection fraction 40% or less. Mild reduced ejection fraction, which is a new phenotype when the ejection fraction is 41 to 49, and the HFpEF, which is challenging in diagnosis when heart failure with an ejection fraction 50% or more, with an objective evidence of cardiac structural and or functional abnormalities, high LV filling pressures detected at rest or with exercise, in addition to high-level natriuretic peptides. When seeing patients with having symptoms and or signs of heart failure in the clinical practice, you have to assess the probability of heart failure according to proper history taking, a clinical examination, electrocardiogram, and then estimating the NT-proBNP level. So a cutoff level of NT-proBNP more than 125 picogram per milli or PNP more than 35, this indicates that probably shortness of breath is due to heart failure. Then echocardiography is mandatory to assess structural and functional abnormalities and estimating the ejection fraction to diagnose which phenotype of heart failure is diagnosed. The guidelines now recommended that ACE inhibitor, which for many years we are considering ACE inhibitor as the cornerstone for treatment of heart failure, according to the evidence from many clinical trials, that ACE inhibitor reduce hospitalization and improve survival. So it's class 1A recommendation. And the same according to the results of beta blocker for bisoprolol, carvedilol, metoprolol, they are recommended to be class 1A, which decrease hospitalization, heart failure, and decrease also sudden death. And according to the RALS study, spironolactone and eplerenone emphasis trial, this group of drugs are recommended class 1A to decrease hospitalization and death. And the new agents, the new game-changing players, which is SGLT2 inhibitor, DABA or IMBA, according to Emperor reduced and according to DABA-HF trial, that using 10 milligram of DABA or IMBA decrease mortality and heart failure hospitalization, so it's class 1A recommendation. And finally, ARNI, sacubitril valsartan, is considered class 1B in patients who are receiving ACE inhibitor and still have symptoms of heart failure. The American guidelines consider the use of ARNI from the start in patients with function class 2 to 3, not in function class 4. The role of diuretics in the guidelines is important. Class 1C just to relieve symptoms and signs of congestion, to improve symptoms, exercise capacity, reduce hospitalization, but has no impact on mortality. while angiotensin receptor blocker is considered a class 1B recommendation in patients who are unable to tolerate this inhibitor or ARNI. So the 4 pillars which should be used for every patient with heart failure: class 1A recommendation, ACE inhibitor, beta blocker, MRA, class 1B, ARNI. So now SGL2 inhibitor is class 1A and the loop diuretics class 1C. When using beta blockers in the daily practice, not most patients achieve the target heart rate, which is less than 70 beats per minute, and some patients cannot tolerate beta blocker. You cannot titrate, you cannot reach to the target dose. So we have to shift and to use another agent, which is an evaprel, which is an IF current inhibitor, which acts specifically on the SE node to decrease the intrinsic activity of SE node, so slowing the heart rate. So ivabradine class 2A recommendation, patients with heart failure with EF less than 35%, sinus rhythm and heart rate more than 70 in spite of using of adequate tolerated doses of beta blocker. Also ivabradine class 2A recommendation in patients who cannot be given or have contraindications to beta blocker. Soluble guanylate cyclase receptor stimulator, which is a very Variciguat cyclic guanosine soluble guanylate cyclase agonist in patients who have worsening heart failure, recurrent hospitalization, high level of NT-proBNP, more worsening of heart failure. This indicates that the use of Variciguat, according to Victoria trial, it decreased mortality and hospitalization, and class 2B recommendation, hydralazine isorbidinitrate combination, class 2A recommendations, according to the data from the use of hydralazine isorbidinitrate in Black Americans, and also it's considered in patients who cannot tolerate ACE inhibitor or ARNI or angiotensin receptor blocker, which is class 2B recommendation. Any patients with heart failure should be screened for iron deficiency, which is commonly seen in heart failure patients. Up to 50–60% of patients have iron deficiency. So estimating serum creatine concentration, TSAT, and intravenous ferric carboxymaltose should be given when iron deficiency is present based on the criteria of serum ferritin less than 100 nanogram per milli, or a serum ferritin of 100 to 299, or with TSAT less than 20%. To relieve symptoms, improve exercise capacity and quality of life. Not only in chronic ambulatory patients, but also in acutely decompensated heart failure before discharge, you can use the intravenous ferric carboxymaltose to improve the patient's status and decrease hospitalization based on the data of a firm acute heart failure study. After stabilization, iron deficiency anemia should be corrected and starting before hospital discharge. So this that treatment algorithm for heart failure patients with reduced ejection fraction, the 4 pillars from the start: diuretics to relieve symptoms, patients improving to continue medical therapy, patients still having heart rate more than 70, so ivabradine is indicated, patients with electrical and or mechanical dyssynchrony with the QRS duration more than 130 milliseconds, indicated for cardiac resynchronization therapy, and considering ICD for patients, especially with ischemic etiology. So CRTD, not CRTB, is indicated. And in patients who are not candidate for CRT, but in the presence of ischemic undilated cardiomyopathy, ICD is indicated when the ejection fraction less than 35%, in spite of using guideline-directed medical therapy for at least 3 months. And it's class 1 in ischemic etiology and class 2A in non-ischemic etiology. Again, this slide summarizes the treatment approaches, pharmacological and non-pharmacological, devices used, and correcting comorbidities. Patients who is candidate for revascularization should be sent for revascularization. Patients with significant valvular heart disease should be corrected, for example, TAVI for severe aortic stenosis. And in advanced heart failure patients who are not improving, so those patients should be considered for advanced heart failure therapy like the use of LVAD or cardiac transplantation. What about the new phenotype of heart failure with mild reduced ejection fraction, which the data are not so much? So you have to use diuretics to relieve congestion and consider the use of ACE inhibitor, ARP, beta blocker, MRA, and ARNI, which are considered class 2B recommendation to reduce mortality and heart failure hospitalization. So the Fantastic Four is ACE inhibitor or ARNI, beta blocker, MRA, SGLT2 inhibitors. And don't forget to correct comorbidities and to consider the use of intravenous ferric carboxymaltose in heart failure patients having iron deficiency. While treating your patients, you have to be cautiously and you have to be alert to blood pressure, heart rate, volume status. We know that less blood pressure reduction with SGLT2 inhibitors and MRA compared with sacubitril valsartan, of course. Diuretics should be titrated and should be flexible and initiate. Also, we consider that SGLT2 inhibitors have a diuretic effect as well. Look for kidney function with the initial worsening of heart failure patients with more rise in serum creatinine can be seen, especially in the first 2 weeks with the initiation of SGLT2 inhibitors, and also can happen with ARNI. So with the continuation of therapy of those patients, there is further improvement of GFR. And don't forget that serum potassium, some patients who are on ARNI, MRA, so hyperkalemia can happen. While the use of MRA decreased hyperkalemia, the risk for hyperkalemia decreased when patients using SGLT2 inhibitors. So SGLT2 inhibitors decrease the risk of MRA-induced hyperkalemia. So to start with all drugs or to start sequential, this slide compare the two approaches, the conventional sequencing to start with ACE inhibitor, titration, then add beta blocker, titration, then MRA, and finally SGLT2 inhibitors, and this can take up to 6 months. While rapid sequence in just 4 weeks to start with, for example, beta blocker if the patient is not congested, with SGLT2 inhibitor, and then after 2 weeks to add ARNI, and within 2 weeks to add MRA with the serum potassium less than 5. This could lead to earlier use of the 4 drugs, even in small doses, and then titration later on. So this decreases the risk for heart failure hospitalization, decrease the risk of mortality, because there is no stable heart failure patients. So patient profile is important when you are considering which drug to start with. Tailoring the drugs according to the patient profile is very important. So look for the heart rate. If it is more than 70, so beta blocker and ivabradine if indicated in patients who are not tolerating beta blocker. Heart rate less than 60, you cannot use beta blocker or ivabradine. Look for serum creatinine and serum potassium. Look for the blood pressure, because you cannot start ARNI, for example, in patients with low blood pressure. So patient profile is very important. But if you look for different patient profiles in this slide, you can see that SGLT2 inhibitors, the only drug which can be given from day one if the patients have an GFR up to 25 with the use of DABA, 20 with the use of IMBA. You can use it earlier without risk for hypotension, without risk for hyperkalemia, single dose, no titration. So this is very important to start with SGLT2 inhibitor in addition. The final 2 slides are related to HFpEF. HFpEF is challenging, not only at the level of diagnosis and also at the level of different phenotypes and different heterogeneity of those patients, because they have a lot of comorbidities. So echocardiography in hypertensive obese patients might be normal ejection fraction and the patient is symptomatic, shortness of breath. NT-proBNP, up to 30% of patients have normal NT-proBNP. Symptoms are non-specific. And finally, you have to estimate LV filling pressure, which could be normal at rest. So with exercise or in the cath lab, you might see a high wedge pressure, which indicates that these patients have HFpEF. And we have many diagnostic algorithms which can be used in the daily practice. However, this is the last American guidelines recommendation for HFpEF. The diuretics should be given to relieve congestion. SGLT2 inhibitors, according to Emperor Preserve It and Deliver study, it's class 2A recommendation, while ARNI, MRA, and angiotensin receptor blockers are considered class 2B recommendation. treatment of hypertension to the target, and correcting any comorbidities are very important. So the take-home message, ladies and gentlemen, ACE inhibitor or ARNI, beta blocker, MRA, J2 inhibitors represent the 4 key foundational therapies. Should be started earlier. Should be started earlier, and within 4 weeks, you have to give the 4 drugs, but patient profile is very important during starting, titration, and the follow-up of patients every 2 weeks. Treatment acts to reduce morbidity and mortality very rapidly if initiated earlier. Thank you for your attention.
شكرا دكتور مجدي اولا في دعوتنا لحضور هذا المؤتمر المتميز، والشكر ايضا الى زملائي في طب القاهره، وايضا احيي تواجد استاذنا استاذ الجيل الدكتور جلال السعيد في هذا اليوم. In your elegant presentation, you highlighted that the SGLT2 inhibitor is one of the important pillars of the management of heart failure. Is any caution should be done as we approaching Ramadan for this particular drug, being has a diuretic effect and also blood pressure lowering effect? Is any caution should we do in Ramadan with this particular drug?
This is a very interesting and challenging question, and I think yesterday Professor Karim Saeed presented a very interesting presentation regarding the how to use the drugs in Ramadan during a long-standing time of hypovolemia, volume depletion, so the cautious use of drugs which could be associated with the risk of diabetic ketoacidosis, for example, in those patients. But at the end, it depends according to patients' age, kidney function, heart failure function status, the use of diuretics, because patients who are using a high dose of diuretics who are at high risk for hypovolemia with the use of SGLT2 inhibitors, I will be very cautiously. But I think it differs from patient to patient. Considering all these variables, you can judge which patients, but I think they are safe. According to the data which was presented yesterday, the number of studies are very small, very limited, observation studies, so we cannot reach to a conclusion. So physician judgment according to the patients is very important to identify which patients should continue the drug during Ramadan or not.
Thank you very much, Professor Magdi, for your illustrative presentation, and I have only 2 small questions. HIF-MERF is still a gray zone, and many fall in it, and the management is sometimes confusing. And the second is worsening heart failure. What shall we do in worsening heart failure?
Worsening heart failure is very common during the journey of treatment of heart failure patients. Patients who are using drugs, but the symptoms are progressive, high level of NT-proBNP, recurrent heart failure hospitalization. This is a very difficult situation. The drug which I have presented, which is according to the Victoria trial, the inclusion criteria of those patients who have worsening heart failure. And the results of this study, it decreased the composite endpoint, but mainly related to heart failure hospitalization, not related to cardiovascular death. So we have to use the vericiguat, starting by 2.5 milligram and titrating up to 10 milligram. I'm actually using it in some patients who responded well, especially when the NT-proBNP is not more than 8,000, they respond well. In advanced heart failure, we need an advanced therapy, LVAD, if the patients can be treated like that.
Thank you. Any questions from the floor?
احنا عندنا بس الوقت
Okay.
مهم قوي.
Okay. So we have to proceed to the next session.
السيشن بس اللي متأجل من امبارح الفالفولار هارت ديزيز احنا هنعمله دلوقتي. السبيكرز افيلبل، اعتقد الدكتور احمد حسن موجود. الشير بيرسون she's coming. دكتور احمد حسن، تشير بيرسونز، دكتور مصطفى، دكتور محمد الرملي. مش اشكال، نبتدي احمد.
Okay, we start. I like to present Professor Ahmed Hassan, challenges in the management of severe aortic stenosis in young adults.
Bismillah ar-Rahman ar-Rahim, dear chairpersons and colleagues. It's my honor to have this talk today. I'm going to talk about the challenges in management of severe aortic stenosis in young adults. And I would like to start with the definition of young adults in the context of aortic stenosis. From the literature related to the valvular aortic stenosis, young adults is usually defined as age between 20 and 65. I'm going to go through the very quick through the etiology and what is the difference between young adults and elderly in aortic stenosis, and then ends with the long life, with a lifelong plan for treatment of such patients. And if you look here, the most common etiologies of isolated aortic valve stenosis is calcific or age-related aortic stenosis and congenital bicuspid aortic valve. Rheumatic heart disease is very unlikely to cause isolated valvular aortic stenosis, and if we look here at the incidence according to age, in the 6th decade we have 6-fold increase in the incidence of aortic stenosis compared to the 5th decade, and the prevalence is almost 3% after the age of 75. And I'm not going through the details of staging. However, we have to know that patient with stage C is asymptomatic patient with severe aortic stenosis, and C1 is with normal ejection fraction, C2 is impaired ejection fraction. The challenge is usually for patient with asymptomatic severe aortic stenosis but with normal ejection fraction, and D is very clear in the guidelines as indication for intervention, and usually have challenges in management of D2 and D3 stages. But what is the difference in young adults with severe aortic stenosis? First, those patients might have severe aortic stenosis but might live a longer life with asymptomatic disease. Is asymptomatic severe aortic stenosis is a benign condition? First of all, you have to consider that many patients has what we call pseudo-asymptomatic disease, which means that the patient is living a sedentary life. He does not do any effort that provoke the symptoms. So we have first to make sure that the patient is symptomatic, and as we looked here, the HA guidelines recommend exercise testing in patient with asymptomatic severe aortic stenosis, but the symptoms could be provoked, and it's important to look at the blood pressure. Hypotensive response is an indication, at a class 2 indication for valve intervention. The disease progression in severe asymptomatic aortic stenosis from a prospective observational study is almost occurred in all patients within 2 to 5 years from the onset of diagnosis to the onset of symptoms. However, we know that in asymptomatic severe aortic stenosis, the rate of sudden cardiac death is very low. But if we looked at some particular subsets of patients with asymptomatic severe aortic stenosis, patients with very severe aortic stenosis, which means that Vmax exceeding 5 meters or 5.5 according to the European, or mean exceeding 60, those patients had almost 6-fold increase in the cardiovascular mortality, and that's why this is a 2 indication for SAVR. And in patients with increased BMB, the odds ratio is 7. So any patient with asymptomatic aortic stenosis with BMB exceeding 3 folds compared to his age and sex matched value for BMB, the odds ratio for any cardiovascular event related to aortic stenosis is 7. and patient with rapid progression, and even patient with decrease in the ejection fraction toward ejection 60 less than 60% in different measurements. All those type of patients has increased events, and surgery might be considered. Not only the conventional assessment in patient aortic stenosis as bare guidelines, we have also some data on the presence, just presence of replacement fibrosis or just extracellular expansion from CMR study showed reduced survival. This data is not enough to be adopted in the guidelines. However, this may highlight the importance of decision making before keeping the patient just for follow-up. What is the next most important thing in the difference between young adults and elderly for patients for aortic stenosis? The etiology. In fact, most of the patients with aortic stenosis in age of less than 50 are bicuspid. In a post-surgery patient study showed that almost 2/3 of patients with the spacement during after surgery was bicuspid aortic valve. And in autopsy study of all different age group, 50% of the valve were bicuspid. We have decision making is very crucial. We have to search for aortopathy and dilated aorta in patient in young adult with aortic stenosis. So we have many different considerations in surgery for aortic stenosis in young adult. First, SAVR is the gold standard for patients younger than 50 years of old. However, as we know, aortic valve replacement per se, regardless the type of valve, whether bioprosthetic or mechanical, leads to reduction in life expectancy. Bioprostheses have the risk of degeneration and reintervention in the future. Mechanical prostheses carry the risk of thrombosis versus bleeding. And if we looked here in the guidelines, mechanical versus biological valve in young adult, the American Heart Association, it's very clear that patients younger than 50, we have to do SAVR. And patients between 50 and 65, which is our group, we might consider mechanical or bioprosthetic. So less than 50, no way for biological valve, except if the patient has contraindication for anticoagulation. Between 50 and 65, we can choose, usually shared decision, mechanical or bioprosthetic. This is more liberal compared to the European guidelines. Patient after 65, bioprosthesis should be considered, and bioprosthesis could be surgical or TAVI. And if we look here at the rate of degeneration at the patient younger, the rate of degeneration is more. If we look here at the patient at the age of 50, you have a rate of degeneration of 20% for reoperation. And if they looked at the patient after 65 years, the rate of structural valve deterioration is only 10% at 20 years. The problem in this data is that this data is usually coming from patients that are highly symptomatic and presented to re-intervention, so it might be underestimating the rate of degeneration in bioprosthetic valve. And if you look here at these graphs, we can see a younger patient between 18 and 64, there is a big difference between the rate of reoperation between bioprosthesis and mechanical prosthesis. And we have also difference between in mortality between patients who had mechanical prosthesis versus bioprosthesis. However, after the age of 65, there is almost identical curve in mortality and reoperation, whether the patient had bioprosthesis or mechanical. However, we have a recent data, maybe slightly different from the old data, that coming from a large registry for valve-in-valve intervention, which is called the VIVID registry, that the median time for presentation for valve-in-valve intervention after surgical bioprosthetic aortic valve replacement was only 9 years. So the durability might be a problem for younger patients with aortic stenosis, and the incidence of structural deterioration may be underestimated from the old data. And this is a very interesting study that published 2018 showed rate of 30% of valvular structural valve deterioration at 6-year follow-up just by echocardiography. وكانت definition increase في المين grade أكتر من 10 or increase في aortic valve regression severity أكتر من 1 grade. ومنهم 11% من التوتال number underwent re-intervention. So that the bioprosthetic valve is better than the TAVI? This is maybe a question, especially في الجروب around 65 of age. وبالتالي أول valve should be chosen very carefully. أقل من 50 years is very clear that we have to choose mechanical. However, ما بين ال 50 لل 65 this is maybe a gray zone, and the shared discussion should be done. And the first valve, if the valve is bioprosthetic, we have to try to be bigger valve, because a smaller valve is a problematic for valve intervention in the future. As you can see here, valve with a stentless valve or with internally mounted leaflet has a higher risk of coronary occlusion if the patient underwent intervention in the future for valve intervention. As you can see here, we are having now increasing rate of valve intervention. Sorry. not working الفيديو للأسف. يعني ده كان examples how can we do a valve intervention in patient presented with degenerated bioprosthesis. كان ال two examples, واحد فيهم for bioprosthetic aortic valve in the aortic position, and the other for a freestyle aortic valve degenerated 8 years after the first surgery. However, the guidelines also mention at the class 2B indication consideration of Ross procedure. Maybe a complex intervention, maybe some anticipating some problems in the future, like degeneration of the homograft and excessive dilatation of the autograft. So it's usually kept for younger patient below 50, and usually anticipated re-intervention is still high. However, what is the position of TAVI for younger patient with aortic stenosis? In fact, patient أقل من 65 سنة we should consider surgical aortic valve replacement. أقل من 50 سنة أكيد mechanical. The gray zone between 50 and 65, it's a biological versus mechanical. Maybe the question here is a biological valve should be surgical or percutaneous valve. As you can see here, the American Heart Association guidelines, the age is very crucial for decision making. For age less than 65, SAVR is a class 1. Between 65 and 80 years, SAVR is class 1, and also TAVI, but transfemoral TAVI only is a class 1. So TAVI in low-risk patient, we have many studies on TAVI in low-risk patient, NOTION, Bartlett 3, Evolute low risk, and some non-randomized trials with a very good reassuring results. However, the mean age in all these trials was between 68 and 79, so we are not talking here about younger patients. So low risk does not mean necessarily younger patients. And as we can see in this graph, there is increasing trend in doing TAVI in patients with low risk. What is the problem of TAVI in younger adults? I'm talking here. I'm talking here about patient between 65 and 60. Maybe we are going to face bicuspid valve more. We are going to have more valve leak with bicuspid valve. The durability is an issue. So, and if we did TAVI for a patient with bicuspid valve and relatively young, we might end with more BVL because of the eccentric expansion of the valve, given the eccentric distribution of calcium in bicuspid aortic valve, more rate of pacemakers, which might affect the long-term follow-up of this patient, خصوصا إنه he is a relatively young patient, and LV ejection fraction may be affected with long-term pacing. And the immediate results, we should not accept paravalvular leak more than mild in younger patients, but we have some reassuring data about the TAVI valve durability. As we looked here from different studies, the rate of reintervention at 7 to 8 years is almost 1% only, and the rate of structural degeneration is variable from 4.2 to 18%. So the data is not that bad, it's reassuring as compared to the recent data on the bioprosthetic surgical valves. but we have a problem of coronary access, and I think this is already discussed in the previous live session. Second, intervention carry high risk of coronary obstruction, and we have to plan this very carefully. We have a good results for SAVR TAVI in TAVI or valve-in-valve in surgical valve. So I will end with this slide that lifetime management is crucial. As we looked here, the younger a patient, the more need for mechanical aortic valves with very low rate of reoperation. However, if I looked here at this patient who started with bioprosthesis in younger age, we have to expect a need for valve intervention within the coming 8 to 10 years. And I will end my conclusions بس ان السافر the gold standard for treatment of patients يعني أصغر من 50 years. Mechanical prosthesis versus bioprosthesis depend usually on a shared decision and different factors. Newer surgical bioprosthetic valve may show greater freedom from structural deterioration. TAVI in low risk patient is an option, but low risk does not mean necessarily young adult. Valve-in-valve procedures are increasing the expanding use of bioprosthetic valves and TAVIs. Thank you.
Thank you very much, Dr. Ahmed. It's only one short question. In patient with aortic stenosis, very young, with calcification, not traumatic, non-congenital, do you think we have to screen lipoprotein little a for those patients and their families?
I'm sorry, ممكن سؤال تاني؟
Would you screen for lipoprotein little a in those patients and their families?
معظم العيانين اللي presented with يعني في age population بنتكلم عليهم بcalcific aortic valve isolated. Usually the etiology is bicuspid aortic valve with accelerated calcification as a part of the natural history of bicuspid valve. I'm not aware of any recommendation to screen patients with lipoprotein little a presented with aortic stenosis in the age of 50 or 60.
Any question from the floor? Because we have another presentation in this session. Any question? Okay, thank you very much. Thank you. Next speaker. Yeah. So we will shift to the cardiomyopathy session. دكتورة أمال، تفضلي يا فندم. دكتور عاطف. Who is the chairpersons of the cardiomyopathy session? دكتور محمد حسن. خليك قاعد.
Good evening. We are now going to attend for the session of cardiomyopathy that we are waiting for. The first presentation will be hypertrophic cardiomyopathy, medical therapy, ablation, or surgery, presented by Dr. Mina Sami.
Good afternoon, dear Chairperson and colleagues. It's a great honor to present in such an elegant meeting. I am very thankful for Professor Dr. Magdi for this chance. So, management approach for patients with hypertrophic cardiomyopathy, we should cover patients with LVOT obstruction, those with mid-cavity obstruction, the non-obstructive, and the atrial arrhythmias, and prevention of sudden cardiac death. For the sake of time, this part is out of scope of this lecture. What I will be discussing today is the LVOT obstruction. So, to start with LVOT obstruction, let's start with the definition. By convention, LVOT obstruction is defined as a peak instantaneous Doppler LV gradient more than or equal to 30 millimeter mercury. But the threshold for invasive treatment is usually considered to be more than or equal to 50 millimeter mercury. So the definition is more than 30, but the threshold to intervene with the patients is more than 50. During management of obstructive hypertrophic cardiomyopathy, the first step is to avoid dehydration, avoid excess alcohol consumption, and weight loss should be encouraged. These are the drug options that can be used in obstructive hypertrophic cardiomyopathy. We can use the non-vasodilating beta blockers, the disopyramide, verapamil, diuretics, and the drugs that can be used for advanced systolic LV dysfunction. Beta blocker trials in obstructive hypertrophic cardiomyopathy are old, starting in the 80s and 90s. And according to this, the most latest guidelines from the ESC in 2014 and AHA 2020 for symptomatic obstructive hypertrophic cardiomyopathy, it's class 1, level of evidence B, to use non-vasodilating beta blockers. If the patient is still symptomatic despite the maximally tolerated dose of beta blockers, the second line is calcium channel blockers, according to both the ESC and also the AHA 2020. The disopyramide, the first paper for disopyramide was in 1982, and it was on 2 patients that there was a reduction in the gradient after 20 minutes of using the disopyramide. And these data were confirmed later in multiple trials, including one in the Journal of American College of Cardiology in 2005. 40 years on, after the first paper with disopyramide, we still don't know how disopyramide really works in hypertrophic cardiomyopathy. Many of us are still concerned, skeptical, and the use of disopyramide is limited. There are some papers to show how the disopyramide works in hypertrophic cardiomyopathy. It might shorten the action potential, it might reduce the cellular arrhythmias, and it reduces the QT dispersion. So, according to these data, the disopyramide is the second line after calcium channel blockers and beta blockers if the patient is still symptomatic in both the ESC and the AHA. When using disopyramide, let's be cautious with the cholinergic side effects, the QTC interval, and if it exceeds 480, we should reduce the dose. Should be avoided in patients with glaucoma and in men with prostatic symptoms, and should be used cautiously in patients prone to atrial fibrillation. We can use low-dose diuretics cautiously to improve the symptoms. And let's move to the most important part of this presentation, the invasive treatment for the LVOT obstruction. We need to discuss the timing for the intervention in this patient. We need to discuss the option, whether surgical myectomy or alcohol septal ablation, and finally, when to do alcohol septal ablation and when to go for surgical myectomy. The timing of invasive intervention, there are no data to support the use of invasive procedures to reduce the LVOT outflow obstruction for patients asymptomatic. The indication is in patients with LVOT obstruction that have symptoms and not any symptoms, who have NYHA class 3 to 4 despite the medical therapy. Or if they have recurrent or exertional syncope, it's a class 2A. This is the recommendation for the American College of Cardiology 2020, that in patients with outflow obstruction that are still symptomatic despite beta blocker, calcium channel blockers, we should refer the patient for septal reduction therapy in any experienced center. So the question, what about the patients that are asymptomatic and have LVOT obstruction, or those who have NYHA class 1 or 2? This is an interesting paper from Cleveland Clinic Experience. They compared to do septal reduction therapy in patients that has class 1 indication, that are NYHA 3 to 4 and are symptomatic and have LVOT obstruction, versus patients that has NYHA 1 or 2 or even asymptomatic and have LVOT or outflow obstruction. As we see, there are most of the patients in the early surgery group are NYHA class 2 or 1, and most of the patients in the patient that have class 1 indication are NYHA 3 or more. Interestingly, the earlier intervention and the earlier surgery for the patients that are NYHA 1 or NYHA class 2 had freedom from the primary composite endpoint that was significantly lower than the later intervention for these patients. What about the options that we have? First, the surgical myectomy. The myectomy is the gold standard. It allows for symptom and gradient improvement that is immediate, consistent, and sometimes permanent. It allows us to deal with the valve and the coronary artery disease, but it requires a skillful surgeon, and it's low risk, particularly in young, and less need for pacemaker compared with the alcohol septal ablation. And this paper shows the sustained benefit of myectomy. The Moro procedure is a rectangular rod that extends distally to the point of the mitral leaflet and below the aortic valve. The main surgical complications are ventricular septal defect, aortic regurgitation, or AV nodal block, but these are supposed to be uncommon in the experienced centers. One of the benefits for the surgery, it allows us to tackle the mitral valve if we need to. We can do mitral valve replacement, we can do realignment of the papillary muscle, we can do partial excision and mobilization of the papillary muscles, and sometimes anterior mitral leaflet plication. What about the alcohol septal ablation? In experienced centers, alcohol septal ablation is selective injection of alcohol into a septal perforator or sometimes other branches of the left anterior descending artery to create a localized septal scar. Has outcomes similar to surgery in terms of gradient reduction and symptom improvement. Let's take some tips and tricks with the alcohol septal ablation. The first question, we should depend on our imaging modality to choose the septal perforator that we will inject the alcohol in. The first imaging that we can use is the myocardial contrast echocardiography, and inject dye and check that which septal perforator would help us in the alcohol septal ablation. We can also depend on the CT angiography guided alcohol septal ablation. How much of alcohol should we inject in the septal perforator? We have the ultra low dose, less than 1 milli. We have the low dose, 1 to 2 milli, and we have the high dose, 2 milli or more. The higher alcohol dose will lead to higher reduction of the peak gradient, but at the same time, it leads to higher occurrence of complete heart block. So what we use is 1 milli of alcohol per 1 centimeter of septum thickness in the target area. This is the amount that we should inject. The third question, while injecting the septal perforator, should we inject fast or should we inject slow? With rapid injection, we could have complete heart block, we could have backspill into the LAD or the other branches, so we should go with the small fractions and slow injection over minutes. What about the incidence of sudden cardiac death and the ICD? Can we depend on the risk models for the developed by the ESCC in the patient after alcohol septal ablation? The answer is yes, we can depend on the risk models of the ESCC after alcohol septal ablation. And the two most points that define the risk of sudden cardiac death are the left ventricular wall thickness, but remember, before the alcohol septal ablation, and the syncope that might occur after the alcohol septal ablation. So we can depend on the model after alcohol septal ablation. After performing alcohol septal ablation, how long should we keep our patients in the hospital? As we see that the complications can occur up to 5 days from the procedure, so hospitalization for patients undergoing alcohol septal ablation should not be less than 5 days. And as we see in the time course for the peak gradient after alcohol septal ablation, the gradient goes down in the beginning, then we start to have septal edema, so the gradient goes up again, and then after 3 weeks with septal shrinkage, the gradient goes down again. So do not repeat alcohol septal ablation very early after the first procedure, and wait for 3 weeks at least to check the peak gradient. What are we targeting from alcohol septal ablation, the long-term outcome? We are targeting to get our gradient, peak gradient, less than 30. Because in patients that the gradient was kept more than 30, this was associated with mortality event. So the target while performing alcohol septal ablation is to achieve a peak gradient less than 30 millimeter mercury. And these are the prerequisites for any center to perform alcohol septal ablation. According to the ESC, you have to have a minimum caseload of 10 alcohol septal ablation procedures per operator per year. Regarding the Americans, you have to have 20 procedures per operator, or for the whole center, 50 procedures per year. These are alternatives that we can use instead of alcohol. We can use the glue, the cyanoacrylate septal ablation. We can use covered stent, but unfortunately the covered stent usually fails because of the collateral formation. We can use also coil embolization. All these are under trials. And the polyvinyl alcohol foam in animal models. The transthoracic percutaneous laser ablation can also be used. However, all these alternative techniques do not have better results in the trials till now than the conventional alcohol septal ablation. Finally, which patient for which procedure, surgery or alcohol septal ablation? The American Heart Association in 2011 and confirmed this in 2020, surgical myectomy is the gold standard, and alcohol septal ablation should be left for the patient that cannot undergo surgery. However, the ESC guidelines in 2014, they have no specific recommendation except if the patient is undergoing another surgery. In this case, you can go for surgery instead of alcohol septal ablation. It is very difficult to answer the question which procedure is better, the alcohol septal ablation or the surgery. Because to answer this question, we need to have a randomized trial, and this randomized trial should look like the trials that compare PCI to CABG. And to have this, it's very difficult in patients with HUCAM because this is a disease with low event rate and it is not achievable to perform this study design. However, this table from the American review for a review of literature that help us to choose when to send the patient for myectomy and when to send the patient for percutaneous alcohol septal ablation. The first point is the site of obstruction. Historically, in early days, surgical myectomy was only for the basal of the septum, but now we used to consider that mid-cavity or apex is an indication for alcohol septal ablation. However, nowadays, surgeons can go to the mid-cavity and do surgeries. The next step is the extent of the hypertrophy. If the hypertrophy is less than 30 millimeter, alcohol septal ablation could be encouraged. However, if it's more than 30 millimeters, you will need a lot of alcohol to inject. That will lead to complications. So, actually, very thin hearts are risky for both alcohol septal ablation and surgery. However, very thick hearts, surgery has the upper hand. However, this is a recent registry that sent the patient for alcohol septal ablation with interventricular septum 16 millimeter or less, and they had very good results. So after the site of obstruction and the extent of hypertrophy, if the patient has any other indication for surgery, if he has mitral valve insufficiency, I need 1 minute.
Just 1 minute.
Okay, if the patient has mitral valve insufficiency, so send him to surgery. Also, if the patient has another indication, like he needs to do coronary artery bypass grafting, if he has aortic valve stenosis, so we will send him to surgery. The patient age. Surgery, unlike alcohol septal ablation leads to a scar. So it is difficult to take an adolescent and do a scar in his heart at young age that will lead to arrhythmias in the future. So if you have adolescent, surgery is better. For adults, it's the same. The hemodynamic success for surgery, it is immediate. For alcohol septal ablation, remember the septal edema, we need to wait at least 3 to 12 months to have the full results, so do not repeat alcohol septal ablation early. Of course, surgery is a more complex procedure than the interventional approach, and finally it depends on the expertise of the center. The need of pacemaker is less with surgery compared to alcohol septal ablation. So my take-home messages: septal reduction surgery is recommended, indicated for symptomatic patients with LVOT obstruction, NIHA class 3 to 4. However, there are recent data that we could have possible benefit for earlier surgical intervention for patients with NIHA 1 and 2. Medical therapy is the first line, including beta blocker and calcium channel blocker at the second line. Do not underuse disopyramide when indicated. Choosing between surgery and ablation, a lot of points should be taken into consideration. However, center expertise comes first. The age of the patient, the septal thickness, association with other indication are other points to consider. Thank you.
Thanks. Excellent presentation as usual, Mina. I have just one comment concerning medical treatment in HCM. Really, حقيقة disopyramide, despite it's not available, data من HCM registries says it's really effective and relatively safe. وحقيقة هو محطوط مع البيتا blocker as a first line. The second thing that we have also another drug, the mavacamten, in the pipeline. Actually, it's started to be approved and وبدأ يستخدم, but relatively was cautious. It's a cardiac myosin inhibitor.
Yes.
وحقيقة there is some risk of heart failure لأن هو بيقلل ال LV function. لكن هو دلوقتي بيستخدم post mark يعني under caution because of the risk of heart failure.
Okay, thank you very much. And we have to proceed to the next speaker, Dr. Mohammed Abdel Ghani from Al-Azhar, with treatment options for secondary mitral regurg.
بسم الله الرحمن الرحيم. السلام عليكم جميعا. دكتور مجدي، شكرا جزيلا على الدعوه الكريمه. دكتور هشام، كل الرويال فاميلي بقى، دكتور حسام، دكتور محمد عبد الغني. انا اسمي محمد عبد الغني، محمد عبد الغني جونيور، مدرس امراض قلب في جامعه الازهر. استاذ دكتور محمد الرملي واستاذ دكتوره وفاء، تحياتي لحضراتكم جميعا. سعيد جدا بوجودي في وسط كوكبه الاساتذه الافاضل. التوبيك طبعا بعتذر عن اللخبطه، بس يعني معلش كان في ريسكيدولينج كده وشويه حاجات فبنعتذر. Shall I stick to English or shall we be casual؟ في حد في الاودينس؟ طيب ماشي اوكي. So التوبيك بتاع النهارده هو treatment options for secondary mitral regurgitation. Mitral regurgitation is quite prevalent among heart failure patients regardless of the phenotype. طبعا the highest prevalence is among patients with heart failure with reduced ejection fraction. لكن الانسيدنس برضه isn't trivial in patients in the other phenotypes of heart failure. You are all aware of the basic mechanism. It's an imbalance between the tethering and the closing forces that control the competence of the mitral valve, and the eventual result of either regional or global LV dysfunction is progressive adverse LV remodeling that leads to mitral regurgitation, and LV dysfunction begets mitral regurgitation, and so on. So the vicious circle goes on, and this vicious circle has been unequivocally linked to impaired outcome. So it's not just a bystander. Mitral regurgitation in heart failure patients is not just a bystander, it's a contributor to the impaired outcome. للأسف مش بس السيفير mitral regurgitation هو اللي associated with worse outcome, but also even moderate mitral regurgitation has been linked to increased mortality. And again, this is not restricted to heart failure with reduced ejection fraction, but also patients with mid-range and preserved ejection fraction are being exposed to the same deleterious effects of secondary MR. المرضى اللي عندهم كمان ischemic heart disease are even more harmed with secondary MR, and this very important study, I would like to attract your attention to this slide. لأن دي كانت study هي observational لكنها كانت large scale، وكان عندهم very meticulous يعني surveillance لل compliance و optimal medical treatment. فالعيانين اللي في الريجستري دي كانوا كلهم quite compliant on heart failure medications. واكتشفنا بالobservations from this study published recently يعني 3 or 4 years in European Heart Journal that the subgroup of patients اللي بتتأثر أشد تأثر بالسكندري MR هم عيانين الانترميديت هارت فيلير، وده على فكرة ليه implications رهيبة هنشوفها دلوقتي. يعني very early in the disease secondary MR is not a very important player, and very late in the natural history of heart failure again secondary MR is not a very important therapeutic target. But in the so-called intermediate heart failure stage, the impact of secondary MR on determining the prognosis is quite important. So to round this off, secondary MR is prevalent among heart failure patients. It increases mortality even when moderate, and intermediate stage of heart failure rather than end stage heart failure is the subgroup of patients or the stage of heart failure where MR plays a very important role. Before proceeding to the therapeutic options, I'd like to highlight this. You are all aware of this dilemma. احنا الخناقة بين الأمريكان وبين الأوروبيين. What defines severe secondary MR? الأمريكان بيقولوا ال cut-off values should be the same for primary as for secondary MR. European guidelines based on very observational data suggest in and the lower effective regurgitant orifice threshold severe MR is already existing. هم بيقولوا ان الأوريفيس مش circular ovoid، وبالتالي البيزا هت underestimate the actual severity، وبيقولوا كمان at even lower severity the prognostic impact is severe. فبيقترحوا ان at a lower threshold we would call MR severe even if it didn't reach the ordinary cutoff values. الامريكان بيقولوا لا، البرايمري زي secondary، and my own يعني impression what I would stick to is this very important compromise. I would go for a cutoff value of 0.3 square centimeter for the يعني effective regurgitant orifice as long as I have other supportive features of severity، أو قدرت بعيني أشوف إن regurgitant orifice مش circular، وده ممكن نحققه باستخدام ال underutilized and underestimated vena contracta area. 3D متاح في كل حتة، نقدر نشوف بالظبط ال regurgitant orifice circular ولا ovoid، وبمنتهى السهولة we can avoid the shortcomings of the assumptions which PISA is based upon. فلو أنا شفت بعناية إن regurgitant orifice ovoid أو not circular أقدر أقيسها، وال cutoff value of 0.4 centimeter square has been validated in several studies. So I would suggest that every single patient with secondary MR we integrate this parameter into our grading scheme. So what are the treatment options for secondary MR? Pharmacological treatment is an established treatment for secondary MR, and there is evidence that ARNI can improve MR severity more effectively than valsartan alone can do from randomized data. And there is also evidence that this reduction in MR with ARNI is sustained up to 2 years with up to 50% reduction in the severity of mitral regurgitation. So the frequency of patients with moderate to severe MR can be halved by the effective use of ARNI, and this reduction is sustained up to 2 years. What about CRT? CRT has been unequivocally effective in reducing MR, and when patients are being responsive to CRT and MR goes down, these responder patients have a significantly improved outcome up to 5 years after CRT implantation. Is there a role for mitral valve surgery in secondary MR? الحقيقة ان most recent European guidelines بتدي class 1 recommendation لو العيان كده هيعمل كابج، وبتدي class 2B recommendation لو العيان هيدخل يعمل جراحة للميترال alone. ورغم ان there is a class 1 recommendation for mitral valve surgery لو البيشنت by all means هي undergo cabbage، الا ان الحقيقه ان مفيش robust evidence to date to prove that patients who undergo mitral valve surgery combined with cabbage would have an improved outcome. Mechanistically ايوه كتير جدا منهم بيبقى عندهم immediate reduction in MR severity، لكن in the longer term there is no robust or concrete evidence that if you combine mitral valve surgery with cabbage, you will improve the prognosis of these patients. وعشان كده الدايليما دي يعني mitral regurgitation prevalence وحتى لو moderate بيمبير البروجنوزز، عايزين نصلحه، طب لما نيجي نصلحه ما بيصلحش البروجنوز، ايه بقى الحكايه؟ فطبعا في theories كتيره to explain this, and one simple theory of them is that mitral repair is not always durable، فبيبقى فيه high rate of recurrence، ولو انت هربت من الحكايه دي وعملت mitral valve replacement this is in itself a risk factor for progressive LV deterioration. From this the idea of a less invasive mitral valve repair strategy has arisen, and يعني once we consider TER or transcatheter edge-to-edge repair in secondary MR لازم طبعا نتكلم عن الجيم تشينجر landmark trial, the COAPT trial. COAPT trial is a unique design, very smart one. Can be include patients with really severe MR, يا إما fulfilling all the criteria or combining at least as much as possible of the features that suggest that MR is really severe, بشرط إن ال LV deterioration hasn't reached its end stage. يعني extreme MR and intermediate stage LV remodeling. More importantly, this study excluded patients with end stage or advanced RV dysfunction and pulmonary hypertension. يعني بنجيب العيانين اللي وصلوا لسيفير MR بس لسه الفنتريكلز فيهم أمل. باختصار. COAPT showed that heart failure hospitalizations, mortality can be significantly reduced by mitral clip as compared to optimal medical therapy alone, with a very low risk of device-related complications, and this has been even more documented up to 5 years with a very recently presented data this year by Greystone that this very beneficial effect of mitral clip on patients with heart failure and secondary MR is sustained up to 5 years after the procedure. مضطرين نتكلم عن الميترا اف ار زي ما حضراتكم عارفين الخناقه الكبيره. COAPT is very يعني encouraging, وميترا اف ار which is another randomized trial showed more or less opposite result. ما فيش اي advantage للميترا clip as compared to medical treatment alone in any of the endpoints of the study. Why is that? Why is that? أنا عارف إن حضراتكم aware of this, but I would like to highlight very few points. As you can see, and as I've just mentioned, once you apply mitral clip to a patient with end-stage LV disease, it doesn't help anymore. It's too late already. So as you can see here, LV end-systolic volume index was significantly less in COAPT patients as compared with mitra FR patients, while the severity of MR was on the other hand, was more severe in patients with COAPT. باختصار شديد لو انت هتسيستماتيكلي اي عيان with heart failure and secondary MR هتعمل له mitral clip, you will end up with a result similar to mitra FR. and if you are selective you will end up with a result similar to COAPT. باختصار زي ما حضراتكم شايفين 614 عيان في COAPT، كم عيان سكريند initially 1600، يعني حوالي الثلث او اكثر قليلا. بينما في المترا اف ار almost يعني it's almost an all comer registry، so اي عيان هارت فيلير بسكندري ام ار بندخله. ف the name of the game is to be selective and then you will end up with a result similar to COAPT. You will have a significant reduction in heart failure hospitalization and mortality. ومن هنا جاء الكونسيبت بتاع COAPT criteria ان احنا what is the indication for TER in secondary MR. The indications are the COAPT criteria. So if you stick to the indications and contraindications, I mean the inclusion and the exclusion criteria of COAPT, you will eventually end up with a result favorable as seen in COAPT trial. وباختصار عشان summarize the previous slide which is very busy. باختصار what are the predictors of poor response to TER in secondary MR when it's too late? When it's too late, then it's too late. Advanced heart failure with very severe symptoms, very high elevation of biomarkers. If there is advanced RV disease, advanced pulmonary hypertension, severe TR, and of course if there is advanced comorbidity that would preclude the benefit of any intervention. وبالتالي لما هنقول ازاي نختار العيانين بتوعنا يعملوا MitraClip for secondary MR, we should answer two questions. Is MR a therapeutic target in this given patient? وبعد ما قرر كده في بقى جزء تاني تكنيكال زي في التافي بالظبط. التافي انديكيتد ايوه، طب العيان اناتوميكلي suitable دي قصه تانيه. فاتس the same. Is it indicated? This is dictated by the severity of MR balanced against the severity of LV and RV failure. So there is a sweet spot, the so-called disproportionate MR. MR is really severe and LV is not in the stage yet. At this spot, you will have a result similar to COAPT. And the other question is a pure anatomical and mechanistic question that is basically determined based on a dedicated and meticulous assessment of the mitral valve complex. طبعا زي ما حضراتكم عارفين basically using 3D TEE والبارامترز كتيره ويعني يضيق المجال ان احنا ندرس الحاجات دي. بس the same concept applies to almost all advanced valve interventions. You need of course to revise twice if the intervention is indicated, and after you make sure that it's indicated, then you proceed to whether it's feasible or not, technically, anatomically. So TAVI is indicated. Is the anatomy suitable? Mitral valvuloplasty is indicated. Is the valve anatomy suitable? Is there is bicommissural fusion? Will calcium قليل? And so on. This applies to almost all valvular interventions. The good news is that يعني الاناتومي اللي احنا نعمل له يعني we can address with MitraClip is becoming more and more complex thanks to the advancements in the technology. طبعا الميترا هو مش البلاتفورم الوحيد المتاح للتي ار، لكنه طبعا the most widely used worldwide. في اكثر من 100,000 implantations worldwide, and there is to date like 4 generations of this device. The most widely used worldwide is the 3rd generation with 2 models kind of speaking. اظن نص دقيقة. So the 4th generation is upcoming, can address even larger regurgitant orifices with lower number of clips. ودي نقطة أنا محبطة لازم أقولها لحضراتكم، إن في الكوابت وفي الميترا اف ار the average number of clips per patient is 1.6. To achieve good results in the MitraClip program, you need to have a backup clip for almost every patient. So you will need it in 50% of cases. With the new generation MitraClip, you may address larger regurgitation orifices with lower number of clips. طبعا the Pascal system is another option with less robust evidence. And my take-home message is that the most established treatment option for secondary MR is the pill, is the drugs, is the optimal medical treatment. Of course, if the patient is indicated for CRT, it's an important add-on. But if MR persists beyond this and it's still symptomatic, then one can proceed to other interventional options as we have mentioned. أنا محتاج أوري صورة اللي هي التيك هوم. So this take home message from the very elegant يعني consensus document from the Heart Failure Association of the ESC summarizes it all, and it highlights that there are multiple options: optimal medical treatment, CRT, surgery, TEER, combination of these, and from this you can appreciate how important it is to address these patients in a multidisciplinary manner. And thank you very much for your attention.
Thanks, Dr. Mohammed, for this excellent presentation. I think you have nicely demonstrated the key for benefit from mitral clip is the selection. You should select patients with disproportionate MR that have severe MR in proportionate to the degree of LV remodeling in order to have benefit. So any questions from the floor? So for the sake of time, thank you, Dr. Mohammed. And Dr. Mohammed, Father Mohammed.
دكتور محمد، الحقيقه بهنيك، انا يعني فخور جدا بيك وفخور ان احنا يعني بنحمل نفس الاسم. المحاضره صحيح جميله جدا وغطت الموضوع يعني كما لم يغطى من قبل. secondary mitral regurgitation ده حاجه مهمه جدا بنشوفها كل يوم in our daily practice. mitral clip بتتعمل في مصر تكلفه غاليه جدا. امتى نبعت العيان؟ انا في كتير ناس بيسالوني نعمل ده بالتكلفه الغاليه دي، هي في ناس قادرين يعني. انا بقعد احتار الحقيقه، ما بقاش عارف الاجابه الصحيحه. فاظن ان احنا محتاجين فعلا نعمل كرايتيريا تناسب مصر، تناسب ظروفنا الاقتصاديه، مين اللي نبعت العيان وايه السكسس كرايتيريا، مين اللي اقول ان العيان ده فعلا استفاد او ما استفادش. مره ثانيه بهنيك، شكرا جزيلا.
شكرا فندم، شكرا جزيلا.
So it's a great pleasure for me to introduce my dear professor, Dr. Magdi Abdelhamid. He will highlight how to suspect and detect ATTR cardiac amyloidosis.
Thank you, Mr. Chairman. Cardiac amyloidosis, as we know, is a very challenging topic. So when to suspect and how to investigate for amyloidosis. This is a nice slide. What's amyloidosis? It's from Latin amylum, which means starch. Amyloidosis is a protein binding disorder. Can be diagnosed histologically. We know the staining with Congo red stain. It is systemic disease, as we know, and it means deposition of amyloid in soft tissues, visceral organs, peripheral nervous system. So it's a systemic life-threatening disease characterized by TTR fibril deposition in organs and tissues. The diagnosis is challenging. It might take up to 2 or 3 years to reach to proper diagnosis if you didn't suspect it from the start. So delayed diagnosis is common, and it has a heterogeneous presentation, as we'll see later. 10% of elderly patients with HFpEF might have amyloidosis, which can explain the symptoms of heart failure with preserved ejection fraction. And it should be suspected in any patient with heart failure and preserved ejection fraction. What is meant by ATTR? ATTR transthyretin amyloidosis. Transthyretin, a protein transport carrier for thyroid hormone T3 and T4. So this is the name of THY coming from thyroid hormones. Retinol, the retin of transthyretin. So transthyretin is transports, a protein transports thyroxine and retinol. We have two major types of amyloidosis. AL amyloidosis, which is a mainly bone marrow disorder, with abnormal immunoglobulins leading to light chain formations, misfolding to form amyloidosis fibrils. While the ATTR, which is transthyretin amyloidosis, it is overproduction of these proteins from the liver and dissociation of transthyretin, misfolding, and finally formation of amyloidosis fibrils. So interestingly, what is the fate of the misfolded TTR? Once it's formed, it is not able to be metabolized. So it forms fibrils, which also not be able to metabolize to form amyloid, to be deposited later extracellular. GIT, peripheral nerves, cardiac, and ocular amyloidosis. So the AL amyloidosis, it is a primary amyloidosis, which is a bone marrow disorder, and the transthyretin or ATTR, which might be hereditary form or the age concordant form, which is wild type ATTR. So when to screen for ATTR cardiomyopathy in patients having heart failure with preserved ejection fraction, unexplained left ventricular hypertrophy over the age of 65 in men or 70 in women. And red flags, in addition to unexplained LVH, are the criteria which might be an earlier alarm to screen for amyloidosis. So HFpEF, aortic stenosis above the age of 65, hypotension or normotensive if previously hypertensive patients cannot tolerate antihypertensive drugs that was used previously. So intolerance to the drugs with sometimes hypotension, presyncope, this may an earlier manifestations of amyloidosis. Peripheral polyneuropathy, kidney affection, skin bruising, bilateral carpal tunnel syndrome, commonly seen, ruptured biceps tendon. So musculoskeletal, neurological manifestations, all this can be considered. And this is to summarize these red flags: cardiac manifestations, patients having fatigue, HFpEF, family history of heart failure, abnormal ECG, atrial fibrillation, conduction defects, discrepancy between the QRS voltage in the ECG and LV mass, imaging, as we'll see later, by echo, increased wall thickness, grade 2 or worse diastolic dysfunction, abnormal GLS, diffuse subendocardial or transmural late gadolinium enhancement on cardiac MRI, and persistent low level of troponin elevation. Patients having mild elevation of troponin and LVH could be a diagnostic criteria for amyloidosis, and high NT-proBNP also can be seen. If you have one of these criteria like bilateral carpal tunnel syndrome, lumbar cervical spinal stenosis, spontaneous biceps tendon rupture, hip or knee replacement, peripheral neuropathy, family history of neuropathy, autonomic dysfunction, orthostatic hypotension, very common sign to be seen in those patients, incontinence, erectile dysfunction, and nephrotic syndrome. So these are important extracardiac manifestations. The difference between the hereditary type and the wild type, the age limits above 20 years, the onset of hereditary type, above 70 in the wild type, the extracardiac manifestations, and both have the same HFpEF, arrhythmias, atrial fibrillation, conduction defects, etc., bilateral carpal tunnel syndrome. The median survival 2 to 5 years in the hereditary type and 4 years in the wild type. So the diagnosis delay, very interestingly, it might reach up to 3 years to diagnose the hereditary type, and you might take 2 years to diagnose the wild type. Again, HFpEF, bilateral carpal tunnel syndrome, lumbar spinal stenosis, hip knee degenerative disease, all these criteria are suggestive of the wild type ATTR. So this is interesting ECG, which you can appreciate the low voltage in spite of patients having LV mass, poor airway progression in the precordial leads, a pseudo-infarct pattern, and different arrhythmias like atrial fibrillation, AV block, and the echo, increased wall thickness, diffuse cardiac hypertrophy, diastolic dysfunction by atrial enlargement, low GLS strained bispecific tracking with apical sparing. So all these echocardiographic criteria are diagnostic for cardiac amyloidosis. So we have to look for this criteria if you have patients suspected to be having amyloidosis. So now you have HFpEF, for example, you have red flags like bilateral carpal tunnel syndrome, you have unexplained LVH, so you have some positive criteria which might indicate that these patients have cardiac amyloidosis. What can we do? What further tests? So we have to exclude AL amyloidosis first. Then identification of the amyloid deposits by histology or non-invasive imaging tools. And finally, is it hereditary or wild type? So TTR gene sequencing to determine the presence of the hereditary form of ATTR. Again, LVH, HFpEF, increased wall thickness, we need non-invasive diagnostic approach after excluding AL amyloidosis. The hereditary type usually have neuropathy, family history positive, carpal tunnel syndrome, autonomic dysfunction, unexplained weight loss, different arrhythmias as we mentioned, renal affection. And this is interesting slide which can summarize that multidisciplinary approach, multidisciplinary management strategy, diagnosis for patients. You have to do a multidisciplinary collaboration with neurologists, general surgeons who see patients with bilateral carpal tunnel syndrome and he doesn't know that these patients have amyloidosis. So don't forget that polyneuropathy, musculoskeletal affection, autonomic dysfunction, all these criteria in patients have LVH or heart failure with preserved ejection fraction might indicate cardiac amyloidosis. So to rule out the AL amyloidosis, you need to know serum free light chain levels, serum and urine immunofixation electrophoresis. If positive, which indicates AL amyloidosis, so send your patients to hematologist, and then do bone scintigraphy using technetium-99 pyrophosphate scan. And according to the myocardial uptake at different grades, if no cardiac uptake, this is 0. The test is excluding cardiac amyloidosis. Mild uptake less than the bone, grade 1, moderate uptake equal to the bone uptake, grade 2, high uptake. So grade 2 and 3 are considered highly suggestive of amyloidosis. So you need to do your further workup to reach to the proper diagnosis. While grade 0 and 1 most probably might be not diagnostic for doing other investigations. So grade 0, as you look, no myocardial uptake at all. Grade 1, grade 2, 3, which are proportional to the diagnosis of cardiac amyloidosis. Again, the red flags, which are considered an alarm to screen for cardiac amyloidosis, echocardiography for patients have LVH, pericardial effusion, decreased GLS with apical sparing. So this is the early investigation which can be done. And then CMR looking for the transmural affection, focal patchy disease, a sensitivity of 88, a specificity 90% for diagnosis of ATTR. So this diagnostic algorithm is very important, very, very important. based on symptoms and signs suggestive of amyloidosis, ECG like low voltage, pseudo-infarct pattern, CMR and echo are suggestive of amyloidosis. Technetium-99, pyrophosphate, scintigraphy, point scintigraphy with SPECT. And from the start, we did screening, serum-free light chain quantification, serum and urine immunofixation to rule out AL amyloidosis. And according to the results of all these investigations, you will consider whether the patient having cardiac amyloidosis or not. So if scintigraphy, for example, is grade 0, hematological test is negative, so AL-ATTR amyloidosis unlikely. But if you have by point scintigraphy grade 1 to 3 and the hematological tests are negative, no AL amyloidosis. If it is grade 2 to 3 point scintigraphy, so cardiac amyloidosis is most likely diagnosis. And then we will do TTR genetic test to see whether it is a hereditary type or it is wild type. If the point scintigraphy is grade 1, so we need histological diagnosis. We need biopsy to diagnose those patients. If the scintigraphy is grade 0, hematology is positive, so AL amyloidosis. If CMR negative, so there is no cardiac amyloidosis. CMR positive or inconclusive, we need biopsy. We need tissue diagnosis by doing biopsy. Scintigraphy grade 1 to 3, hematology positive, so also you need histological diagnosis. So this is a very demonstrative algorithm how to reach to proper diagnosis. And this is the 2022 ACC guidelines for management of in the heart failure, that they recommend to screen for amyloidosis in patients with heart failure and preserved ejection fraction. And sometimes in 12% in patients who will undergo TAVI, they have amyloidosis. And it was described that many patients who were subjected to TAVI still have heart failure with preserved ejection fraction. And لا ده مش معايا انا بقى. لا ده ما ينفعش. نمنا من الكلام ده. So we have to consider according to the guidelines to diagnose amyloidosis in HFpEF patients. And finally, now we have a treatment. So the awareness for amyloidosis started in the last 3 or 5 years once we have a definitive treatment for those patients. Because in the past we did not have, we have liver transplantation, cardiac transplantation, but now we have drugs which might act earlier to stabilize the ATTR, to prevent it to be disfolded and form the amyloids, and this is the tafamidis, and other mechanisms of action for other drugs. But tafamidis, which is available now, was studied in the ATTR-ACT study in patients having cardiac amyloidosis, and the use of tafamidis was associated with reductions in all-cause mortality and the cardiovascular related hospitalization. So this is a great achievement in the last few years for treatment of those patients. If you look for the all-cause mortality, definitely compared with placebo, it is better. And if you look for 6-minute walk test, it improved in patients who have given tafamidis. Quality of life in those population in terms of Kansas City Cardiomyopathy Questionnaire improved markedly. So at the end, cardiac amyloidosis is present. Please don't forget that when you have heart failure with preserved ejection fraction in elderly patients having some red flags to suspect amyloidosis, LVH unexplained, and then you have a battery of investigations to reach the diagnosis, non-invasive imaging tools. Finally, you might need biopsy to reach to the proper diagnosis. And this is a very interesting statement for Ronald Whittle, one of the authors for amyloidosis. He said, when I give talks on cardiac amyloidosis, I tell cardiologists and internists, if you have not seen a patient with amyloidosis in your practice in the last year, it is not because it was not there, it's because you missed it. So amyloidosis is not uncommon. It can be seen in the practice, so we have to diagnose it earlier. Thank you for your attention. عايز بس اقول طبعا ان احنا في القصر العيني دلوقتي بنعتبر يعني سنتر اوف اكسلنس في كاردياك اميلودوزيس. البروجكت اللي واخدينه انترناشونال او جلوبال فور 3 years to screen patients for cardiac amyloidosis. عندنا في اخر شهرين number of patients who were investigated. We are doing the investigations free, starting from the hematological test. بروفيسور امال رزق طبعا هي she is responsible عن اللابوراتوري ورك اب، وبعدين بنبعت العيان يعمل بون سنتجرافي دكتور عادل علام، وبعدين بنبعت العيان يعمل CMR عند دكتور عبد الله الاغا، وعندنا التيم بقى طبعا الدكتوره غاده والدكتور كريم، يعني مش عايز انسى حد من التيم اللي موجود اللي بيشوف العيان والانفستيجيشنز. ودي طبعا حاجه يعني موجوده في القصر العيني دلوقتي، فبنعتبر من السنترز، وابتدى يبقى في ريفيرال من بروفيسورز في other institutions لما عرفوا ان احنا running this important project.
Thank you very much دكتور مجدي. وسعيد ان في سنتر دلوقتي موجود نقدر نعمل له ريفيرال. حتى الجايد لاينز زي ما حضرتك وريتنا كده كلها مبنيه على السسبشن. We have to suspect. We have to suspect when we have red flags. لكن الاويرنس انا شايف ان هي اقل بكتير جدا من اللي بيتقال. فايه راي حضرتك؟
الاويرنس بيجي من ال continuous medical education. احنا we have to the same that we are presenting when to screen, when to suspect, when to send your patients, the diagnostic algorithm. So I think it needs an effort, a continuous medical education. And for our young generations, our fellows, this is very important because they are seeing patients and don't think that this HFpEF it is due to a curable disease like amyloidosis. وباي ذا واي حد يسال يقول طب ما نشخص amyloidosis هنجيب له علاج very 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 expensive drug. لا دلوقتي الحقيقه الشركه وانس ان في عيان يبقى دايجنوز هي بتجيب له الدواء، لان عاملين هم يعني كولابوريشن كده بيقدروا يوفروا للعيان الدواء في المراحل الحاليه. يعني
شاريتي ولا كولابوريشن؟
يعني ايه شاريتي يعني
which
is good.
شكرا جزيلا دكتور مجدي. Any questions from our professors? Okay, thank you very much, and we have to move to the next session. Thank you.
بقول لك
احنا will continue the sessions now. We'll be moving to Boehringer Symposium. I'm glad to have Professor عمرو معايا co-chairman وبروفيسور حسام الحصري. We will be moving to the first presentation, the title of which is Guardians Across Heart Failure Spectrum. وطبعا غني عن التعريف بروفيسور حسام أنديل أستاذ ورئيس قسم القلب السابق will be our speaker. اتفضل بروفيسور حسام.
مساء الخير على حضراتكم. أنا مش هقول محاضرة، أنا جاي أستمتع معاكم. وأنا طبعا براقب وبشوف المحاضرات على مدى اليومين بتوع المؤتمر، ولازم أشكر أخويا العزيز الأستاذ دكتور مجدي عبد الحميد وكل الأساتذة القسم على حاجة أنا شايفها إن هي قيمة كبيرة جدا، إن إحنا نجتمع يومين في السنة ونستعرض العلم اللي إحنا يا ابني لسه ما في الأول. اوعى تحط لي تايمر ولا الكلام ده. في حد من بوهرينجر موجود هنا؟ بوهرينجر. فين بوهرينجر؟ تمام. هاي. فأنا شايف إن هي فرصة كويسة إن أنا أحكي لكم على بعض الحاجات، ومن وسطها إن إحنا هنحط هل الصوت بتاع الراجل ده طالع؟
فنصحك احد الاساتذه المشهورين
احد الاساتذه المشهورين في الوقت ده في اسكندريه وما زال نصحني بان انا ماليش علاج لان المكان ضيق.
الراجل اللي انتوا شفتوه ده قصه ستوري، انا مش هاخد وقت فيها دلوقتي، لكن لو المحاضره وقتها سمح هقدر ان انا اديكم تفاصيل عنها. أنا عايز أسألك أو أسأل اللي حاضرين، أنت فاكر أي محاضرة سمعتها السنة اللي فاتت؟ طب الشهر اللي فات؟ طب امبارح؟ غالبا هتلاقي، ولا إيه يا حسن؟ أنت هتفتكر إن الدكتور مجدي يعقوب كان امبارح موجود، فهتفتكر الإيفنت المؤتمر بتاعنا اللي كان فيه الدكتور مجدي يعقوب. أنا لما هقول محاضرة على الهارت فيلير وانتوا الديفينيشن محطوط، وانا سمعت طبعا زملاء من القسم عندنا اتكلموا على الموليكيول ده. في رايي ان ده من اهم الادفانسز واهم الموليكيولز اللي طلعت في الطب يمكن في ال20 سنه اللي فاتت. لكن عايز اقول لزملائي اللي قاعدين ورا اللي انا ما بيجيليش فرصه كتيره ان انا اتكلم معاهم، انا لما دخلت اسم القلب الكلام ده بقاله رفاع عارفه بقالنا سنين طويله. اما الناس عرفوا ان انا جالي نيابه كارديولوجي بقيت احس ان انا صعبان عليهم، ما بقيتش فاهم هو ايه الحكايه. فلما دخلت الاسم، الكلام ده بكلمكم على سنه 81، اول يوم يعني ليا دخلت على المرور بتاع الدكتور عبد العزيز الشريف. كانت الدكتوره وفاء هي يعني موجوده كنايبه في الاسم، ومعها الدكتور حسن الطوخي والدكتور شريف الدجوي والدكتور ايمن قداح. فانا طبعا ما اعرفش ايه يعني ايه المشكله، ما انا هخش ايه يعني المرور عادي يعني. فطبعا شفت الهيبه بتاع الاسم وشفت المرور، وعشان اقرب لكم الموضوع واحد من زملائي برضو جه بعديه دخل المرور بتاع الدكتور عبد العزيز الشريف بعد ما قعد 3 شهور يجرب نفسه، وبعدين بعد المرور قال له انت لازم تنزل سنه ثالثه. انا مش هقول لكم مين لان هو ما كملش في الاسم. قال له انت لازم تنزل ايه؟ سنه ثالثه. فراح جبس رجله وعشان ياخد اجازه 6 اشهر وما يمرش تاني. فاللي انا عايز اقوله هنا ان الاسم بتاعنا ده اسم غير عادي، اسم بيعلمك، اسم بينشفك. ناشف تبقى ناشف تقدر تقف في اي موقف. انت ما كنتش تعرف تبص في عين الدكتور عبد العزيز الشريف، روحوا بصوا في الصوره كده اللي قدام مكتب رئيس القسم، كنتش تعرف تحط عينك في عينه. ولما يقول لك ازيك يا دكتور تبقى فرحان قوي، مش باسمك ازيك يا دكتور، يا خبر ابيض. لما سافرت بقى امريكا لقيت رئيس القسم انتوني دي ماريا ويقول له يا توني، فعرفت انه احنا لنا طباع وهم ليهم طباع. انت هنا بتستمد يعني كيان وقوه من وجودك في اسم زي اسم القلب. انت لازم تبقى عارف ان من اكبر النعم عليك ان انت جيت في اسم زي الاسم ده. الوقت انا مش عايزه يسرقنا، انما من اجمل الحاجات ان فيه دلوقتي ديفينيشنز واضحه للهارت فيلير. الديفينيشن ده معمول مش بجي ال اس، مش بالجلوبال بتدن شورتنج. فين محمد عادل؟ معمول بالايجكشن فراكشن. ده معناه ان الايجكشن فراكشن هو الحاجه البراكتيكال اللي بنقدر نقسم بيها، مش معمول بالان تي برو بي ام بي. ولا ايه يا دكتور مجدي؟ الديفينيشن ده ما اتعملش ببايو ماركر، اتعمل بالايجكشن فراكشن. وفي رايي ان ده فيري سمارت ديفينيشن، لانه بيه قدرنا نصنف العيانين. انا مش هضيع وقت كتير في ده، لكن انت في الهارت فيلير ليك اهداف واضحه. من اهم الجولز ان انت تمنع الهوسبيتاليزيشن فور هارت فيلير، ان انت تمنع دي هيطلع هنا ان انت زي ما انتم شايفين كده prevent او relieve symptoms, improve quality of life, increase functional capacity. لكن الحاجه اهم حاجه ان انت improve survival. انا كنت بتكلم مع الاستاذ دكتور هشام صلاح والاستاذ دكتور مجدي عبد الحميد عشان افتكر حاجه انا عشتها شخصيا، انك لما تدي دواء للعيان بتاع الهارت فيلير ده تحسن السرفايفل. يا خبر ابيض. وافتكرت طبعا اول دواء واول استادي اللي هي كونسنسس ستادي، دي كانت 87. ده التاريخ اللي انا اول مره رحت فيه امريكا، وكان الابريل ده ساعتها ثوره في الطب. انا فاكر اما الكابتوبريل طلع كان الدكتور عبد العزيز الشريف يقول لك العيان بيفرح لما تحس انه انبسط لما خد الدواء ده. You cannot imagine يعني ايه عيان عنده هارت فيلير قبل ما تظهر الادويه دي. The patient was miserable. وبرضه ما انساش عيان كان عنده 27 سنه وكان عنده فيرال مايكاردايتس، وكانت الرعايه دكتور وفاء فاكره الرعايه كانت في الاوضه اللي احنا بناخد فيها الدرس، مش في الرعايه وكانت هي 4-5 سراير. ومره انا فاكر واحد من دكاتره الامتياز عيان ارستد وانا وهو بس اللي في القاعه بالليل، سابني وطلع يجري جري. وساعتها انا طبعا ما زعلتش، انما عرفت ان نيابه الكارديولوجي دي نيابه صعبه مش اي حد يخش فيها. لكن القصه اللي انا عايز اقولها لكم ان الشاب اللي عنده 27 سنه الفيرال مايكاردايتس ده جه قال لي الدكتور فلان اللي هو استاذ كبير في القسم قال لي انت هتموت. اثر فيا جدا، قال لي انت هتموت. وفعلا العيان ده دايد في جوه الفتره اللي هو كان فيها جوه المستشفى. افتكر بقى المثل ده بعيان تاني انا بعالجه دلوقتي، جاله dilated cardiomyopathy post viral او whatever، والعيان ده بقى له اكتر من 10 سنين بعالجه، وجالي من حوالي سنه وهو خلاص يعني سنه دلوقتي كان 27-28 سنه، وقال لي انا عايز اتجوز يا دكتور. جايب معاه الست اللي هو هيرتبط بيها، وجم قعدوا معايا وقال لي ايه رايك يا دكتور نتجوز ولا لا؟ موقف من اصعب ما يمكن. فانا قلت له يعني قلت لهم اتجوزوا. فالمهم هو راح عمره من مثلا 2-3 وجاله فايرال انفكشن جامد جدا والهارت فيلير ديتوريتد، وبعدين لقيته جاي لي تاني بيقول لي انا يا دكتور مش قادر يعني حياتي الزوجيه فيها مشكله. فالهارت فيلير is a disease that is going to be part of you وانت بتشتغل، وانت لازم تعتبر نفسك محظوظ جدا انك عايش في فتره فيها الادويه دي. فان انت النهارده بقى في دواء on top of all other medications اللي انتوا كلكم عارفينها، يعني انتوا عارفين دايوريتكس مالهاش قيمه، لكن بقى في 4 pillars هنا. ده بيوري انه الهارت فيلير مع
preserved ejection fraction بيزيد، مش بس ان هو موجود بيزيد. لكن هنا انا عايز اقول لكم I believe empagliflozin اللي هو Jardiance is among 5 most important drugs in medicine that changed clinical practice in last 20 years.
نجاوب؟
Yes, no. نعم؟
نجاوب؟
يا ريت.
طيب مين اللي شايف يس نمبر 1 يرفع ايده؟ طيب اللي شايف نو يرفع ايده بس يطلع بره القاعه بعدها. هو انت حضرتك مسهل السؤال لان حاطط فيه 5 most important.
طبعا.
انا بتهيألي انه يمكن even from the 3 most important.
Is the most important.
One of the most important.
انا ما حبيتش اقول ان هو is the most.
بس very nice question. بس definitely في شبه consensus انه number 1.
يكفي ان احنا نبقى عارفين قيمه كل مولكيول. خليني برضو احيي الاستاذ دكتور جلال السعيد واقول انه وجوده في حياتنا من النعم الكبيره. انا واحد زي الاستاذ دكتور جلال تاريخ وانا كنت لسه بتكلم مع الدكتور مجدي اختلاف الدكتور جلال عن بقيه الاساتذه وكلهم عظماء ان هو تحس ان هو بيحب الاسم. النهارده في الميتنج بتاع الاسم الساعه 1 وشويه وهو موجود وقاعد في الاسم، ودي حاجه احنا يعني بنشكر ربنا عليها، ان هو انك بس لما تشوفه تشعر بالامان. انا شخصيا انا بكلمكم عن نفسي لما بشوفه بحس بالسعاده والامان ان هو موجود. وهو الحقيقه السبب اللي خلى الدكتور مجدي يعقوب يجي امبارح، وهو اللي انت هتفتكر ان المؤتمر اللي جاي فيه الدكتور مجدي يعقوب، انما ما عملنا 50 مؤتمر حد فيكم هيفتكر حاجه؟ لا. ففي حاجات بتبقى لا. وبعدين خليني برضه اقول الدكتور استاذ يعني سير مجدي يعقوب هو واحد من الناس اللي غيروا الفكر في جراحه القلب في العالم بسبب ان هو بقى بايونير في الكاردياك ترانسبلانتيشن، وخصوصا في الاطفال، وخصوصا كمان انه دخل البيزك ساينس. وانتوا شفتوا المحاضره بتاع امبارح. فان انت لما الدكتور جلال سافر وشاف الناس اللي هم بيعملوا العلم وقعد معاهم الدنيا اتغيرت. فان انت تبقى جزء من الكيان ده وان انت تبقى شايف اللي بيحصل قدامك ده اي ثينك ان هو بيغير شخصيتك تماما. خلينا برضو عشان نخش في ال عرفنا ان في 4 بيلرز بيقوم عليهم التريتمنت اوف هارت فيلير. يعني ايه 4 بيلرز؟ يعني لو حضرتك ما كتبتش واحد من الادويه دي يبقى انت عندك مال براكتس. طب ايه قيمه كل واحد من دول في الهارت فيلير تريتمنت؟ هنشوفه في السلايدز اللي جايه. لو جينا هنا نبص على الهارت فيلير ويز بريزيرفد ايجكشن فراكشن قبل ظهور الدواء اللي هو الجارديانس او الامباجليفلوزن كان كومبليتلي nothing، كلها حاجات اظبط البلاد بريشر ودي دايريتكس وكلها كلاس اوف ايفيدنس سي وبي، حاجات كلها ما هياش مؤثره. ودي الشارم بريزيرفد على الكاندي سرتان، البريندوبريل والاربي سرتان والسبارونولاكتون في التوب كات، باراجون سكوبوتريل فالسرتان قرب من السكسس بس was not successful لحد لما طلعت الامبرور بريزيرفد في اليوروبيان في 2021. هي دي غيرت البراكتس. فالامباجليفلوزن اللي هو جارديانس the first drug to show clinical benefits across the entire range of ejection fraction من اول من الامبرور ريديوست مرورا بالامبرور بريزيرفد، وبعدين كمان بعدهم الامبلس اللي اتعملت على الانبيشنت انيشيشن. هنبص على الافيكاسي بروفايل وانا مش هطول في الحته دي لانه ده بيزنس از يوجوال، وانا عايز ابقى انط للحته اللي تخليك فاكر المحاضره دي ما تنساهاش. الامباجليفلوزن بال 10 مللي جرام هو ده اجينست الستاندرد اوف كير، نجح في الريديوس ايجكشن فراكشن ونجح في البريزيرفد ايجكشن فراكشن. خليني ابص معاكم هنا على البيز لاين كاركترستكس دي لانه هتلاقوا اغلب العيانين كلاس 4 كلاس 3 لا كلاس 2. الدواء ده ما تديهوش لما تكون الدنيا باظت خالص. الدواء ده بتديه لما يكون لسه العيان في عنده هارت فيلير بس ما هواش اند ستيج، ما بقاش المايوكارديوم فايبرس تيشو. فيو هاف تو جيف ات للبروبر بيشنت. زي ما انتم شايفين كده 75% من العيانين كانوا كلاس 2. البودي ماس اندكس في الريديوس كان 28، في البريزيرفد اولموست 30. بصوا بقى على السلايد اللي جاي ده انه في عيانين في الامبرور بريزيرفد كان الايجكشن فراكشن بتاعهم اقل من 50. كان في عدد مش قليل من العيانين ايجكشن فراكشن فوق ال 60. وانا كنت عايز الدكتور مجدي ممكن في الدسكشن والدكتور هشام يقولوا لنا هل كل العيانين بتوع الامبرور بريزيرفد كانوا عاملين ان تي برو بي ام بي؟ فاحنا نفكر في السؤال ده لحد لما نيجي للاجابه بتاعته. كل العيانين كانوا واخدين علاج بيرفكت، ايس انهبيتورز، ار بيز، ارني، بيتا بلوكرز، كلهم واخدين علاج. يعني انت بتختبر دواء اجينست البيست ميديكال تريتمنت، ومع ذلك طلع مورتاليتي بينفيت. فديس از ريلي فيري ديفيكولت ان انت تيجي وتطلع حاجه في الوقت ده في الزمن ده وعندهم كلهم حاطين مثلا سي ار تي، حاطين كل الحاجات اللي هي تحسن الهارت فيل بما فيهم الايفابرادين. كل الميديكال تريتمنت اللي كان موجود في الوقت ده كان متاخد. واحنا شايفين هنا الريزلت. انا هنا سبت اسم جارديانس متعمد لانه هو يستاهل الاسم ده، لانه ما فيش كوبي تقدر تحطها في السلايد ده. This is the brand, this is the drug that resulted in this wonderful result. ان انت عندك relative risk reduction 25%، absolute risk reduction 5.3، number needed to treat 19 عيان. وبعدين البنفيت ده حصل very early في اول 3 اشهر. زي ما انتم شايفين هنا البنفيت ده حصل very early. فالدواء ده is like magic وسكسسفول في ريديوس، ونفس النتائج دي شفناها كمان في البريزيرفد والنتيجه حصلت فيري ايرلي. نيجي بقى نبص، هو البنفيت ده ليميتد للهارت بس؟ لا، ده البنفيت كمان حصل على مستوى فيري امبورتنت فايتال ستراكشر اللي هو كيدني. ده عمل كيدني بروتكشن، والانيوال مين تشينج اوف جي اف ار بقى سلور من 2 ل 4 مرات ديكلاين في الكدني فانكشن. فهو بقى سكسسفول سواء في الريديوز او في البريزيرفد على مستوى الريدكشن اوف برايمري كارديوفاسكولار اند بوينتس، او على الكي سكندري اند بوينتس، او على مستوى الجي اف ار. هل ده فرق بقى ميل فيميل، دايابيتك نون دايابيتك، فانكشن كلاس ايه؟ كله البنفيت على كل الانتاير سبيكترم اوف بيشنتس. زي ما انتم شايفين هنا بودي ماس اندكس فوق 30 تحت ال 30، هيستوري اوف اي اف، كله العيانين استفادوا، ما فيش جروب او سب جروب ما استفادش. وبرده في الايجكشن فراكشن رينج كلهم استفادوا. فالبنفيت consistently reduced cardiovascular death or hospitalization for heart failure across broad range of patients with heart failure. فايوه انت محظوظ، كل اللي موجودين النهارده عشان يعالجوا الهارت فيلير محظوظين، ومحظوظين اكتر ان في واحد زي الدكتور مجدي عبد الحميد بقى ممبر في اليوروبيان سوسايتي اوف هارت فيلير، وبقى كل الساينس اللي بيحصل اوريدي احنا بقينا جزء منه، سواء على مستوى البراكتس او على مستوى الريسيرش. السيفتي از 100% زيها زي البلاسيبو. الحاجه الوحيده اللي يمكن فيها بعض الزياده اللي هي genital tract infection may be addressed with proactive monitoring and management، لانه بيزود يمكن الجلوكوز في اليورين، واحنا قلنا اوريدي انه بيحسن الكدني فانكشن. فهو اتس سنجل دوز اللي هي 10 مللي جرام وانس ديلي ويز نو تايتريشن، وعلى طول بقى في الجايد لاينز وهاي كلاس 1A. معناها ان ده دواء غير تماما البراكتس سواء في اليوروبيان او في الامريكان، واتحط هنا زي ما انتم شايفين. انت بتظبط الفوليوم بالدايوريتكس از نيدد، لكن اول واحد محطوط اللي هو الاس جي ال تي 2 اللي هو الجارديانس او الامباجليفلوزين in this regard في الهارت فيلير بيشنتس، وبعدين بيجي بقيه الحاجات سواء في البريزيرفد او في الريديوست. فإن summary, Jardiance is the first treatment that significantly reduced risk of cardiovascular death or hospitalization for heart failure. وإنه Jardiance reduced the first and recurrent hospitalization and finally it protected the kidney by slowing decline in renal function. خليني بقى اقول لكم القصه بتاع العيان. تقدر تشغل الصوت بتاع الفيديو؟ يا استاذ ابراهيم، انا الدكتور حسام قنديل، وانا عايز اعرف من حضرتك انت المرض بتاعك ابتدى امتى؟
بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا رسول الله صلى الله عليه وسلم.
قبل ما اسيبه يكمل، انا عايز اقول لكم ان انا مش من النوع اللي بسجل للعيانين ولا غير العيانين في العياده، لكن الحاله دي انا حسيت انها اتس امبورتنت انها تبقى ديسكاست وفيها جزء مهم من الاديوكيشن. وكويس ان اخويا العزيز الاستاذ دكتور عمرو كمال موجود، لان المريض ده من اسكندريه وهيحكي الستوري بتاعته، وهنشوف ان فيها دروس، ويمكن ده اللي يفكرك بالمحاضره دي بعد بقى الله اعلم من السنين قد ايه، انما you will never forget this story.
الحالة المرضية بتاعتي في بدايتها بدأت في اسكندرية سنة 2001.
تمام.
فسنة 2001 جات لي أزمة قلبية كده في حاجة في صدري هنا شديدة جدا، وسببت لي عرق وخلتني عاوزة أجيب اللي في بطني. كل دي أعراض ظهرت عليا في ثانيتين. فاستمرت معايا، رحت مستشفى اسمها الإنجليزية أو حاجة زي كده مش متذكر يعني. فاتعمل معايا
خليني برضه عشان لو حد بيسمع، احنا النهارده كام فبراير؟
النهارده 14 فبراير 2023.
تمام. الساعة كام دلوقتي؟
الساعة دلوقتي 8:15 أو 8:30 مساء.
وأنت قاعد
في غرفة الأستاذ الدكتور حسام قنديل، أستاذ القلب بجامعة القاهرة وعميد كلية الطب.
أنا أستاذ القلب بطب القصر العيني ورئيس سابق الاسم. فقول لي بقى حضرتك، أنت دلوقتي لما تعبت في 2001 عملت قسطرة؟
عملت قسطرة. فالقسطرة ديت طلع إنه عندي ضيق في مكان ما
الشرايين.
في شرايين مش عارف اسمها الطبي، ولكن في مكان ضيق ما ينفعش معاه يتحط دعامات.
تمام. فنصحك احد الاساتذه المشهورين.
احد الاساتذه المشهورين في الوقت ده في اسكندريه وما زال نصحني بان انا ماليش علاج، لان المكان ضيق.
ماليش علاج بالقسطره؟
ماليش علاج بالعلاج اساتر. وفي جزء من الجدار بتاع الشرايين من جوه عليه ماده كلاسيكيه كلسيه، شبهها لي كده بانها زي الجير.
اوكي. انما قال لك ان العلاج الاساسي هو الجراحه.
فقال لي انت لازم تروح لدكتور جراح.
ومين اللي عمل لك القسطره في الوقت؟ حد من الاساتذه في اسكندريه في الوقت ده؟
هو اللي عمل لي القسطره وقال لي خلاصه الكلام ده.
تمام. فانت علاجك الكلام ده في 2001.
في 2001. تمام. فهو اداني علاج وانا مشيت. تمام. واهملت العلاج. يعني قعدت كده سنه، وبعد سنه ما بقتش
تاخد العلاج.
وعشت كده لغايه لما جينا لغايه 2012.
تمام.
2012 فجات لي بأشد الحاله دي بأشد. بنفس الاعراض بنفس الحاله بطريقه اشد.
وبعدين جيت لي ساعتها.
الاول رحت له وانا في اسكندريه. فرحت له فدورت على الملف، لانه من 2001 ل 2012. فدورت على الملف، فجاه الملف فبص فيه وبص لي قال لي انت لسه عايش. انت المفروض ما تبقاش عايش. انت جاي لي بنفس الحاله بتاعت 2001 وما عملتش قلب مفتوح.
تمام.
فانت كان المفروض تعمل قلب مفتوح. فانا مش عارف، انا يعني الطب هنا ملوش عندك غير انك تروح.
كانت 2012.
كانت 2012.
جيت لي بقى بعدها.
فرحت نزلت، اخويا شرع عليا. حضرتك تعرف يعني كنت بتعالج حد تبع عيله السيسي. فقالوا لي ده دكتور شاطر وكده. فجيت طبعا انا يائس لان عمليه. فاي حاجه اي حد هيقول لي حاجه همشي فيها غير العمليه. عمليه قلب مفتوح. وكان في الوقت ده القلب المفتوح مش زي دلوقتي. كان كطبيا بسمع حاجات مهوله في القلب المفتوح. تروح المستشفى وتقعد في المستشفى شهر في العنايه ومش عارف ايه كده يعني. فكان بالنسبه لي الباب ده مرفوض.
فانا قلت لك ايه بقى؟
فحضرتك رحت لحضرتك فطلبت مني شفت الحاجات اللي انا عاملها في اسكندريه وقلت لي الموضوع بسيط مش محتاج على قلب مفتوح، انت مالكش قلب مفتوح وانا مش هعمل لك قلب، انا مش هخليك تخش في جراحه، امشي معايا بالعلاج وانا يعني ان شاء الله ربنا هيوفقنا احنا الاثنين. ده كان كلام حضرتك. فمشيت.
وحضرتك التزمت بالعلاج.
انا خدت بقى، كنت الاول هزار يعني من 2001 لغايه 2012 ما كانش فيه. من اول ما جيت لحضرتك 2012 التزمت بالعلاج حرفيا. يعني البرشام اللي هو بتاع السيوله ما ممنعوش. برشام اللي هو انا بقى باخد الحاجات اللي هي بتخلي الشرايين تبقى مفتوحه في القلب لان ما يجوزليش دعامه.
تاخد ادويه الدهون.
وادويه الدهون. فانا التزمت بيها لغايه وقتنا الحالي. يعني مشيت في الموضوع. تعليمات حضرتك قلت لي 3 اشهر تجيني كل 3 اشهر، فمشيت معاك كل 3 اشهر، وبعدين قلت لي قعدنا حوالي كده بتاع حوالي سنه، وبعدين قلت لي كل 6 اشهر تجيني. فجيت لحضرتك كل 6 اشهر، قعدنا برضه حوالي سنه، وبعدين قلت لي خلاص انت كده الحاله مستقره والحاله تمام تجيني كل سنه. فمن 2012 2013 14 تقريبا بدأ او 2015 بدأت اجي لحضرتك. انا جيت استقريت في مصر هنا. يعني كنت سبت اسكندريه وجيت استقريت، فانا استقريت في مصر من 2015. فجيت لحضرتك 2016 او 15 مش فاكر. فحضرتك قلت لي كده انت تمام وماشي على اللي احنا بنقوله تجيني كل سنه. فمن 2016 لغايه وقتنا الحالي الحمد لله فضل ونعمه.
2023 دلوقتي.
فاحنا النهارده 14 فبراير 2023 الساعه 8:30 مساء في غرفه الدكتور.
يعني فات حوالي 22 سنه
تقريبا على
اول مره حصل فيها مشكله
تقريبا
اللي هي عملت فيها القسطره
تقريبا.
وانت
حتى حضرتك ما قلتليش اعمل قسطره، يعني المفروض كنت تقول لي اعمل، فانت خدت القسطره بتاعتهم ومشيت. مشيت معايا، يعني حتى ما كلفتنيش ان انا اروح المستشفى عشان اعمل قسطره تشوف الوضع الحالي. احنا مشينا على العلاج وبفضل ربنا سبحانه وتعالى وبفضل حضرتك الدنيا مشيت والحمد لله، وكان فضل الله عليا عظيم وعلى حضرتك.
طب انت حاسس بايه بقى؟ هل حياتك عاديه ولا حياتك
جدا
عاديه جدا؟
بس العلاج
بنتزم
بالعلاج. ما بهزرش. انا عندي 71 سنه فما فيش عندي فرصه لاي حاجه اعملها. مش
يعني الشكوى لما حصلت كان عندك اقل من 50 سنه؟
كان عندي 50.
انا 49
2001 كان عندي 50. دلوقتي عندي 71.
تمام.
يعني ايه، من 2012 من ساعه ما التقيت بحضرتك كل الدواء تقريبا باخده الا اذا كان في دواء ناقص مش عارف اجيبه.
تمام.
وكنت اتصل بحضرتك او اكتب لك على الواتس، فحضرتك كنت تديني بديل 1 و2 و3، تقول لي خد ده، فاتصل بيك تاني اقول لك مش لاقيه، تقول لي خد ده، فاتصل بيك تاني. حتى بعمل عمره في السعوديه واتصلت بحضرتك وكتبت لك على الواتس ان الدواء مش لاقيه، فكنت حضرتك بتديني البديل مره واثنين وثلاثه واربعه. يعني حضرتك كنت متابع معايا بالتليفون تقريبا.
تمام. وانت هتحتاج تعمل، بتقول عندك فتاء وعايز تعمل،
عاوز اعمل عمليه مأجلها وخايف عشان البنج والسن.
تمام.
71 سنه فخايف من البنج يأثر عليا في السن ده، وانا تعبان في فتق قربي تعبني. كان عندي وعملته زمان 96 وبعدين رجع لي تاني 2004. فمن 2004 دلوقتي وانا بعاني منه وانا مأجله عشان حكايه بخاف من الازمات القلبيه. وجيت لحضرتك السنه اللي فاتت وقلت لك عندي فتق وعاوز اعمله، حضرتك ناس قلت لي روح اعمله، فانا برضو خايف فمأجلته. فخلاص هو كده وصل معايا لمنتهاه.
ان شاء الله تعمله وتبقى كويس ومفيش مشكله باذن
بس
الله.
دي الحاله المرضيه بتاعتي والحمد لله ما زلت.
خليني اقول انه الدكتور المشهور هو مش الدكتور محمد صبحي عشان ما حدش راسه تروح لبعيد. وخليني اقول برضو ان الدكتور المشهور ده انا بكن له كل الاحترام والتقدير. هو واحد من اهم الناس في الكارديولوجي في مصر مش في اسكندريه بس، وانه في اختلاف في الاراء. انما اللي خلاني الكلام ده حصل قبل ما نتائج الكارج تطلع، وقبل ما نتائج الاسكيميا ترايل تطلع وقبل الستيتش وقبل كل ما النتائج دي تطلع. اللي خلاني اعمل كده ان العيان ده نفسه stood the test of time، قعد 11 سنه من نفسه ماشي على بطل، خد العلاج شويه وبطله وهي سرفايفد 11 years. ولما خد الشورت تيرم تريتمنت كان اسيمتوماتيك والفنتركل بتاعه كان نورمال. انا مش عايز اطول اكتر من كده، انما انا وريت الفيديو ده لزمايلي الاصغر اللي هو ممكن يسيب في دماغك اثر. انت الديسيجن ميكر وبتعمل الديسيجن ده بيزد على وجودك في الاسم، على وجودك في المؤتمرات، على اختيارك اللي انت شايفه اصلح للمريض بتاعك. شكرا.
هي طبعا دكتور حسام it's a fantastic story و just showing how effective medications became وفي نفس الوقت the wisdom of taking decisions. ولكن برضه there is another side of the story. احنا هنا مش عايزين ننسى ان العيان ما كانش تقريبا بيشتكي بالchest pain and he was going relatively stable. بس ممكن جدا في بعض العيانين the story will turn upside
هو
down.
جاله 2 attacks of acute coronary syndrome
بس انا قصدي
انما المهم ان هو لما خد التريتمنت بقى اسيمتوماتيك.
لا بس احنا بنشوف on the other hand
طبعاً
عيانين يروحوا مستشفى ويقولوا لهم لا ده انت كويس ما تقلقش and he arrested بعدها ب few hours.
لا في
فانا
قصه
برضو I don't want to give this يعني relieving story لان في ناس تانية بتقلب الستوري completely to the opposite
طبعا. هو العيان اللي هيرسبوند على الميديكال تريتمنت ويبقى ما هواش يعني كومبليتلي فاهم الليميتس بتاعت جراحه القلب، وان احنا خصوصا دي قصه اخرى ان احنا ما عرضناش النتائج. انت النهارده لما هتروح مكان معين ويقول لك النتائج بتاعتنا مثلا على مدى ال10 سنين اللي فاتوا كانت كذا كذا مع الجراح الفلاني، وان احنا السكسس ريت عندنا وي دونت هاف ذس انفورميشن. فاحنا بنتيلور التريتمنت على حسب وات سوتس اور بيشنتس. وانا اهم لينك هنا او اهم حاجه حبيت اوريها لكم انه انا الله يرحمه الدكتور عبد العزيز الشريف، على قد ما هو كان يعني عملاق وزي ما بقول لكم ما تعرفش تحط عينك في عينه، انما بعد ما توفى الى رحمه الله العيانين بتوعي لما كانوا بيجوا لي يقول لي ده كان بيعاملني زي ابنه، كان بيعاملني يا دكتور زي ابنه، كان حنين جدا مع العيانين. فان انت تقدر تستبلش جود ريليشن مع العيان وما تتكبرش على العيان، وتقدر ان انت تديله التايملي ادفايز وتقدر ان انت تطبق العلم على البراكتس، اي ثينك ان دي حاجه مهمه جدا.
بشكرك جدا دكتور حسام على ال very exciting story. وطبعا لو هتحضر سيشنز في كل المؤتمرات عمرك ما هتحضر سيشن او محاضره زي اللي بيديها الدكتور حسام انديل، رئيس جمعيه القلب الاسبق ورئيس قسم القلب الاسبق في القصر العيني. في نقطه بس يا دكتور حسام كنت حابب ان انا اعلق عليها، وهي ان طبعا حضرتك عارف ان العلم بيتغير من سنه للتانيه للتالته. سنه 2001 انا I most probably this patient I don't know him but I think this patient was even a left main disease or a calcific ostial LED. Then he developed ischemic cardiomyopathy over the 20 years.
الرايت فنتركل از نورمال لحد النهارده.
طيب اوكي ما جالوش حاجه الليفت فنتركل كويس، بس it necessitates at this time 12 years ago necessitated ان هو يعمل كابج. وده اتغير طبعا، يعني ممكن يكون الكلام ده اتغير، كان ساعتها left main intervention is a class 3. فممكن ده يكون الدومين التايم دومين مهم في الايشو ده، ان هو في الوقت ده ما كانش ينفع يعمل انترفنشن والبيشنت ريفيوزد سيرجري. وده على فكره كومن سيناريو بنشوفه كتير. الصوره اتعكست دلوقتي ان معظم الناس بيعملوا انترفنشن. لما البيشنت يمشي على ميديكال تريتمنت اكيد 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 هيتحسن. بس في برضو ايشو تاني بتاع هل الاناتومي ده ممكن يكون precursor for sudden cardiac death for that patient. فانا برضو لو انا همشي مع الجايد لاينز همشي مع الاسكيميا ترايل I should investigate at least this patient with a CTCA. ما ينفعش ما اعملوش حتى CT coronary angiography، لازم اشوف الاناتومي بتاعه، لازم اشوف لو ما عملتلوش قسطره على الاقل اعمل له اناتومي. لا ماشي، بس القسطره دي من 20 سنه في 2001. فانا لازم اشوف ايه دلوقتي. ممكن يبقى عنده اناتومي which is dangerous for his life not the problem of the symptoms.
خليني اقول لك يا دكتور عمرو،
صح ولا ايه؟
انه ان جراحه القلب في وجود نورمال فنتركل مفيش اي ستادي ورت ان هي لها مورتاليتي بنفيت. هي كلها هي والبي تي اي الاثنين دول كواليتي اوف لايف. You have no study whatsoever. البي سي اي از لايف سيفنج في الاكيو كوروني سيندروم. لا سيبك من الانات، مفيش اي ستادي. كوروناري ارتري سيرجري ستادي الوحيده اللي اتعملت بس قبل ظهور الميديكال تريتمنت على الليفت مين وعلى 3 فيسل ديزيز في ظل وجود ليفت ventricular dysfunction، لكن في وجود نورمال فنتركل there is no evidence حتى قبل الميديكال تريتمنت ما يطلع. لا الليفت مين ده ما فيش تعملش عليه ستادي كومبيرد الجراحه لكن بالميديكال تريتمنت، لكن الليفت مين لما اتعمل ما كانش فيه اصلا ميديكال تريتمنت. وانا مش عايز اسهب في الحته دي، انما احنا ساعات يعني انت اكيد مريت بيها وكل الدكتور هشام وكلنا نيجي لك عيان ويرفض اللاين اوف تريتمنت ده. خلي بالك برضه انا عايز اكد تاني ان انا بحترم كامل الاحترام الراي بتاع الاستاذ ده، وانا بعرض الفيلم ده للاطباء فقط عشان اوري انه بعض المرضى ممكن يبقى لهم سيناريو مختلف and it will be a success story. شكرا.
شكرا دكتور حسام for the excellent lecture. Next is my colleague and my friend مجدي. الناس لما بيجي لها كانسر بتعرف انها doomed and she's going to die. مع ان 5 year survival بتاع الهارت فيلير اقل كتير من الكانسر. ده بيقول لنا ان الناس دي لازم تعرف what's heart failure, what's his prognosis, and how can he deal with his heart failure. ده اللي اتكلمنا عليه مجدي and the need for heart failure clinics عشان تقدر تفهم العيان how to deal with his disease. اتفضل.
Thank you very much, dear Hussam, for the kind introduction. In a couple of minutes, because we have live for CTO within few minutes, so in 10 minutes maximum, I will cover. We know that heart failure is an epidemic disease all over the world, and more than 60 million patients worldwide have heart failure. The prognosis is bad. Once heart failure is diagnosed within 5 years, the mortality rate is 50%. And you can see here in this slide the prevalence of heart failure globally in different countries, different regions, and overall it is 1 to 2%, but some countries like Germany is 4%. Unfortunately, we don't have an prevalence rate, but in Turkey, for example, 2.9%, and the new estimates in other countries. This slide shows that in the inter-heart failure registry, Africa, Middle East, we can see that the age for heart failure is 10 years lower than the Western countries. And ischemic heart disease, hypertension are common causes for heart failure. Still, in the low-income countries, the epidemiology of heart failure, the prevalence, are not well studied well. So we know that patients with heart failure have symptoms, have poor quality of life, have frequent hospitalization. They are necessitating intensification of drugs, especially diuretics, to relieve symptoms and signs of congestion. And during the journey of heart failure treatment, patients will be admitted several times, recurrent hospitalization, and mortality rate will be high. This is reflected, of course, on the economic burden, because 70% of the economic burden is related to the hospitalization. Otherwise, outpatient referral, drug treatment, so it represents for the healthcare cost a burden. So prevention of heart failure can prevent this problem. And heart failure should be treated in a multidisciplinary approach. And this is the gold standard of care. And there are many studies which demonstrated that when patients with heart failure are treated in a multidisciplinary approach, will be associated with lower mortality and heart failure hospitalization. And you can see that we need heart failure specialists, we need a heart failure nurse, pharmacists, pulmonology, psychologists, and the primary care physicians who are taking care of heart failure patients in the outpatient. So it's a multidisciplinary management, and you can see here the impact of multidisciplinary team care on all-cause mortality in heart failure. Look for ACE inhibitor, 16% relative risk reduction mortality, 34% risk reduction with the use of beta blockers, 30% with the use of MRA. CRT is associated with 36% reduction in mortality, as well as ICD, and the multidisciplinary approach, 25% relative risk reduction in all-cause mortality. The use of guideline-directed medical therapy in treatment of heart failure has shown to reduce morbidity and mortality, and the majority of heart failure patients, unfortunately, they don't. Oh, live is waiting. Okay. 3 minutes, we'll start the live, okay? Patients who are managed in heart failure clinics receive guideline-directed medical therapy and target doses of disease-modifying drugs when compared to patients treated in the outpatient without a heart failure clinic. So when patients with heart failure are treated in a heart failure clinic, we are sure that this will be reflected in the use of guideline-directed medical therapy, proper use, titration of the drugs. So this will be translated into reduction in mortality and the heart failure hospitalization. So the heart failure clinics versus the ordinary primary health care reduce mortality rate, relative risk reduction from 20 to 30, rehospitalization 25 to 70. So we advise that patients should be treated in heart failure clinics. And the following advantages also have been described. The multidisciplinary care, where different specialties are available to see patients when patients needs a consultation with nephrologist, pulmonologist, scheduled optimization of medication, education to the patients. This is very important, that you have to take more time to discuss with the patients the dietary approaches, salt restriction, etc., etc. High rate of being on target doses. If you compare patients treated in the heart failure clinic with other patients not treated in the heart failure clinic, the doses of ACE inhibitor or RNA beta blocker MRA is different from other patients treated not in heart failure clinic. So you know that we have a heart failure clinic in our department, and we have an efficient heart failure specialist now are running this service. Mariam Khalid وسلمى عصام حاليا و other young fellows also. The setup is not so complex. You need the ordinary equipments and devices which should be available in any outpatient clinic. The electronic medical records are important to collect the data properly, and now we have a system and platform where all patients presented to the clinic are recorded, and this will facilitate the extraction of data to be analyzed in a proper way. Heart failure nurse, of course, is very, very important. In other countries who have heart failure nurse, the heart failure nurse is responsible for the calls with the patients, adjustment of diuretics, body weight, diet. So all these measures are followed by the nurse, not with the heart failure specialist. So this is important, and unfortunately in our country, the role of heart failure nurse is limited, and we don't have enough heart failure nurses, and we should encourage to have heart failure nurses in the near future. And the referral of patients, when indicated to other specialties, should be done properly. The service provided with the heart failure clinic regarding clinical evaluation, optimization of treatment. You will see all trials that guideline-directed medical therapy in proper doses, titration to reach the target doses will equal survival better. And seeing patients who are candidate for device therapy, like CRT and ICD, this will prevent sudden death. Patients who are candidates for implantation of ICD. So the clinic is very, very important. And this slide summarizes the basic settings, required, advanced setting, and optimal settings, and the different types of services which can be performed in each one. And how can we follow up those patients? Not only clinical evaluation, body weight, GFR, potassium, electrolytes, etc. You know, when seeing patients, NT-proBNP, which is available now in our department, is very important to follow up your patients to see whether these patients is receiving well-optimized medical treatment or not. And this is clinic and how to see your patients. This is a quality of care centers in Europe. It is a recent project like Peptide for Life that we initiated with the EC 2 months ago to implement the use of NT-proBNP in the daily practice. Also heart failure quality of care centers, they selected some centers in Europe to start this project to see the outcome of patients treated in a well-managed heart failure service. And we are proud to be one of these centers from outside Europe to be included in this pilot phase, 12 countries from Europe. And this is necessitated to complete a lot of data to be allowed to be entered in this quality of care heart failure centers. So the take-home message is that heart failure clinics are associated with reduction of hospitalization and mortality, implementation of specialized heart failure clinics. Of course, this will allow us to use the guideline-directed medical therapy in a proper way, and this will be translated into improvement in outcome of patients with heart failure. Thank you for your attention.
Thank you very much, Magdi, for the excellent presentation. Just for the sake of time, we will not be allowing further discussion. We will be moving now to the live session. حالة CTO طبعا هنعرف الديتيلز ومعانا بروفيسور خالد تمام من الكاث لاب من القصر العيني. اهلا بيك يا خالد ومنورنا.
دكتور هشام, do you hear me?
سامعينكم كويس. برحب بيك وسعداء جدا بوجودك, وطبعا معاك من الاسم احمد سمير, واحد من السترونج interventionist عندنا.
First of all, thank you, Dr. Hisham. Thank you, Dr. Magdi, for the honor to be here with the great people in the Qasr Al-Aini. They prepare for you and for me a tough case. So we need a space and time to deal with this case. I will let Dr. Ahmed to present the case. Please, Dr. Ahmed.
First of all, I'm introducing the cath lab team. احنا معانا Mr. ضياء, technician, Mr. Said, Mr. Adnan, myself, and طبعا Dr. Khalid among us all. Our patient is 57.
لا أنا شايف له أي كمان وراك.
أنا عايز بس أرحب
محمد كمان.
We have Dr. Wasim.
عايز أرحب بالدكتور خالد تمام. دكتور خالد سامعني؟ دكتور خالد.
مجدي. أيوة يا فندم. أيوة يا فندم.
أنا طبعا بشكرك على يعني إن أنت النهارده موجود معانا في القصر العيني. وانت طبعا بنعتبرك واحد من ابناء القصر العيني، فدايما بنسعد بتواجدك معانا في القسطره.
ربنا يخليك يا فندم. Same here. Go ahead.
Our patient is 57 years old. He's hypertensive, not diabetic, has long history of being ischemic heart disease. By 2020, on background of an acute coronary syndrome, he had coronary angiogram that revealed multivessel disease, including subtotal occlusion in the circumflex, total occlusion in the proximal LAD with an ambiguous cap, and severe successive lesions in the right coronary artery. He was counseled for bypass surgery. However, he kept refusing and insisting to refuse for the past 3 years, while in the past 6 months, he started to suffer from crescendo progressive angina to Canadian class 3 and occasionally 4. The last week when we re-angioed him, we find that the right coronary artery has, the distal lesion at least, has become very vulnerable and tough subtotal occlusion. That was fixed, and we were planning him for the complex procedure with Dr. Khaled طبعا إن شاء الله, for the CTO of the LAD and the circumflex, which became CTO as well with the disease progression.
So, Dr. Magdi, Dr. Hisham, I will just review with you the angio. Can you have the angio from beginning? So first of all, we prepare, this is a very tough procedure. We don't know we'll finish the 2 CTO today or not. We'll do our best. He has, before please, before, first.
أول حاجة خالص.
الأول. So we prepare a 2/7 French guiding catheter. We have here, thanks for anesthesia team is with us here at the backup. The case has been discussed with the patient. He again refused to the surgical option. He has, as you see, we shortening also the guiding. We can show you the film of shortening the guiding, because if we go retrograde, we have to have a shortening guiding, and we have to fix this mid-segment RCA. He has a tough. It's this, of course, with a wire. All his arteries is tortuous, so he has some accordion effect in the wires. So we protect the RCA with left ambulance 1, 7 French, and we put a wire in the RCA. And here, as you see here in this view, we can see the very long CTO segment in the LAD as well as the circumflex, tough tortuous.
يا ريت يجيبوا لنا بس الصورة اللي على الشاشة، لأنهم بيورونا حاجات تانية. ايوه كده مظبوط كده.
قبليه أول صورة خالص، أول صورة. So here, Dr. Magdi, as you see here.
Yeah, we can see here احنا شايفين two catheters، واحد engaging the right coronary والتاني engaging the left. وطبعا باين ان في CTO في ال LAD وفي السيركمفلكس الاثنين.
Yes, and the CTO is very long segment, ambiguous cap. We don't see at all any of this the entry point for LAD.
في فيوز ثانيه well engaged.
Next please.
دكتور هشام، دكتور خالد، انا دكتور حسام قنديل، وانا قاعد جنب الاستاذ دكتور جلال السعيد، وهو عايز يرحب بيك، وهو بيقول دي حاله منيله قوي، وانا متفقين كلنا.
ما منقيين لك يا خالد ده.
نعم يا فندم.
منقيين لك.
دكتور جلال دكتور حسام، ازي حضرتك؟
خالد
على قدر اهل العزم.
الحمد لله، اهلا وسهلا في القصر العيني، ودي حاله صعبه قوي. وايه اللي
ربنا يخليك يا استاذ جلال.
هتعملها؟ تبدا بالرايت ولا بالليفت الاول؟
انا مستمع صوت حضرتك يا دكتور جلال. الرايت اوريدي هاز بين فيكسد. وي ويل بلان تو ستارت وذ
هو الدكتور جلال بيرحب بيك وبيقول لك ايه الاستراتيجي، فانت بتشرحها دلوقتي الاستراتيجي.
ايوه احنا وي نكست بليز نكست. We'll start with circumflex. I need to fix the circumflex first. If I succeed to see the fix the circumflex, not very complex, we'll do the LAD today. If it's not, we'll do the LAD in another session. And the LAD will start after we finish the circ. We'll say the strategy of the LAD. But first, I focus in the circ. We have guiding 7 French. We have a Corsair Pro from Asahi, and we start with Felder XTR to cannulate the circ. We try to find a microchannel, which is difficult. I think here is also he has some calcific lesion, so we need to penetrate this one and then de-escalate again with the Felder XTR. course, this a very high G CTO score. So give me a Gaia next, please. Gaia next 2.
Next 2 من شنطة الدكتور خالد. Gaia next 2.
يعني يا خالد انت ابتديت الاول بحاولت باكس تي ار واير فيلدر
we have always we have to
اساهي
start
بس
with-
هو ما it's clearly not crossing. طبعا انت you're using it عشان تشوف اذا كان في مايكرو channels that you can probe and cross.
Gaia next.
فهو حاليا الواير مش معدي وانت شاكك ان الكاب فيها calcification فانت you will get some stiffer wire and you will go for Gaia next 2. Is this what you're going to do يا خالد?
True.
Yes, yes, Dr. Hisham.
Okay.
Exactly. I think this is not bad. We can take another view. Give me a LEO cranial. لا في next 2 بره لو ما فيش حتى هات جاي next سايد.
هو في Gaia 2 موجود بس
وانا جايب next معايا بس عشان it will be more. You see here we not too much. Because you don't have.
عشان هي مش engaging.
So ارجع تاني كده بيا صح؟
رايت كود التاني اللي احنا كنا شغالين
Give me
فيه.
guy next please. Yes. لا
next. وري الاول وري.
Guy next 2 has more penetration and better to control the tip of the wire. Tip load is heavy, I think, is a 3 gram.
طبعا في مايكرو كاثيتر دي كورسي ولا كانت ايه يا خالد؟
Corsair Pro, yes. Corsair
اوكي.
Pro.
ودلوقتي انتوا داخلين بواير Gaia Next 2 مش كده؟
Yes.
Just for some tips يا خالد انت عادة بتعمل angle very near to the tip مش كده؟ Around كام؟ 30 45 degrees?
Yes. No, but this guy it's already.
It's pre-shaped. Okay.
Yes, it's well shaped.
Okay.
Pre-shaped, yes.
Yeah.
عايزين ندي 2500 هيبرين بره ميك شور بس انهم يجوا. لما ندي ده 2500 هنعمل ريسيت.
I think this case will take all the time of the conference, so you may finish the conference and come to us again.
يعني احنا if you feel يعني ان عايزنا
لا،
نريجوين
no,
again زي ما انت
لا،
عايز
لا،
احنا
لا،
احنا
لا،
we
لا،
can
لا.
go يعني احنا ميزه ان
بالعكس،
احنا
it's very
نتابعك يا
out.
خالد
Very
ان
out.
احنا
لازم نعملها out.
نشرح بالراحه كده and step by step to our junior staff how steps for CTO are being done. This is an anti-grade approach. احنا بنبقى مهتمين جدا ان الجايد كاثيتر تكون well engaged عشان ما تضايقنيش وانا بحاول ادخل. هنا احنا داخلين بمايكرو كاثيتر وبندخل الاول هنا في الستيب هنا هو ابتدى باكس تي ار. اكس تي ار دوت كمان بيستخدم في الريتروجريد بس يعني المهم ان هو داخل باكس تي ار ما عداش فراح مغيره بجايا نكست 2 واير. الجايا وايرز بالذات 2 و 3 ار اكسلنت وايرز الحقيقه وكتير جدا they succeed to cross such CTOs.
Can you play for me the previous film, please? شغال اللي فات؟
I think لو السيشن الجايه جاهزين احنا ممكن نطلع وندخل تاني.
احنا طالما في تاخير فهناخد نستغل الفتره دي ان احنا بنكرم يعني اسم 23 طبعا الدكاتره بيقوموا طبعا بكل المجهود اللي احنا عارفينه ابتداء من النواب لغايه الاساتذه، لكن في ورا النجاح اللي بيحققه الاسم يعني مجموعه كبيره جدا من التمريض ومن السكرتاريه ومن العمال ومن الموظفين. فطبعا بنستغل طبعا مؤتمر الاسم ان احنا نقوم بتكريم مجموعه من الناس اللي هي الحقيقه ادائها متميز في الاسم يعني طوال الفتره اللي فاتت، ودايما احنا بنستغل اي تجمع في ان احنا نقوم بتكريم الناس المتميزين كل واحد في مكانه. فبسرعه لغايه ما نرجع لللايف عايزين نقوم بالتكريم. دكتور محمد رملي اتفضل. دكتور هشام. دكتور حسام. دكتور ياسر. سريعا اسماء.
Give me fill the XTR as well.
XTR تاني.
عايزين بسرعه نخلص. انت لازم تكتبي لي قدام كل واحد شغله.
الهيبرين يتاخد.
الورقه اللي انا اديتها لك.
ريست تايم.
اول الاسم ال 23 طبعا في اثنين الحقيقه يعني بيقوموا بمجهود كبير جدا من التمريض حنان حسن وزينب عبد السلام. اتفضلوا. تعالي بقى هنا عشان تسلمي كل واحد كده. اكتبي الوقت عشان نعرف ده بيشتغل ايه وده بيشتغل ايه. يلا بقى انت تسلم بقى. روح اسلم. ادي لمحمد واحد. كل واحد ده واحد.
ده ممكن توريني الجايدنج بس للليفت الرايت.
هات ليفت زيادة. ليفت زيادة.
ليفت ستريت ليفت.
ليفت وقلل الكود. الليفت كتير.
ليفت عادي. ليفت عادي. ليفت عادي عشان رايت. انجيج رايت.
احنا برضو عشان الوقت احنا بعد ما نخلص يبقى نصور صورة جماعية مع المكرمين مرة واحدة عشان الوقت بس. رعاية اسم السكرتارية اسم 23 هدى إبراهيم، هدى محمد، شيماء خليل. أسطرة 23 إيمان مصطفى، عمرو جمعة، سكرتارية الأسطرة أميرة طارق، سماح عثمان، منار منصور. بعد كده رعايه 23 صباح شعبان وحنان نبيل. قسطرة الرابع نادية زكريا وسحر جلال.
انا قلت مش هتصدق.
موجات الرابع هالة وصفاء محمد. هالة وصفاء دول اللي عاملين شغل كويس في الدور الرابع. هالة دي ماسكه الهارت فيلير كلينيك فعشان كده متوصين بيها. رعاية الرابع نادية عبد الموجود ونورة السيد. بعد كده صباح محمد محمود. صباح دي اهم واحده في القسطره دي، هي بس كانت شغاله ولسه جايه متاخره بس. عمال اسم 23 بقى دول بيقوموا بدور كبير جدا الحقيقه، عايده ويسريه. شكرا جزيلا. هنكمل لايف بقى.
دكتور مجدي you are with us؟
معاكم. انتوا تحبوا نسيبكم شويه ونرجع لكم ولا continue live؟
We have a patient has a big tortuosity.
Okay.
Protruding. We have a guiding 3.5 ABU. We need to have a more support.
Okay.
ABU 4.
يعني انتوا غيرتوا خلاص الجايد يا خالد؟
No, we cannot. We don't have.
We don't have an ABU 4.
Yes.
Okay. ولا XP4؟
ولا XP4.
طب هل تلجأ لليفت امبلاتس مثلا؟
لا ليفت امبلاتس would be more dangerous عليه عشان
بس ما يجيب يو سبورت وبس proper adjustment وخلاص.
Yes, but it will not help me in the LED.
اسحب المايكرو كاتيتر وامسحها من بره.
I prefer to continue with this one.
Okay.
Just for safety wise يعني.
وانت مشكلتك كمان انك مش عارف تودي واير تاني مثلا يعمل لك سبورت بطريقه مريحه يعني.
مفيش حته يروح فيها.
خالد, do you like ان احنا نطلع off life ونرجع لك مثلا بعد تلت ساعه ولا حاجه؟
It's really as you like دكتور مجدي. احنا لسه we have still a lot of work to do.
طيب انا تهيألي ان نطلع بره تلت ساعه كده ونرجع لك وهنا هندي محاضره. اوكي؟
اوكي.
Thank you very much. هنطلع اوف لايف. هيثم. احنا will be moving now to our next session. لو في شرف. هو مين Two reasons to love Lakeview.
Okay, this is Novartis symposium. Again, a different topic. Why inclisiran, Lakeview? We know that cardiovascular disease is the leading cause of disease burden in the world, and it is responsible for 18.6 million deaths every year. We know the close correlation between high LDL and the risk for cardiovascular disease and the major adverse events. And we know for many years that lipid-lowering therapy with the use of different statins was associated with significant reduction in the MACE events in terms of myocardial infarction, stroke, and death. If you look for the 4S, the CARE, the WASCOP, the lipid, all lipid-lowering therapy trials was translated into a reduction in the MACE events. However, the residual risk is still high. And meta-analysis of 26 trials showed a significant cardiovascular risk reduction per 1 millimole, which equals 39 milligram per deciliter reduction LDL. So this will be translated into 22 relative risk reduction in heart attack and stroke, 46% reduction in atherosclerotic cardiovascular disease risk. We know the pleiotropic effects of statins and the regression of atherosclerotic plaques, reducing cardiovascular risk and save lives. So we are in the era of combination therapy because moderate intensity statin was associated with 30% reduction LDL, high intensity 50%, high intensity statin and ezetimibe was associated with 65% reduction LDL. and PCSK9 inhibitor was associated with 60% reduction in LDL. So combination therapy, if you add the PCSK9 and the high intensity statin, 75% reduction, and the triple therapy is associated with up to 85% reduction in LDL. So combination therapy is associated with significant and more reduction in LDL. And if you look for the meta-analysis for high intensity versus standard statin for a subgroup of LDL less than 76, the mean LDL comparison 66 versus 50, looking for the outcome of myocardial infarction, coronary artery disease death, stroke, coronary revascularization, and high intensity statin is always associated with significant reduction in these MACE events compared with standard of care. And we have seen the combination of high intensity statin and ezetimibe compared with the statin only in the improved post-ACS patients, which was associated with significant reduction in the MACE events. And recently we are in the era of a new lipid-lowering therapy, which is PCSK9 monoclonal antibodies. FOURIER and the ODYSSEY trial, 2 different monoclonal antibodies, evolocumab and alirocumab, and up to LDL level of 30 milligram per deciliter was achieved in the FOURIER. And this also was translated into a significant reduction in cardiovascular death, MI, stroke, coronary revascularization, and unstable angina for a median duration of 2.2 years. And for post-ACS syndrome, ODYSSEY's trial also demonstrated the benefit of using alirocumab in those patients with a significant reduction in myocardial infarction, coronary artery disease, death, stroke, and unstable angina. And if we look for the last dyslipidemia guidelines, 2019 ESC in secondary prevention in patients at very high risk and LDL cholesterol reduction 50% or more from the baseline, and LDL less than 55 milligram per deciliter are recommended, which is class 1A recommendation. And this can be achieved with the use of high intensity statin therapy. Then look for the LDL. If it is at the target, you have to continue. But if you are still not reaching the target, so combination therapy with the use of ezetimibe is class 1B recommendation. And if the LDL is still not reached to the target, we have to add the PCSK9 inhibitor, which is class 1A recommendation. So lipid lowering therapy can be achieved with the use of different mechanisms of action. So if you look for bempedoic acid, which acts at an earlier stage of cholesterol synthesis, which is an ATP citrate lyase inhibitor to decrease conversion of citrate into acetyl-CoA. And then we know for many years the mechanism of action of statin, which is an HMAG-CoA reductase. And recently, with the use of monoclonal antibodies to block the action of the BED protein, PCSK9, which is responsible for degradation of the LDL receptors. So with the use of PCSK9, this will lead to more expression of LDL receptors and significant reduction in LDL. And recently we have the novel mechanism of action, which is with the use of inclisiran, which is a small interfering RNA therapy targeting the PCSK9 mRNA within the hepatocyte. So this will lead to increased number of LDL receptors on the liver, and the use of inclisiran was associated with significant reduction in LDL by 50%. So this slide summarizes the different mechanisms of action, how statins work,
the mechanism of action of ezetimibe, which reduce absorption of dietary cholesterol in the small intestine, but it reduce LDL by only 15%. And the monoclonal antibodies, which decrease circulating LDL by 60% by blocking the plasma PCSK9. So statins and ezetimibe are given once daily, while anti-PCSK9 monoclonal antibodies should be given twice per month, and inclisiran, the new agent, the new player, can be given only twice per year. So again, inclisiran is a short-chain synthetic small interfering RNA, prevents PCSK9 protein production. It acts into the hepatocytes, specifically binds to the mRNA precursor of PCSK9 protein, reduce intra and extracellular PCSK9 protein levels. This will lead to long-lasting reduction of LDL cholesterol, and it can be given twice per year. Again, the different mechanisms of action of lipid-lowering therapy and how inclisiran works, and it can be given every 6 months. Again, the guidelines for lipid-lowering therapy according to the risk. If you are treating patients with very high risk, like patients with established cardiovascular disease, you need to achieve an LDL less than 55 milligram per deciliter. High-risk patients should achieve an LDL less than 70 milligram per deciliter. Moderate intensity statin, moderate risk, you have to treat to an LDL less than 100 milligram per deciliter, and the score chart are less than 1%, LDL less than 116 milligram per deciliter should be achieved. So we have to know what is the target that we have to achieve, and how can we achieve the target with the different lipid-lowering therapy, starting by high-intensity statins, combination therapy, ezetimibe, PCSK9 if indicated. So Leqvio or inclisiran, which is available now, and by this drug, which acts by a unique mechanism, this can decrease LDL significantly, and unpredictable levels in the circulation can be seen with the use of the drugs within 48 hours of administration. It allows for greater uptake of LDL into the hepatocytes. So we have many studies for the use of inclisiran, and some studies are undergoing now to look for the hard endpoints, infarction, stroke, mortality. But the earlier studies, which is an Orion studies, Orion 9, 10, 11, they looked for the LDL reduction. So in 3,660 patients across 1.5 years, in the 3 pivotal phase 3 trials, Orion 9, 10, 11, in patients with familial hypercholesterolemia, atherosclerotic cardiovascular disease patients, patients with atherosclerotic cardiovascular disease and high-risk equivalent patients like type 2 diabetes, and different LDL levels where the drug was started at different LDL levels to look for the outcome with the use of inclisiran. And we can appreciate that effective and sustained reduction in LDL levels are achieved with the use of inclisiran, 2 doses per year. So the Orion phase 3 pooled analysis for Orion 9, 10, and 11 was associated with effective and sustained reduction of LDL versus placebo. You can appreciate that up to 55% reduction in LDL, and the interesting is the sustained benefit, up to 52% reduction in LDL. So Leqvio was effective and associated with sustained reduction of LDL cholesterol versus placebo in patients with atherosclerotic cardiovascular disease. This was demonstrated in Orion 10 which included 1,561 patients. So by giving 2 doses per year, single subcutaneous injection, this was associated with significant reduction LDL, and at the same time, there was no adjustments for renal impairment or mild to moderate hepatic impairment, with the safety of the drug with no serious adverse events. And following a single sub-Q administration of the 284 milligram of inclisiran, LDL cholesterol reduction was apparent with 40% within 2 weeks after giving inclisiran. The mean reduction of 51 for LDL were observed 30 to 60 days after giving inclisiran. So we are expecting earlier LDL reduction within 2 weeks of giving sub-Q injection of inclisiran. This is important analysis of phase 3 trials to look for the safety with the use of inclisiran, looking specifically for MACE events. So it is considered a safety study. And they found that Leqvio was associated with lower probability for MACE-related safety events, with 25% relative risk reduction in the MACE events. So this indicates the efficacy in reducing LDL level, as well as the safety of the drug, with 25% relative risk reduction in MACE events. And this is a common sense, because we have seen with the different lipid lowering therapy that always LDL reduction was translated into reduction in MACE events, myocardial infarction, stroke, and death. So inclisiran, it is the first and only approved small interfering RNA, effective with sustained reduction of LDL cholesterol in patients with atherosclerotic cardiovascular disease, well tolerated in phase 3 trials across 1.5 years. It is effective as well as associated with sustained reduction LDL. So it was approved for the treatment in Europe and US. Again, Leqvio is associated with effective and sustained LDL reduction, lowering LDL by up to 52%. And the interesting that by giving 2 doses in addition to statin therapy, this will be translated into reduction in LDL and the MACE events. Thank you.
Thank you very much, Professor Magdi, for your illustrative and very important presentation. Only simple question, and I know that you are very busy. In the guidelines, there is a stepwise algorithm for treatment of atherosclerotic cardiovascular disease. But in extremely or very high risk patient, would you recommend from the beginning the combination therapy? Because the recent consensus stated that the very high risk and the extremely high risk patient, we should start with the combination therapy.
Yeah, this is a very interesting question, an important question, Professor Atif. I think when we're treating the high-risk patients, and we are seeing in the daily practices, it's very difficult to achieve the target LDL with the use of only monotherapy. So combination therapy in high-risk patients is recommended. And the interesting that currently PCSK9 in hospital in patients with acute coronary syndrome, some studies prove the efficacy of starting PCSK9 earlier in the hospital. So combination therapy should be given from the start to high-risk patients. I know that especially patients who developed recent event, acute coronary syndrome, and you don't know these patients' the baseline LDL level. So if you started with combination therapy in the vulnerable phase, I think this is very important. And this was achieved with, if you look for high intensity statin level lowering therapy, the residual risk is high. So combination therapy avoids this gap.
Okay, thank you very much, Magdi. I think we'll be moving to the next session. ولا الأول نشوف اللايف نرجع لللايف كده يا جماعة.
افتح جلاديوس.
افتح ايش؟
جلاديوس؟
اه.
Okay, we are back. معاك يا خالد.
دكتور هشام, still it's a very tough tortuous lesion. The wire is little bit progress. We try to escalate and de-escalate.
What wire are you currently using?
We use all the wire. We use a Gaia Next 3. We use a Confianza Pro 12. Now we de-escalate again with a Filter XTR. I try to do it with Filter XTR in terms of safety again, because circumflex is always difficult and very easy to go subintimal.
طب هو سؤال
And the course,
when
and
you
the
are
course is,
نعم معاك.
the course is very tortuous.
Okay.
So
طب
we
may I
don't
ask
know-
something? Why are you starting with the CX not the LED? يعني ايه اللي خلاك تفكر احسن تبتدي بالcircumflex not the LED?
For the circumflex, yes, here you see we are so close lately.
Yeah.
The circumflex is not recently, but is more recently included. I need to fix the circ, and then we put the IVUS and we penetrate the LED with the IVUS. But if the circumflex will not successful, we'll shift to the LED.
Okay.
دكتور هشام يعني لو تسمح لي برضك هي احنا لما revised الانجيوس across the years هو ال LAD هيبان ان هو 2 levels of tough CTOs with an island in between. فهنبقى عارفين ان it will not be a piece of cake. هنحتاج ان احنا utilize intracoronary imaging to tackle the LAD, and having a patent circumflex in that instance will be quite helpful and safe.
Now I'm changing with Gladius MG wire. It's a little bit like Pilot 200.
Okay.
Yes, but again, it's going
with the knuckle subintimal.
with the subintimal.
بس احنا لو نزلنا على الحته التحتانيه مش معاك كروس.
Is again is subintimal. That's better. Okay, can we have a test retrograde?
Shot or test?
Test. There's a subintimal here. Is a new channel.
Track. Yes.
New track. The vessel is very fibrotic, tortuous, calcified.
طب Khaled, just for the sake of discussion, when are you willing to go for a retrograde approach for the CX? Now you're trying antigrade approach and you're finding difficulties. Then you went subintimal. You have tried escalating the wires and then sometimes even de-escalating. But here, for how long you continue to try, and when do you think that maybe in this particular patient that going retrograde approach would be good?
To be honest, retrograde approach in this case with single axis remaining. He has only RCA, and if something happened to the RCA it will be disaster. So I try to take my time for antegrade because retrograde need umbrella to support this case.
Okay.
Otherwise, it will not be safe to.
Exactly. Yeah, this is a very wise idea لأنه هنا هو تقريبا عايش على الار سي اي. ال LAD is totally occluded, CTO, circumflex is totally occluded, وبالتالي هو عايش على الار سي اي. If I tried the RCA as a retrograde approach, it may be quite risky. ممكن نعدي وكل حاجة بس يعني it would be risky to do so. فبالتالي the wise thing is not to use the RCA as a retrograde approach في العيان ده.
Totally. Why not bad? Yes, كلهم في architecture بس.
So I'm probably from a higher point.
So any ideas? Who is voting to start
يعني
LED
I'm not so sure يعني هل ممكن go for the LED بس عايزك تاخد وقتك يعني not to rush you to any direction يعني احنا we are just still less than an hour in this approach يعني.
This one better.
أنا عندي idea الصراحة. To knuckle and go down to the healthier part of the circumflex. We will not lose any branches through this 10-20 millimeters, but certainly re-entering downstream will be a faster trip. Actually, احنا كمان عندنا bifurcation. If we were lucky and start into the bigger one, it's an S.
Same, huh?
The guide is not very well supporting الحقيقة برضو.
Everything is not supporting.
حتى أنا.
No, I mean I'm trying to. I will try. Maybe we can go here with a Gaia and try to re-entry. Okay, give me a new Gaia cert.
Ordinary third, not next.
Yeah.
جا third من عندنا. شوف بالشنطة. Third, برافو عليك. You have it ready.
Yeah, open it.
افتح.
Yeah, open.
Okay, thank you. مش هحتاج. مش بيحتاج.
So we'll give another 30 minutes here, and if it will not pass, we'll move to LAD. And then circumflex. Usually circumflex is difficult than LAD, but again, here's the LAD. We need to IVUS.
Do we have a Stingray balloon?
Yeah, but this Stingray cannot go here because it's very tortuous.
Calcifications.
And the calcium.
يعني not cross يا خالد؟
No, cannot cross. Will be tough to cross.
Then if you're subintimal, what will help you? One of the things is to use a Stingray balloon.
Yes, but without calcification, we don't see the distal cap.
هو ستينجراي علشان السكسس بتاعها يبقى عالي we need to go even subintimal but to reach a segment of the distal true lumen that is good patent.
والحقيقه انا ما شفتش لغايه دلوقتي ولا حقنا بالنسبه لي هنا واضحه. يمكن انتوا حقنتوا قبل ما احنا نشوف، بس ولا حقنا واضحه للسيركمفلكس انتوا واصلين فين صراحه يعني.
لا احنا لسه kind of in a range of 20 millimeters away from the distal bifurcation of the true lumen.
اوكي.
The distal cap is unbifurcation.
يبقى هنا ما فيش لسه مجال للستينجراي يعني.
ممكن ندي لؤي، هنعوز ندي مورفين سلفيت، هنعوز مورفين ساقعين. مستر عدنان.
ممكن نبتدي.
looks centered inside the calcium. Hopefully إن شاء الله هيبقى كويس. تسلم إيدك يا بيه. ناخدها صورة عشان نشوف. أنا طولت شوية. دكتور هشام, I hope everybody is seeing this shot.
Yeah.
This is what we were talking about.
بس انتوا ما حقنتوش الليفت سيستم مش كده؟
هو الليفت سيستم ما فيش فيه فلو.
ما فيش فيه.
الليفت سيستم مش بيوباسيفاي السيجمنت ده خالص.
المشكلة الواير كنترول هنا very tough.
For the 3 double curves and a non-supportive guide.
You see, even the microcaster cannot go.
تحب إني أمسك لك الجايدنج شوية؟
I'm trying to go with my microcaster to pass this tip, first curve.
You usually do it without opening the valve. بتحب تعمل الحركة دي والفالف مقفول؟ احنا حيدنا في البلد بنفتح الفالف علشان
Okay, give me a pilot 200 again.
نعرفه لوحدي.
If the pilot 200 will not go, we'll start with a LED.
لا العكس يا صديقي، العكس يا صديقي.
I told you this case may end until the finish of the like Ain Shams case. We start morning time, we finish at 10 o'clock in the evening. So, but we have a limitation of radiation dose, we have a limitation of contrast media. So we check all this.
When do you stop regarding contrast dose? لو البيزلاين سيرم كرياتين النورمال ولا مفيش قاعده؟
يعني؟ مفيش قاعده عليها، بس if we exceed us, if the patient is body mass index, it's good average size, I stop in 500 600 cc of contrast.
يعني انت مش ماشي بقاعده 5 ml per kg ولا حاجه؟
No.
يعني usually 500 to 600. انا زمان لما رحت اتمرن في المانيا كان المنتور كان غراب جدا، كانوا بيستخدموا حاجات 200 سم كده contrast. He was not even يعني interested in the amount of contrast dye, which is very strange. يعني طبعا we have to be very interested. احنا ريسنتلي حالتين دخلوا في سي اي ان كنا بادئين بسيرم كرياتين، واحد اعتقد كانت 1.6 يا ميرنا حاجه كده، والتاني كان 2.1 and they went into CIN. واحده منهم الراجل وصل ل6 وشويه كرياتين بس we didn't dialyze الحمد لله و went fine، والاثنين recovered completely يعني. بس انا قصدي يعني
if the GFR is okay, if the GFR يعني above 100 and patient is not diabetic.
لا ده مفيش 100 يا اخي خالد، ده نادرا لما ده في اللي ماشيين على رجليهم العاديين نادرا لما تلاقي 100. extremely rare.
So, if I remember correctly, one of the data coming from a large meta-analysis كانت حاطة cut-off 3.75 times the GFR total contrast volume from the non-ionic dye.
دي انا قاريها دي البيبر ديت.
Cool.
Yeah, sure.
I guess we need to.
خالد هل بتفكر تغير الفيو ولا this is the best that you tested?
Yeah, we don't find a good view. We can go with the iliocranial, but all the views overlapping. So this is one I.
40
and in this view also I find.
بس انا قصدي ممكن to find another helpful view، ده اللي انا قصدي فيه.
هي الفكره ان انا الفيرست فيو اللي شفته كان مفتوح السيركمفلكس. this view. لا اديني بعيد عن ابعد الجايدنج، ابعد افتح الجايدنج.
لا لم الكرينيال، قلل الكرينيال وتعالى ناحيه كودر.
كويس. لا قل عليا حط عليا فيو. كمان يس روح كرينيال بقى. اوكي كل معايا. This is very tough, very tough.
We are not very far away على فكرة. في كده في آخر الشوط باين إن إحنا مش بعاد قوي.
أيوة بس في pulse human.
طبعا ده أكيد يعني.
Go to epicoder again.
with the sunrise اللي كنا شغالين فيه. نفس الانجل اللي كنا شغالين فيها قبل كده يا ضياء. Yeah. Advanced a bit outside.
احنا الواير الحالي ايه اللي احنا مستخدمينه؟
Pilot 200.
اوكي.
And I have a very strong friction in my hand, so I'm totally, I think I'm outside. So I think it's time to move to LED because this one will not be
soft crack.
It will not finish this time.
Okay. احيانا بقى we can go for step كده approach ان احنا نفتح ال LED وبعدين if we cannot go anti grade already عندنا LED بقى ساعتها ممكن نفكر نعمل ال CX retrograde.
Yes, having two patent vessels, not a single one, will give plenty of several options.
هو مين اللي مختار الحالة ديت؟ أحمد سمير ولا مين؟
لا يا والله يا شريف يا ابني.
لا مين اللي مختارها أنت ولا مين؟ عايزين الاسم بس.
شريف طبعا.
شريف رزق؟ مش موجود.
Yeah, this case was chosen before the circumflex close. It was just LED.
Okay. مرة يا خالد زمان كان في مؤتمر بس من سنين طويلة يعني، وجاي لنا كذا اكسبرت فروم ذا ستيتس ويوروب وكده، وداخلين يساعدونا في اساطر. فاحد الناس من غير ذكر اسامي جاب لهم حالة اوكي هي 3 فيسل ماشي مش مشكلة يعني، بس الاوريجن بتاع الرايت كرونيال I have never seen this before. طالع very high very high in the aorta. فالراجل من غير ذكر اسمه برضه يعني تنته حوالي ساعتين trying just to engage، واخد بالك، وبعدين finally it failed. على فكرة احنا اوت خالص، احنا we are not on the same level.
We are in the vessel architecture, but the calcium at that bend is always deviating the antegrade gear into the subintimal space rather than entering intimally. I presume particularly لو حضرتك حاسس انه هو مش بنفس السهولة. بص قبل ما تقول هنمشي ونسيبه، تعال نعمل فيه ماينر كي يكرر لنا وكده. probably it will. هو ده بتاع المرة اللي فاتت. لحظة واحدة هعبي أنا آسف. Take your time.
خالد do you like إن إحنا نخرج نسيبك ونعمل سيشن ونرجع لك؟
هتخرجوا كتير.
Thank you very much. إحنا تعبينك. إحنا تعبينك معلش. اوكي هنطلع بره اللايف ونبتدي السيشن اللي بعد كده.
This is the side branch in the very early stage.
اوكي we'll start السيشن بتاعت الادلت congenital heart disease. ويسعدني اقدم بروفيسور سهى امام، وهي واحده من الناس الاساتذه الافاضل من البيدياتريك كارديولوجي ديبارتمنت، وهي بتساعدنا regularly to initiate our adult congenital heart disease services, and she will give us an update about the services that we are providing. Professor سهى اتفضلي.
السلام عليكم. Good afternoon. dear Professor هشام على الانترودكشن، وطبعا انا سعيده جدا بالتعاون اللي بيننا وبين اسم الادلت كارديولوجي. thanks للاودينس اللي قاعدين that late، و I am not sure ان عندهم خلفيه عن الكونجنتال، لكن ان شاء الله we will try to make our things as simple as possible. وبشكر كل التيم الجميل اللي بنشتغل مع بعض وهتشوفوهم دلوقتي. الحقيقة الأدل congenital branch is a challenging surface. مش هطول عليكم عشان أوفر الوقت للكيسز. احنا دلوقتي الصورة في العالم اتغيرت، يعني الأدل congenitals بقوا much more percentage than pediatric congenital. عندنا الصورة لسه مش نفسها في مصر، لكن بقى عندنا عدد كبير من البيدياتريك children اللي عندهم congenital heart disease بيوصلوا للادلتهود، وده طبعا كان نتيجة progress في fields كتيرة جدا على مدى السنين. فدلوقتي الريشيو اتقلبت، ف most of the patients now are adult congenital و small percentage بقت pediatric congenital. Our experience in Cairo University احنا من سنة اولا عندنا البيدياتريك كارديولوجي من سنة 2005 بدأنا نريلايز ان عندنا populations بيكبروا وعايزين سبيشال كير، كانوا هم mainly البوست اوبراتيف patients. فبدأنا نستبلش الكلينيك دي ومع استاذتنا دكتورة هالة أغا ومايسلف وبقية التيم، كانت الكلينيك is very fruitful. By time عيانينا بدأوا يكبروا more and more ويوصلوا للادلتهود، وبدانا نتواجه باللوجيستكس اللي في ابو الريش او في البيدياتريك هوسبيتال، ان احنا مش قادرين نعمل ادميشنز، مش قادرين نعمل certain investigations، ومش عارفين نلاقي other services اللي هم بقوا محتاجينها زي الباطنه والنساء وهكذا. فبدانا نفكر نعمل ايه. شفنا كذا روتس نحاول نكوميونيكيت، وكان قبلها بسنين الحقيقه من قبل 2019 حاولنا كذا مره مع كذا انستيتيوت، لكن في سنه 2019 بفضل دكتور محمد عبد الغني وساعتها كان رئيس القسم ودكتوره هلا اغا، وبدا التعاون بين الادل كارديولوجي والبيدياتريك كارديولوجي على ان احنا نستابلش السيرفيس بتاعه الادل كونجنتال هارت ديزيز في اسم 23 ونبدا السيرفيس هناك. وده التيم بتاعنا كلنا في الادل كونجنتال اللي لسه مستمر معانا لغايه دلوقتي، ورحلتنا بدات من الحته دي. الادل كونجنتال ده مالتي ديسيبلينري برانش محتاج a lot of talented people من specialities مختلفة، فعشان كده it has to be a teamwork من skilled people. عايزين جراح كويس، عايزين interventionist كويس، عايزين anesthesia كويس، عايزين nurse، عايزين hematologist، عايزين كل البرانشز، عايزين حد بتاع نسا. فبدأنا نستابلش التيم. الحقيقه ما كناش لاكي قوي لان بدايتنا كانت مع 2020 ما هي بدايه الكورونا، فكانت اغلب الاكتيفيتي بتبقى واقفه في اوقات كتيره. فيعني استثمرت السنه دي في ان احنا نعمل البيزك لوجيستيك ارانجمنتس ونعمل الفورمات والتريننج للبيزك تيم من الادل كارديولوجي، لانه بدا الادل كارديولوجي ممبر ينضموا للتيم وهم عايزين تريننج في الكونجنتال. في سنة 21 كانت الكونديشن ماتش بيتر، وعملنا بروجريس في المالتي ديسيبلينري تيم، وبدأنا ان احنا نشتغل الانترفنشنال كاس. وفي سنة 22 بدأنا نبقى have a well established unit within the cardiology department. وطبعا مستمرين في التريننج ومستمرين في الكوبريشن مع ابو الريش. زي ما قلت لكم سنة 20 عملنا فيها بس الفورمات واللوجيستكس، وكان معانا في اول حد في المالتي ديسيبلينري تيم هم الفيزيوثيرابيست تيم، والكوبريشن كان مستمر مع ابو الريش. وانضمنا عملنا اوفيشالي تيم من السيرجيكال تيم وتيم من الاوبيجاينا ومن السايكاتريست، معانا دكتور محمد نصر الدين، وعملنا من البلمونولوجيست والبلمونري هايبرتنشن تيم. وطبعا مستمر تملي الكوبريشنز مع ابو الريش، يجوا ترين وناخد منهم سبلايز وحاجات مستمره لان كونتينيو. وعملنا في السنه دي فاند ريزنج مع بيت الذكاء ومع بيرسونال اكتيفيتي، قدرنا ان احنا نجيب بيها فاند ريزنج وكوبريشنز مع بيت الذكاء. فاستفدنا من السنه 21 كانت الاكتشوال رايز للكلينيك وللسيرفيسز. في سنه 22 بقينا خلاص ويل استابليشد يونت، عندنا ستاف راوند كل يوم 4 او every other 4 حسب الفلو بتاع الكيسز، وبدانا نعمل عدد اكبر من الانترفنشنال كاس. حالاتنا بتيجي منين؟ المين بالك بيجي لنا الحالات اللي كبرت في ابو الريش، لكن بيجي لنا ريفيرلز من حتت ثانيه، وبيجي لنا عيانين بيسمعوا عن العياده فبييجوا عايزين يتابعوا معانا في العياده لغايه لغايه امبارح وصلنا الى 198 عيان كلهم ليهم فايلنج سيستم. خلال سنة 21 آخر 21 و22 عملنا كاس انترفنشن ل8 حالات ASD، حالتين BDA، 3 BS، and عملنا واحدة حوالي 4 هيمودايناميك، وواحدة حاجة كلوجر للأزايجوس فين، حاجة كده معقدة، و3 حالات عملوا surgical intervention during the year. احنا لسه محتاجين ايه؟ طبعا this journey never ends. احنا لسه محتاجين حاجات كتير في الانفكشن كنترول، محتاجين الحقيقه بيتر ارانجمنت مع السيرجن، لان الكتالوج والشغل مع السيرجن في اللوجيستيك وايز الحقيقه بيبقى متطلب ديماندز معينه. برضو الانستيزيا بنفس الطريقه، عايزين اللوجيستيك بتاعت ان احنا نجيب السبلايز والفاند ريزنج، يعني محتاجينها تبقى more simple than that. بنتعب حقيقي عقبال ما بنجيب السبلايز بتاعتنا زي البلد كلها تقريبا. عايزين نعمل more fundraising وعايزين establish better documentation و database system بالdocumentations اللي بنبه عليه التيم بتاعنا ان لازم يعملوا proper documentations ولازم يعملوا نحاول نعمل a software database system. طبعا التريننج is continuous with training is an endless process. We are establishing a training program يبقى complete training program. وحقيقي adult congenital is a very challenging branch that needs the balance between the risk and benefit to the patient, between cooperation between the multidisciplinary teams. This is a really challenging and need a proper balance. And the journey, it's a lifelong disease. And the journey continued, and I'm very happy to be the team leader of a very wonderful team cooperation between the pediatric cardiology and adult cardiology. Inshallah, the team and the journey will continue for the sake of patient learning of our under and postgraduate student. I will leave the stage now to demonstrate by my team some cases that it's simple cases from our point of view as a congenital, but it's very interesting cases with a lot of effort done by the whole team. So please be patient and we will explain everything. Thank you so much. الأول هنبدأ بحالة فيها intervention وهيبدأ دكتور بيشوي يقدمها. والحقيقه الفضل في تشخيص الحاله دي لدكتور بيشوي هو اللي شخصها على كلينيكال وايكو كارديوجرافيك بيزس مع انها كانت بتتابع فور ا لونج تايم مع الشيست ديبارتمنت بانذر diagnosis. ف let's say what بيشوي will find. Thank you.
شكرا حضرتك دكتورة سواد. Good afternoon. It's my pleasure and honor to present this case in behalf of the other congenital heart disease team of cardiology department. I'll present this case with Dr. Ahmed Azma. This case is entitled Hiding in Plain Sight. The story begins during a shift. We received a consultation from the chest department about a young female who was diagnosed with idiopathic pulmonary hypertension based on previous investigations that were done outside our hospital. While they are doing her right heart catheterization, they failed and the patient developed seizures and hemodynamic instability. When evaluating the patient in the chest ICU, she is a 70-year-old female student with no special habits of medical importance. She was complaining of progressive shortness of breath of 3 years duration associated with exertional pre-syncopal attacks. There was no orthopnea, paroxysmal nocturnal dyspnea, no fever, no cough, no hemoptysis. Also, there was no other symptoms suggestive of other system involvement. She had negative family history and negative consanguinity. By examination, the patient was fully conscious. She had no special features. She was lying flat. Her blood pressure was 90/60 millimeter mercury, or noradrenaline infusion. They started it in the ICU of the chest. Her heart rate was tachycardic, 130 beats per minute regular. Small volume, but with intact peripheral pulsations. She was slightly tachypneic, but her saturation in the room air was 95%. She had elevated jugular venous pressure 6 centimeters in semi-sitting position with systolic collapse and prominent A waves. Chest was clean and she had low peripheral edema. By cardiac examination, the apex felt in the 5th intercostal space outside the mid-clavicular line, diffused with systolic retraction, left parasternal and pulmonary pulsations, and a thrill was felt in the 2nd and 3rd left intercostal spaces. By auscultation, normal S1, loud pulmonary component of S2, systolic ejection murmur heard maximally at the 2nd left intercostal space. Reviewing her previous investigations, the patient had a previous transthoracic echo done outside showing a dilated right-sided chamber, normal left ventricle, severe tricuspid incompetence, severe pulmonary hypertension, and otherwise no significant findings. She also had a CT pulmonary angiography showing dilated pulmonary trunk, dilated left main branch, and no evidence of pulmonary emboli suggestive idiopathic pulmonary hypertension. This was the electrocardiogram for the patient showing sinus rhythm, right axis deviation, tall peaked P wave of P pulmonale, and a tall R in V1 and V2 with signs of RV strain denoting right ventricular hypertrophy. This was her plain chest X-ray showing a mild increase in card-traffic ratio, prominent pulmonary vessels, and prominent pulmonary artery and trunks, and lung oligemia. Her routine laboratory results showed hemoglobin 13 and a normal kidney and liver functions. We performed here a transthoracic echocardiography, and here we can appreciate in the parasternal lung axis view that the left ventricular is small in size but preserved contractility. The mitral and the aortic valve show normal thickness, normal movement, with no significant disease apart from a mild to moderate aortic regurgitation. However, the right side is markedly dilated. The septum is shifted towards the left ventricle, compressing it, and the contractility of the right ventricle is impaired with estimated fraction area change 26%. She had mild tricuspid regurgitation with estimated right ventricular systolic pressure 110 millimeter mercury. This all was consistent almost to the previous finding. However, the previous echo missed to assess the pulmonary valve. And here in the parasternal short axis view, we can see that the pulmonary valve is thickened. It is not opening. In the short axis view, we can appreciate the presence of tri-leaflet and commissural fusion and the small opening in the central, and the estimated peak pressure across the pulmonary valve was 114 millimeter mercury, denoting severe valvular pulmonary stenosis. The pulmonary trunk was dilated, and the pulmonary valve annulus was 20 millimeters. So upon this data, the patient was transferred to our CCU. She was fully conscious. We did her a CT brain for the convulsions she developed. With gradual weaning of the noradrenaline, the patient on the third day was vitally stable and was transferred to the ward. And the patient then discussed in the staff round, the case was discussed in the next staff round for the possibility of balloon pulmonary valvuloplasty.
So, as Bishoy said, he could catch this patient, misdiagnosed as severe primary pulmonary hypertension. In fact, they were doing right-sided cath. Okay.
Loud.
Usually, usually it's not loud. They are not so much expert in that. It usually will be small, but sometimes it gives true, it's from the murmur, because the murmur is very loud. Sometimes of the young generation, they feel that it's the S2 is loud, S2 cannot be loud in such case, especially in this case, because the commissure is hardly opening in this. But the very loud murmur is giving a wrong estimation that the S2 is loud. I totally agree with that.
النقطة اللي الدكتور محمد الرملي بيشير إليها is extremely important. اما بيجي لي عيان العياده وعامل ايكو في حته معقوله مش لازم اعيد الايكو. امال امتى بعيد الايكو حتى لو معمول النهارده الصبح؟ if I find ان في discrepancy between my clinical findings and the echo findings. فهنا صعب قوي الحقيقه عيان pulmonary stenosis وسيفير بالطريقه دي وما عندوش الميرمر السجستيف وما عندوش في نفس الوقت a second sound, a pulmonary component which is diminished. هو في الحالات ديت عادة بيكون في wide splitting which is not fixed خلاص، وفي نفس الوقت ال pulmonary component is usually quite diminished.
هو السبليتنج is not شرط في الحالات دي، يعني مش شرط يبقى فيها سبليتنج، بس definitely هو will be diminished. والحقيقة العيان ده أكيد ما اتسمعش، لأنه لو كانت سمع
لا مش فاهم ايه تاني السكند ساوند بيكون ايه؟ السبليتنج ايه؟
مش لازم يبقى فيه سبليتنج في البالمونري ستينوسيس، بس definitely will be diminished.
لا it will be diminished، وعادة لو في severe stenosis المفروض يكون في white splitting.
عادة بس مش
ليه؟
مش
لأنه
مش
الميكانيزم بتاعه كده. بس variable لأن مفيش ASD.
variable yes.
اوكي بس مفيش، ما هو لازم بيكون وايد لو في severe stenosis. بس يعني ده انا اللي قصدي فيه this is a good opportunity ان احنا نتكلم ان clinical sense is important، ومش عيب على فكره انك ما سمعتش، مفيش مشكله يعني.
وده هياخدنا للهوم مسج بعد كده.
هو repeated the echo ده based على الميرمر اللي هو سمعه it cannot be explained بعين عندها severe او primary pulmonary hypertension ان هو يبقى ليه يبقى عندها pulmonary stenosis murmur.
دايما يعملوا حاجه برضو whenever you find حصل يعني حاجه you missed، انتوا خدتوا يعني افتكرتوا ان كان السكند ساوند عالي وبعدين اكتشفتوا انه في pulmonary stenosis، it's a good opportunity to rehear the patient. حط السماعه كمان مره عشان this is how you learn. خلاص؟ فدي اللي انا قصدي فيه. اتفضل يا احمد.
We decided that we will do balloon pulmonary valvuloplasty. We had some concerns about doing balloon this specific patient. First, when they attempted doing the right side heart cath with a Swansgang catheter, the balloon, actually this was not convulsions. The patient went into bradycardia, she was arresting in the balloon of the Swangangs. So we were intending to crossing a balloon. We had this concern in mind. What we did that we chose one of the good profile balloons, the crystal balloon. We tried to have prepared peripheral balloons in case that even the crystal didn't pass. We pass initially by peripheral to do predilation, then to allow the passage of the proper size balloon. We prepared anesthesia. We don't need to anesthetize the patient to do it, but in case that the patient went into any hemodynamic compromise, we had the anesthesia by our side. We were expecting that after doing the procedure, if we succeed to doing, we may get into pulmonary edema from the increased flow to the lung, longly deprived from this. So prepared an ICU stay with the ventilator and the CPAP. We had our equipment prepared and we went to the procedure. Thanks to that, it went fine. We see here the balloon passing upwards. The wire is parked in the distal branch of the lower left pulmonary artery. And this is the balloon inflated. It's crossing the valve. This is where the waste is gone. This was a 23 balloon, crystal balloon. The RV systolic pressure pre-dilation was 126 millimeters mercury. It came down to 68 millimeters mercury post dilation. Choice of the balloon, we didn't do much oversizing. The annulus we measured around 2.1. We get a 23 slight oversizing with a 1.1 ratio. What we don't want to get a severe regurg in this patient. We will not tolerate this. The ventricle is already impaired. If even we get some suboptimal result, it's not a big deal. We can come and do further dilation later. Actually, some people opt for step dilation in this patient, but it went fine. And this is the echo after. Continue.
The success of the procedure was also confirmed with the echocardiography finding, and here we can appreciate the comparison between the pre and post balloon pulmonary valvuloplasty, that by 2D the valve now is opening. We can see here at least two commissures was fully opened in the short axis of the pulmonary valve, and the gradient dropped from 114 to 52 millimeter mercury with the presence of grade 1 to 2 pulmonary regurgitation. This was reflected on the function of the ventricle. Here we can appreciate that the left ventricle is less compressed, the right ventricle is less dilated, and the contractility was much more improved of the right ventricle. So the post-CAS course, the patient on table, and until she was transferred to the CCU, she was vitally stable. However, 1 hour later, her saturation dropped to 80%. With by auscultation, she had crepitation here up to mid-zone in both lung fields, and this was diagnosed to be due to the pulmonary overflow after opening the pulmonary valve. So she was treated with non-invasive mechanical ventilation using CPAP mask and small dose diuretics. Fortunately, her condition improved in the second morning, and she was transferred to ward. The patient transferred home 4 days after the procedure, and she came on follow-up 10 days after the procedure with very good function capacity. She could climb to the 4th floor. So our take-home message, that valvular pulmonary stenosis is one of the commonest congenital heart defects, representing about 10% of congenital heart disease. Careful physical examination is vital, and it guides the further investigation and management. Echocardiographers should give more attention to the assessment of the pulmonary valve. A successful intervention started with understanding the disease, planning the procedure, preparing all needed equipment, and mastering the proper techniques. Knowing the possible complications after the procedure helped us in providing the rapid and appropriate management which saved the patient's life. And thank you.
الحقيقة أنا عايزة أزود على التيك هوم مسج، وهي أهم تيك هوم مسج بالنسبة لي. الكلينيكال assessment of the patient is very important، والحقيقة ودي لي something اليونج generations بيفتقدوها. تملي تلاقي النايب جاي بيجري على الإيكو بالعيان، طب سمعته، طب عملت examination، لا. فالكلينيكال examination is very important. العيانة دي definitely have a harsh systolic murmur since birth، فأكيد لو كان حد سمعها كويس كان هيسمعها. This is number one. العيانين بتوع ال congenital heart disease in general especially adults has to be dealt with in a very gentle way، لأن هم متعودين على باثوفيسيولوجي معين طول حياتهم، فلما بتيجي تعمل لهم interventions الهيمودايناميك ده بيتغير، فلازم يبقى gradually change، يعني ما تعملش aggressive intervention. أنا مش عايزة ال 140 pressure gradient دول ينزلوا للزيرو، لأن she will not be able to tolerate ده. هيحصل lung injury، ممكن يخش في pulmonary edema very aggressive. فعشان كده we have to be gentle سواء في البروسيجرز اللي بنعملها و very gentle في الاي سي يو، لان الاي سي يو is very tricky very crucial للعيانين دول سواء post cas او post operative. and thank you بشوي، thank you دكتور احمد والتيم بتاع الكاس كله.
We'll move to the next speaker.
Yes, the next speaker, our rising star, Dr. Ahmed Samir, نايب الكارديولوجي اللي معانا في التيم، وهيقدم لنا الحالة الثانية، والحالة الثانية برضو an interesting case مع بقية التيم. حقيقة في اتنين للأسف مش موجودين النهاردة معانا من التيم. دكتور أحمد أمين، وده مدرس مساعد adult cardiologist، وهو one of the pillar of the team، وهو الحقيقة ليه الفضل في تحضير الحالة الثانية. بس أحمد بنتمنى له، هو تعبان شوية، عنده severe common cold ومش قادر يجي النهاردة. ودكتور الحسين أحمد ده مدرس pediatric cardiology ومعانا برضو في التيم، وهم الثلاثة مع أحمد سمير هم اللي حضروا وجهزوا الحالة الثانية. والحسين محجوز في أبو الريش مع حالة ومع افتتاح مبنى العيادات، لأن النهاردة عندنا افتتاح المبنى الجديد في أبو الريش. تفضل يا أحمد.
السلام عليكم. Good morning my dear professor and colleague. I am Ahmed Samir, cardiovascular resident in Qasr Al Aini. Today I'm gonna present an interesting case. We call it expanding the horizon, using the usual for the unusual. He's 33-year-old male patient from Minya, a single manual worker with no special habits of medical importance, came complaining with gradual progressive shortness of breath of 2 months duration. He's a known case of congenitally corrected TGA with intact interventricular septum with dysplastic and gradually progressive systemic AV valve regurgitation. He was diagnosed accidentally at the age of 6 years, and he remained asymptomatic until 2 years ago when he started to develop gradually progressive dyspnea till being at rest. He has history of recurrent admissions with heart failure. He developed atrial flutter with high-grade AV block. He has a history of stroke with residual right side weakness. The past history was negative. The family history was negative for congenital heart disease, and he was a son of a non-consanguineous marriage. On presentation, blood pressure was 90/60, heart rate was 60 beats per minute regular, saturation was 93% on room air. There was signs of systemic congestion, congested neck veins, bilateral pitting lower limb edema, moderate ascites and mild hepatomegaly, and signs of pulmonary congestion, bilateral basal diminished air entry, bilateral basal fine inspiratory crepitations. By cardiac auscultation, there was single loud suck and hard sound, systolic murmur with maximum intensity at the apex. This is his electrocardiogram.
عفوا يا احمد، قبل ما نخش بس عشان الاودينس، الكوركتد تي جي اي هم عيانين تي جي اي، يعني الاورتا والبلمونري لفوا، بس الكوركتد الفنتركلز كمان لفت، فالدنيا فيسيولوجيكالي اتصلحت بس اناتوميكالي لسه غلط، بس فهي دي القصه. فهيبقى ستيل عندك سيستميك فنتركل اللي هو هيبقى الرايت فنتركل فيسنج السيستميك سيركيوليشن، ودي حاجه مش هو متعود عليها، فدي بتبقى المين بروبلم للعيانين دول. البروبلم الثانيه ان ممكن يبقى عندهم تندنسي للهارت بلوك. اتفضل يا احمد.
هو بيبقى ده ال ترانسبوزيشن يعني.
ال ترانسبوزيشن.
ال ترانسبوزيشن. فمشكلتنا ان الرايت فنتريكل بقى سيستميك، وكونه سيستميك هو عاده مش متعود على كده، فإت يوجوالي ات ماي فيل. هي دي المشكله.
Regarding his electrocardiogram that shows atrial flutter with high grade AV block, laboratory finding was within normal except for slightly elevated kidney function tests. Regarding the echocardiogram,
ممكن دكتور باهر بعد اذنك تساعد احمد في التعليق على الايكوكارديوجرام. دكتور باهر برضو استاذ بتياتر كارديولوجي ومعانا في التيم. اتفضل دكتور باهر.
This is a subcostal view showing abdominal situs solitus, the IVC on the right of the spine and the aorta on the left. Sorry. This picture also a subcostal view that shows a hugely or aneurysmally dilated chamber. Mostly it's a left atrium as the IVC is not connected to it. This is the four chamber view, apical four chamber view, showing a hugely or aneurysmically dilated left atrium that open in a apically displaced dysplastic valve. Seems that's a tricuspid valve into a morphological right ventricle due to heavy trabeculation. The left atrium is compressed and small in size, opening through a mitral valve into a left ventricle which is appears smooth surface.
طب if I may interrupt معلش يا احمد ومعانا دكتور باهر. هو احنا يوجوالي بنقول ان الرايت اتريوم هو اللي بيفتح فيه الانفيريور فينا كيفا. خلاص؟ وعادة الفالف it follows the ventricle. فهنا we are having an L transposition.
Yes.
فدي right ventricle هو السيستميك، وبالتالي اللي فاتح ما بين the so called left atrium و left ventricle side wise بس هو right ventricle is usually a tricuspid valve.
Yes.
فهو الفالف بيفولو الفنتريكل.
تملي بنقول ان الفالف عمره ما يمشي من غير الفنتركل بتاعه، فالتراكاسبيد فالف ماشي على مع الار في، والال في ماشي مع الميترال فالف. wherever it will go with. هنا كل الدنيا في مكانها ما عدا حاجتين، الار في راح مكان ال في، فهو كمان ترانسبوزد زي ما الجريت ارتريز لفوا هو كمان لف.
So the atria follow the situs, so we have a left-sided left atrium and the right-sided right atrium as usual, but this left atrium is connected via tricuspid valve to a morphological right ventricle placed on the left side of the chest. And we know that the ventricle is a right ventricle because it's a tricuspid valve, and it is more apical and with the trabeculation pattern of the right ventricle. That's how we do the nomenclature.
اللي بنسميها المودريتور باند، فدي كاركترستيك للرايت ventricle.
But it's not enough ان احنا diagnose CCTGA with the valvular anatomy. We have also to check the great vessels and make sure that which vessel is connected to which, because we at most cases we have a wide variability whether of the connections of the AV valves to the ventricle or the connections of the ventricle to the semilunar valves.
This video is a low thanks for Dr. Amin for capturing it. The right atrium, the left atrium open, when it's repeated I will talk about it. the left atrium open through the tricuspid valve into morphological right ventricle. Here is the left ventricle opening through a vessel that show bifurcation, so it was a pulmonary and yes very clear هنا انه هنا يبقى في bifurcation فده pulmonary. ده connected to left ventricle المورفولوجيكال left ventricle، وكان الاورطه هنا باين ان هو connected هيظهر برضه لما نفتح تاني هيبقى باين ان هو connected للمورفولوجيكال right ventricle.
Usually the echoes of these patients are tricky because maybe you can see in one view that there's a possible VSD at the tricuspid valve site, but it is not so because it's just the orientation of the ventricle that gives this impression, it's just a dropout. Same for the interatrial septum, because it's hugely dilated and you can find it in different planes, you might see that it has a dropout, but there is no actual shunt. We can also appreciate the spontaneous echo contrast because this patient has a hugely dilated atrium. He went into flutter. The usual history, natural history of the CCTGA patients is that they go into complete heart block. They have برضو an anomaly in the placement of AV node. So they go whether spontaneous or intermittent into complete heart block.
This modified apical fold chamber shows
اسكيب يا احمد بقى للي بعده عشان الفانكشن is very important assessment في العيان ده هو التارجت بتاعنا.
During the assessment of the function using the fraction area change, it was 49%. But when we did CMR, that showed that the morphological right ventricle or the systemic ventricle function, ejection function was 35%, and it was hugely dilated. QB over QS was 0.97 to exclude that there is we have an intact interventricular septum. Tricuspid valve was ebastanoid with apical displacement of the septal leaflet 11.27 millimeter per centimeter square. We did him an Holter study. The baseline rhythm was atrial flutter. Maximum heart rate was 65, minimum was 35. There was infrequent polymorphic pulmonary BVCs with 3 runs of non-sustained VTAC. Longest was 5.8 seconds. Our management course went as following. The patient was admitted, received diuretics, achieved dry weight, then ACE inhibitors and MRA was started. 6-minute walk test at the time of discharge was that the patient walked for 150 meters only. After 1 month from discharge and during a heart team discussion, we decided to optimize the medical treatment and to add ARNI and sodium glucose cotransporter 2 inhibitors for at least 3 to 6 months, then reassessment. The surgical plan was tricuspid valve replacement with high probability for the need of apical pacemaker. During his follow-up, after 6 months, the patient showed marked symptomatic improvement. He was clinically euvolemic. 6-minute walk test showed much improvement. He walked for 450 meters. Also, the fraction area changes as a value slightly improved to be 59%. His chest X-ray also, there was no bilateral effusion. This shows, but there was signs of chronic congestion, mustache sign, and Ogun side pattern of the transposition of great arteries, and we can appreciate here the dilated left atrium. The current medication was sacubitril valsartan 50 milligram twice daily, dapagliflozin 10 milligram, spironolactone 50 milligram, torsamide 10 milligram, warfarin 3.5 milligram, and piracetam due to his old stroke. Let's review some lecture talking about some related to our topic. There was a study named long-term outcome of surgically treated patients with corrected transposition of great arteries. It was a case series done on Children's Hospital in Boston on 123 patients with congenitally corrected TGA who underwent physiological repair. That shows the survival rate being 75% after 5 years, 68% after 10 years, 61% after 15 years. But what is the most important, that the risk factor associated with poor outcome was if we are going to do a tricuspid valve replacement, which is in our case, if we have preoperative right ventricular dysfunction, which also we have in our case, complete heart block after surgery, we already have it before the surgery, and Epstein-like tricuspid valve, which we also have it in our case, subvalvular pulmonary stenosis. Let's discuss the current state of ESC guidelines in management of such patients. Most of the recommendations are based on clinical experience, not clinical trials. Symptomatic patient with failing systemic right ventricle treated with diuretics, inhibitors of renin-angiotensin-aldosterone system and beta blocker. Influence in clinical outcome is remain unknown, but there is few small studies looking to the new drug sacubitril valsartan in these patients, but no recommendation can be made at this moment. Another study called long-term clinical outcome of valsartan in patients with systemic right ventricle. This is the largest study.
Ahmed, we will summarize. Just one slide.
بالراحة بس.
One slide.
أحمد احنا we have 3 minutes لأن احنا هنرجع لايف تاني.
Okay.
يعني
We finished. We almost finished.
This was the largest trial done on a conventional heart failure medication, which was valsartan on 88 patients. That showed that the valsartan did not improve survival but decreased the risk of events in symptomatic patients, events like arrhythmia, heart failure, hospitalization, and tricuspid valve surgery. Last trial I am going to talk about was sacubitril valsartan in treatment of systemic right ventricle. It's a very recent trial done in Netherlands that showed using sacubitril valsartan in such patient. It was only in 18 patients, but it showed a significant decrease in N-terminal pro-NP, in improvement in 6-minute walk test, and improving in fractional area change and global longitudinal stream. Particular changes in congenital corrected TGA that the studies based on systemic left ventricle extrapolation from it's not practical. Beta blocker usage in such patient is not recommended, not appropriate due to being at risk of heart block. There are small cohorts. All of the studies I talked about was retrospective studies. So what's the take-home message? That congenitally corrected TGA is peculiar pathological disease, natural history of systemic right ventricle failure and AV block. Current heart failure guidelines cannot be extrapolated at ease owing to structure and the hemodynamic difference between the morphological right ventricle and left ventricle. Recent small studies are holding promise in this group of patients. More wide-scale prospective trials are needed. Thank you very much.
شكرا دكتور باهر وشكرا دكتور احمد سمير على الكيس دي. والحقيقه الحاله دي كانت very challenging، والحقيقه اول مره اتعاطف مع الجراحين لما رفضوا الحاله طبعا which is a true mortality. ويعني ماذا يصلح العطار ما افسده الظهر. الار في ده is very disastrous. ايه اللي هيراحوا؟ بس الحقيقه I was very much impressed بالافكت السيمتوماتيك ريليف اللي حصل للعيان بعد الميديكال تريتمنت. العيان جه بشكل مختلف تماما. فان شاء الله sometimes كل الديسيجنز بتبقى هارد في العيانين الكومبلكس زي دول، وبيبقوا محتاجين a real challenge من multi disciplinary system. Thank you for the whole team. Thank you for the presentation. Thank you for attendance.
Thank you very much. احنا يعني شاكرين للسيشن الجميلة دي. احنا بس we are back live. يا خالد ازيك؟
دكتور هشام.
قول لي ايه الاخبار؟ what are we doing currently?
We give up to circumflex because we think it's very complex to do it this time. So we try to the LAD. Next, before please. Do you have the angio? Before, please. Before.
ممكن تعمل دروبس. اعمل دروبس. دروبس. اطلع فوق شويتين.
So we put IVAS guiding in the left main. We can show you the IVAS. It's very ambiguous cap, very calcified lesion. Here the circumflex, we advance but subintimal.
Next.
So here we put the IVAS. That's here. Can we choose IVAS? Can we switch to the IVAS? So here's the IVAS. If you can see, the IVAS in the left main, and we have in 5 to 4 o'clock, here's a LAD, so plate, back. Dr. Hisham, can you see the IVAS?
Yeah, it's clear with us.
So here, so in 5 to 6, 5 o'clock exactly, here is with, we have to puncture in this place. And these are LAD. So next, please. I try to puncture it. Very tough. We use Confianza Pro 12, cannot puncture. Next, please.
على فكرة we don't need to have severe calcification عشان تبقى الحالة tough أو يعني هنا calcification very minimal.
هنا we have all يا دكتور هشام.
عندنا إيه؟
We have a severe calcification. We have a tortuous, we have ambiguous cap, we have a long segment.
It's a very tough case I know, بس أنا قصدي calcification هنا أنت شايفها very severe?
No, it's not severe. It's but there's
في just small patches of calcification. بس الفايبروزس في حد ذاته ممكن يوقفنا بمنتهى السهولة يعني. و very long segment. It's a very difficult case الحقيقة. بس يعني أنت أهل لها يا خالد.
إن شاء الله بس يعني you give me time to. So here next please next. So next.
احنا بتهيألي احنا هندخل نتغدى ونرجع لك بعد كده.
يس واتعشى كمان.
أنا بغيظك بس يا خالد.
So here we are somewhere, but we are not sure. The wire is passed by puncturing. This is a Gaia next 3. Next. We try to see it. Where is it? Maybe we are in diagonal, but I think we are in some remus which are outside. Next please.
لو يحطوا لنا بس الصورة اللي على الشاشة مش الايفس.
انت لسه مش صور. طيب احنا عمالين نتكلم على نفسنا.
احنا دلوقتي في ال دي جاية next 3 مش كده؟
ايوه
اوكي.
هنا we puncture it, but I think we puncture it lower. Next please. We succeed to puncture, but slower. So next please. So it's not, we will result in the LAD. Next, please. So we are lower. So I went back again, and I tried to puncture a higher side.
Okay.
Next, please. Here we are totally lower. Within the, not in the septal, but this in the ramus branch. Next. Outside. Next.
وده septal perforator ده ولا ايه بقى يا خالد؟
We have the same. No, it's outside. It's not in the septal. Next. Next. And now I'm here.
نسحب واحد جديد على 5.
So I try to puncture again. Next, please. Epicodal. Here more better. If you can see here, I can see the calcium. I try to advance. So it's advancing. So we'll go to epicranial and we have a retrograde injection. Patient need just to urinal, so we have to stop to put for him a Foley catheter. So we'll have one picture for you, the epicranial, and then we'll stop just to
1 minute.
So is that a bit better? Actually, we have a very big aneurysm in the middle of the LAD. So you can go and come to us back at Hisham just because we have to stop to make a Foley catheter for the patient because he cannot urinal. He cannot pass urine. So what do you think?
انا مش سامع كويس يا خالد. انت بتقول ان في انيوريزم في الميد ال اي دي؟
Yes, the LAD has a big aneurysmal.
سؤال، هو العيان ده قبل ما ندخله اتعمل له سي تي يا احمد يا سمير؟ سي تي كرونري؟
لا والله يا فندم، هو احنا كنا اصلا planning according to the angio that he had a couple of years ago, but 4 days ago we brought him to repeat the angiography. We found that the circumflex that had subtotal occlusion progressed into true CTO, and we had the progression of the right coronary artery. But from the previous angio, because it was a bit at earlier stage of atherosclerotic cardiovascular disease, we had some impressions about the courses of the coronary total occlusion courses. And they were indeed challenging when they were still patent.
ما اعرفش يا خالد رايك ايه هنا. السي تي كرونري كان be of some help pre procedure.
He has a very heavy calcifications.
قصدي اديني some impressions about the الكالسيفيكيشن فين، الكورس ماشي ازاي، يلخ يعني.
Yes, can give you.
You're not that usually advocating قصة السي تي كرونري.
No, we do all the patient, all most of the patient we do CT coronary before. To him, if we are doubt where is the course, but here we will see only calcium, so it can give us a good information about the calcium in the left main. But IVUS can give the same result, so there is not fully calcifications. There is some amount of calcium in the ostial left main. We just put a Foley catheter for the patient. And then we'll continue. So I will try just to pass the microcatheter a little bit and de-escalate again with a
انت استخدمت الكونفيانسا ولا؟
دلوقتي جايه next 3.
Now we go for what? Confianza Pro 12 ولا؟
No, I will de-escalate again with a Gladius Mango or with a Pilot 200.
أنا مش سامعك يا خالد. You will de-escalate.
De-escalate again, yes, with some hydrophilic coating wire.
اوكي، يعني واحنا عموما يا اما بنمشي ستيب باي ستيب ابروتش وناسكاليت، يا اما احيانا حتى بالرغم ان احنا وي ار اسكاليتنج نوصل الى مرحله نقرر نو وي ونت تو دي اسكاليت. دي اسكاليت يعني ايه؟ يعني بننزل بقوه الواير اللي انا بستخدمه. ليه؟ لان انا شايف انه مثلا I need something more gentle to cross. طبعا بايلوت 200 ده جبار اخر يعني مش واير بسيط يعني، ولكن يعني ممكن بقى لو عايز يسكاليت يدخل بقى على حاجات اللي هي بقى التيب لود بتاعها 12 او 14 جرام او كلام من ده. طبعا understanding الوايرز والتايبس بتاعتها، ومش حكايه بس هيدروفيليك ولا نون هيدروفيليك، ايه البوليمر جاكيت وخلافه، والتيب لودز وايه المقصود بالتيب لود is very helpful while working مش بس CTOs، كمان different types of lesions.
ايدك ورا دماغك بقى.
ممكن نرجع ايدينا خلاص يا عم داوود، احنا عملنا كل حاجه.
خالد سؤال كده ما اعرفش رايك فيه ايه. كان في بيبر زمان نزلت على ال outcomes of cases which are life transmitted وان maybe such patients are يعني not very fortunate لان الحاله اتعملت live. Do you think that this is true ولا انا عارف طبعا that you are يعني a very experienced operator ومتعود على اللايف وكده.
I don't have the I don't hear you دكتور هشام. ممكن تقولي سؤال تاني؟
بقول ان في بيبر كانت نازله على قصه انه الكيسز that which are done live maybe يعني شويه حظهم يعني a bit lower منهم يعني they are done live ممكن الاوتكمز بتاعتهم ما تبقاش as good. ف do you think انا عارف انك you are a very يعني very experienced operator ومتعود على اللايف كتير جدا بس do you think that this is an issue ولا لا؟
I don't think so. If we are not before we have just to be pushing by the commentator and the chairperson ممكن ايده جنبه بس عشان to do something aggressive for the patient. But now because of the internet, so we have the time, we can stop whenever we see that there is some risky for the patient. So can you have a test, please?
Yes,
I have some advancing. So we give the priority for the patient, not for the life.
Okay.
I'm ready.
So whenever it's we feel the patient will be dangerous, I will stop.
Okay. انا حاسس ان احنا we are out of plane ولا بتهيألك ايه؟
No, I feel we are good.
We are feeling we are good. We have a so we can have another plane.
Zawad right.
Zawad right or left. The problem is here, as I told you, is here we need to de-escalate. So give me epicaudal, please. Epicaudal. I will try just to push the microcaster as much as I can. However, the microcaster is already gone from the huge tortuosity. So it's advanced. Give me a pilot 200. Epicranial again.
Runner.
Yes, retro.
Okay. Very good.
This looks bad. If we go to this diagonal, will be well and good. And the only no good signs, the extra stall we have.
خالد thank you very very much for the يعني your collaboration مع القصر العيني. أنا بشكرك شخصيا وباسم الاسم كله. You have been always يعني a dear friend and always very helpful. نبقى احنا we will try to stop now علشان we are coming to an end for the meeting وعشان اللايف transmission. فبنشكرك جدا يا خالد، انت نورتنا وانا متاكد ان شاء الله ان الحاله هتمشي كويس as we all wish ونبقى نسمع الاخبار منك بقى او من احمد سمير. Thank you very much.
Thank you.
I presume that the very lateral thing is circumflex.
لا مالكش على السؤال.
خلاص الكل بقى كده يجي هنا يا جماعه، هناخد صوره جماعيه.